Ladies and gentlemen, COVID-19 virus has Ladies and gentlemen, COVID-19 virus has changed this world forever. The transformation in healthcare, what I thought, especially digital transformation of healthcare, what I thought would take
Good morning, everyone. Are you all there? Dr. Siddharth Shah, sir, good morning. Dr. Bharat Shah, Dr. Hello, Krishna, Dr. Krishna, hi. And who is there? Who else is there? Dr. P.C. Manoria.
Yeah.
Manoria, sir. Good morning, Mr. Shirish.
Good morning, madam.
See, when I came, ಅವರು ಇದು ಪ್ಲೇ ಮಾಡ್ತಾ ಇದ್ರು ವಿಡಿಯೋ ದೇವಿ ಶೆಟ್ಟಿದು. There is a delay. ಅವರು ಲಿಪ್ ಮೂವ್ಮೆಂಟ್ ಗೂ ಆಡಿಯೋ ಡಿಲೇ ಬರ್ತಾ ಇತ್ತು. ಮೇ ಬಿ ಇಲ್ಲ ಅಷ್ಟೊತ್ತಿಗೆ ಅವ್ರು ಆಫ್ ಮಾಡ್ಬಿಟ್ರು. ಹ್ಯಾವ್ ದೇ ಕರೆಕ್ಟೆಡ್ ಒಂದ್ಸತಿ ನೋಡಿ, ಇನ್ನು ಟೈಮ್ ಇದೆ ಯಾಕಂದ್ರೆ ಜಸ್ಟ್ ಪ್ಲೇ
ಹರೀಶ್ ಸ್ತುತಿ ಒಂದ್ಸತಿ ಫೋನ್ ಮಾಡಿ.
Yeah, sir. I'm here. Sir, you have mute yourself.
Stuti, good morning.
Good morning, sir.
Good morning. Madam was just telling that there is a small delay in the lip movement and the voice of the video. Is it so?
Yeah, actually the video is very heavy. We'll just play once and you have a look at it.
Yeah.
Ladies and gentlemen, COVID-19 virus has changed this world forever. The transformation in healthcare, what I thought, especially digital transformation of healthcare, what I thought would take
Stuti,
Yeah.
can you convert this into VLC player?
Sorry?
This is MP4 version. Convert this into VLC and just try to play it again.
Just a moment.
Open with VLC.
Sir, good morning.
एक मिनट હું કરું છું
Dr. Siddharth Shah, sir, has joined.
Yeah.
Can you hear me?
Yes, sir. Good morning, sir.
Good morning. How are you?
Sir, how are you, sir? All set.
Yeah, all set.
Yeah. Sir, today I think it will be nice if you can welcome and start, sir.
Yeah.
Or you want us to welcome and then give it to you, whatever you suggest, sir.
Okay.
So I'll do the formal welcome and hand it over to you, sir, then.
Yes.
Okay, sir. We still have about 4-5 minutes, so.
Yeah.
Yeah.
You gave me a missed call. There is nothing, no?
Nothing, sir. I just want to tell you that I've sent you the link, but by that time आपने login कर दिया था.
कल का ही लिंक मिल गया था तो.
Same link, sir.
Yeah.
So Dr. P.C. Manoria and Dr. Bharat Shah have also joined.
Good morning, Dr. Manoria, Dr. Bharat Shah. Welcome.
Good morning, everyone.
Good morning, sir.
Probably when you upload it, probably.
Good morning, Dr. Bharat Shah.
Good
morning. Namaste, sir.
Good morning, sir.
Good morning.
Good morning, Dr. Bharat Shah.
Good morning, Dr. Siddharth.
How are you? Looking good?
Yeah, all well. Nice program.
Thank you.
Yesterday it went on very well, sir.
Yeah, it was very well attended.
Yeah.
दरवाजा आवाज आए दरवाजे बंद.
Yeah. Good morning, everyone. Hello.
Morning, sir. Good morning.
morning, sir.
Audible?
Yes,
Yeah,
sir.
you're audible, sir.
Okay. Okay. I'll just keep myself out of the video and mute it. I just.
Yeah, sir.
Sure, sir. Thank you.
Thank you.
Sir, Dr. Devi Shetty's is a recorded one. So once your introduction is over, we'll play the video, sir.
Okay.
Yeah.
Can we start now?
Yeah. Stuti, are you ready?
Yeah. It's 9 o'clock. We can start.
One
Yeah,
more minute.
Sir,
One minute.
just wait for another 2-3 minutes.
Not an issue. No problem. It will take 3-4 minutes because I'll take 1 minute. Dr. Siddharth Shah for introduction will take another 1 minute. 2-3 minutes we have on hand.
Hello.
Good morning, sir. Dr. Jagdish Channappa sir has joined. Sir, good morning. Dr. Bansal.
Good morning, ma'am. Very good morning.
Good morning.
Yes, I'm Dr. Bansode.
Good morning, sir. Good morning,
Good
sir.
morning. Good morning. Good morning.
Good morning, Dr. Bansode.
Good morning, sir.
Good morning.
Very difficulty. Yesterday I faced a lot of difficulty, but today I luckily lockdown has done.
Dr. Pathak, good morning.
Good morning. Good morning. Huh? क्या करना है?
902. Stuti, can we go live?
Yes, sir, in 30 seconds.
In 30 seconds. Okay. After my welcome, Dr. Devi Shetty's CV will go live, go up. Then Dr. Siddharth Shah will introduce, and then the video will go. Right?
Okay. Hypertension. HYPERTEN. Yes, I will. Go to mail. Gmail.
Stuti, do we go? So if there is a slight drag, let's leave it that way.
HyEcon.
1 second.
So yes, we can start.
Yes.
Pardon?
So we can start.
Can start now? Yeah. Let us know once you go live.
Good morning, Dr. Phatak, Dr.
Good morning.
Bharat.
Hi, Dr. Varsha. After a long time.
Long time, yes. How are you?
Open
All well, sir. All well, sir.
TV. Good.
Dr. Patak, good morning.
Good morning, Dr. Susi.
So we are live.
We're live? Okay. Thank you. Very good morning and a very hearty welcome to you all. At the outset, we wish to thank each and every doctor for gracefully accepting our invitation and registering yourself for the first HyEcon, that is Hypertension Expert Conclave, which happens to be the first virtual national conference of Hypertension Society of India, and is being conducted in partnership with the ICP, Indian College of Physicians, and Microknowledge Academy. As you're aware, Hypertension Society of India has been the first society in the country to bring in the concept of hypertension as a specialty, and has been very active in driving down the concept of better management of hypertension in the country. As you would agree, doctors, the current COVID pandemic has derailed the way medical fraternity was treating and interacting with patients, has thrown up a challenge for the future. The things may not turn back to 100% normalcy in the near future, and this makes it more important to adopt to the changes and the newer challenges. Keeping these factors in mind, we, with the guidance of the faculty, have come up with an amazing agenda for this conclave. We had wonderful interactive sessions and lectures yesterday, which was attended by close to 3,000 doctors from across the country. This today Hypertension Expert Conclave will bring in the best of Indian faculty, speaking on the latest and the most relevant topics to you. The better part of this conclave is that apart from excellent orations and discussions on hypertension, you will also get to hear a lot of off-track topics. Today, you will be hearing the importance of social media management for doctors and other topics. And yesterday, we had wonderful topics on artificial intelligence and disease management. I think these are the things which will make this conclave very interesting. So, we from Microlabs, myself and along with Dr. Manjula Suresh, will once again extend a warm welcome to all and assure you an academic feast. And we personally would like to thank the office bearers of Hypertension Society of India and Indian College of Physicians for giving us this great opportunity to host this show. Without wasting much of the time, I would want to hand over the session to Dr. Siddharth Shah, Executive Chairman of Hypertension Society of India, to start today's proceedings. Over to you, Dr. Siddharth Shah.
Thank you. Very warm welcome. On a Sunday breakfast day, we all welcome you to this very important meeting that started yesterday with the national and international faculty. And today also, we have a busy program, and I would request all the faculty and the chairpersons and moderators to keep to the time so that the interest of the audience will remain with the subject. I on behalf of Hypertension Society of India and Indian College of Physicians, Dean Dr. Shashank Joshi, And I would like to welcome today Dr. Bansode, who's not unable to come yesterday, but he is a pillar of Hypertension Society of India. He has uh, chosen a big path in steering the Hypertension Society of India to this stage. Not forgetting the members of the Hypertension Society of India, the organizing committee, and the executive committee of Hypertension Society of India, and the Indian College of Physicians, fellow faculty members, and all the members who are attending this important program for today. Today, I would like to welcome Padma Bhushan Dr. Devi Shetty, whose name is well known all over the country for his innovative measures for healthcare. He is the chairman of Narayan Hrudayalaya Limited. He is the chairman, Board of Governors, Indian Institute of Management, Bangalore, part of International Advisory Group invited by Japan Center for International Exchange to address the global health agenda under Japan's G20 leadership during 2019 and 20. He has a US patent number 10,109,377 registered as inventor of system and method for facilitating delivery of patient care, recipient of prestigious awards including the Padma Shri, the Padma Bhushan, the Economic and Innovation Award, Ernst & Young Entrepreneur of the Year, Nike, Asia Prize for Economic and Business Innovation, and honorary doctorates from University of Minnesota, University of Mysore, and IIT Madras. With this background, I'm sure Dr. Devi Shetty will be able to give us guidelines for healthcare delivery for the poor patients and the needy patients, for which he specializes, and would like to invite him to give today's keynote address, Changing Paradigms in Patient Care. Dr. Devi Shetty.
Ladies and gentlemen, COVID-19 virus has changed this world forever. The transformation in healthcare, what I thought, especially digital transformation of healthcare, what I thought would take at least 5 to 10 years, COVID transformed it in less than few weeks. I've been trying to promote telemedicine for the last 17 years. We started telemedicine when this world never had a internet. Nobody heard of websites and nobody heard of online consultation. But with the help of Indian Space Research Organization, we could install satellite dishes in most of the government hospitals, and sitting in this office, I treated 53,000 heart patients across the country and helped to save so many lives. But until COVID came, my action was illegal. Telemedicine consultation was illegal, in spite of our best efforts. But COVID changed everything. Today, sitting in this office, I see more patients online than patients sitting in front of me. I fondly recollect my experience of a 80-year-old lady who had a heart operation done by me about 25 years ago. Every year, religiously, she came to Bangalore to see me from Calcutta. It was as if she was preparing the whole year for this trip. It was painful for an old lady to travel, but she did it. Couple of months ago, when she saw me sitting on her bed in her bedroom in Calcutta and looking at my face in her mobile phone, she started crying. She didn't believe that it was possible for her to talk to me, interact with me, get my advice, sitting in her house. This is the beauty of technology. I strongly believe that digitizing healthcare will dramatically transform the way healthcare is delivered across the world. By removing the pen and papers from the hands of doctors, nurses, medical technicians, we will make healthcare safer for the patients. We will make healthcare affordable to the patients, and we will make healthcare accessible to the patients. Today, I am getting patients for complex surgeries from Bihar, Madhya Pradesh, parts of central India, Srinagar, UP. This was not our area of patient referral. How they land here? All they do is to see me online and get my opinion, and by few days they are here for the surgery. It is truly, truly remarkable. One would think all these digitizing tools are the tools which will again serve the haves, depriving the have-nots. But believe me, technology will give rich people what they always had in a better form. But technology will give poor people what they can never dream of having. I will give you a simple example. When I started telemedicine consultation about 4 months ago, I saw a lady who was operated by me many years ago for a routine follow-up from somewhere from Eastern India. She was talking to me from her mobile phone, but at the backdrop, I could see her house. It wasn't the house. It was a thatch roof house resting on somebody else's wall. Any serious breeze can blow the roof of the house, and I could see dogs and the kids playing around. And she paid 500 rupees to see me. I finished my consultation and I thought to myself, that 500 rupees she gave me doesn't make any difference to me. But for her and her family members, it can perhaps buy food for the next half the month, 15 days. That is the day I decided that my consultation fees for patients who see me online is going to be 50 rupees. I know in social media, a lot of people criticize, a lot of people appreciate it. I didn't care. I don't care. Essentially, time has come for anyone suffering from any disease in any part of the world. If they have a dream of seeing a doctor who they trust, who they think they need the opinion, believe me, it is possible. It may not be costing 50 rupees, it may be costing a little bit more, but it is possible to access any doctor in this world. My advice to all the doctors, all the medical students, young doctors, specialists, senior specialists of my age, if you are not tech savvy, please become tech savvy. If you do not become tech savvy, believe me, one day we all have to get together, we may have to get together and block the road like the London taxi drivers blocking the road against Uber cars. It is going to happen. We have no choice. And technology is much, much easier than what we think it is. Many years ago, I was trying to catch the last flight from Delhi to Bangalore. And my driver told me that if I travel by car, I won't be able to make it. He suggested I go by the metro to the Delhi airport. So I quickly ran downstairs and I wanted to buy a ticket. But there was no ticket counter. I looked around and in one corner, I could see one lady inside a cubicle. I ran there and put the money and I said, I want a ticket for the airport. She looked at me as if she was looking at some alien landed from the space. I again said, Madam, I want a ticket for to the airport. She just did like this, showing me one of those machines which went the ticket. I looked at it and I told her that I don't know how to use it. Then she shrugged her shoulders, said, that's it. She didn't even say it. She didn't even look at my face. And that's what will happen to all of us if we do not become tech savvy. Believe me. It will happen to us in metro station, it will happen to us in airports, it will happen to us in supermarkets. So time has come, it doesn't matter how old we are, we have to learn technology. Critical care services are going to be the largest growth segment in healthcare delivery across the world. Today, when you hear that there is a hospital with 100 beds, we all assume that 90 beds are ward and room beds and 10 beds are critical care beds. 8 to 10 years from now, the ratio will get reversed. Whatever we are doing on the patients in ward and room will be done online when patient is at home. 90% of the beds in the hospital will be critical care beds. This is going to be the reality. In that kind of a situation, how are we going to find that many intensivists, critical care experts to manage all these patients? So we started working on it for the last 3 years. Our aim is to tell the intensivist that you all work for 9 to 5 like anybody else, but after 5 o'clock, you have to cover the patient online staying at home. Patient in a critical care unit in India, US, Europe, anywhere in the world gets the best care only between 9 to 5. 16 hours in a day, a patient in the ICU gets suboptimal care, cared by junior doctors and junior nurses. If we can connect the ICUs online to the intensivist at home and split the entire 16 hours when the patient is getting the suboptimal care into 4-hour slots. Intensivist from his bedroom will cover only for 4 hours on every 3rd night or a 4th night. That they don't mind. So they take rotation. And there are fantastic cameras available which can beam the patient, the monitors and everything much better. In fact, an intensivist can see the cardiac monitor much better in a security camera than directly him standing in front of the patient. And by free flow of data from the bedside, from the machines, to the intensivist tablet at home, we can dramatically transform the way ICU is managed. We have a hospital in Cayman Island, which is very close to US. As you know, the manpower is very expensive in the first world countries. When it is 12 o'clock at night, it is 11 o'clock in the afternoon in India. When those doctors are sleepy, our doctors and nurses are nice and fresh. And this is the way critical care can be managed, and that is the way it will run. All we need to do is to get the data from the cardiac monitor, syringe pumps, ventilator directly to our phone. And this is not a rocket science. I can tell you, in my mobile phone, I have our own application developed by our team called Adi. This is Adi, and all I need to do, 11 o'clock at night before I go to sleep, I do the rounds in the ICU with this app. I can see any patient I want. I can see the patient's chart. I can see the cardiac monitor. I can see the X-rays, whatever I want. You want to see the cardiac monitor is here. You want to see the patient's X-ray? The moment the technician touches the button of the X-ray machine, in no time, I get the X-ray beaming in my mobile phone. So I do the rounds at 11 o'clock at night before I go to sleep, and by 4:30 I am up, I do the rounds again. In good old days, I used to enter the hospital at the back door, because if the patient relatives face me in the hospital lobby, they'll ask me a lot of questions about how the patient is, which I am not in a position to answer. Today, I can face any patient anywhere because I have all the data about the patient in my mobile phone. So this is the beauty of technology, how it is going to disrupt. Now, it's not just about getting the data in your phone. I strongly believe in a matter of time, in a hospital, there will be only doctors, nurses, and technicians working. Entire support staff will work from home. And they will not work for one hospital. They will work for multiple hospitals from home, at the comfort of their house. In the next 2 months, all our receptions of all our hospitals will have no receptionist. Receptionists will be at home. All the registration will happen online. And if the patient walks into the hospital, like most of the Indian patients do, receptionist sitting at home will do the registration. By doing it, we will be very efficient, because every reception of a hospital is busy only till 12 o'clock, 1 o'clock in the afternoon. At that time, you need about 100 receptionists. After 12 o'clock, you need hardly 4 or 5. And we have a unique problem, unlike in other countries. Our first patient who registers speaks only Kannada, second one speaks Bengali, third one speaks Oriya, fourth one speaks Tamil. Can you have a receptionist who knows all the languages? It's not possible. So we want to create kiosk with the title Kannada, Telugu, Tamil, whatever, and a receptionist who can speak the language sitting at home. And patient can have a chat with the receptionist, take all the details from the patient in no time. So essentially, future is never an extension of the past. It is different. How different it is going to be, it's all left to your imagination. COVID has taught us one lesson. Every extra person working in the hospital is a risk for himself and a risk for others. Risk for himself if he or she doesn't have COVID. risk for others because if he or she has COVID. So we want less number of people to work in the hospital. We have ICUs, each floor has 80, 100 beds. You can imagine the number of people working there whose only job is taking the blood sample from the bedside and getting the blood gas analysis done, or bringing a syringe or a needle or some disposable from the store. You have hundreds of them working in the hospital. Do you really need that many people? So we collaborated with a company called Asimo Robotics from Kerala, and they have developed a very, very smart robot which can collect the blood sample from the nurse, go to the blood gas machine, and a technician will do the blood gases, and through the Wi-Fi, the blood gas report will come. Nurse wants to get a bag of blood from the blood bank, robot will bring it for her. And all this can be developed in India. And these are not robots which we cannot afford. So essentially, time has come for us to reimagine healthcare. And to reimagine healthcare, we have all the tools in our own backyard. We have to open our eyes and make it happen. And all this transformation will never happen unless doctors like you and me take the initiative. And this is my advice to all of you, and thank you very much for your patient listening. Thank you. Good luck and God bless.
So thank you very much. It was really a wonderful and brilliant talk by Dr. Devi Shetty, as always. And Dr. Siddharsha, thank you so much for moderating.
Thank you, Dr. Manjula. 2 words.
Yes,
I
sir,
must
please.
really appreciate the work done by Shirish and you, Dr. Manjula, for making this program as we see today. And especially the wholehearted support of Micro Labs will never be forgotten. Thank you.
Pleasure, sir. It was all under your guidelines, and thank you so much. And with a very nice beginning, sir, can I move to the next session, sir? Dr. Shah,
Yes, please. Yes, please.
So we move to the next session of today. We are having 2 sessions in this. The first session is a newer approach to management of CKD and hypertension. So we all know that CKD and hypertension are closely associated with an overlapping and intermingled cause and effect relationship. Decline in kidney function are typically associated with rise in blood pressure, and sustained elevation of BP hastens the progression of kidney function decline. And in some form of CKD, hypertension may be the earlier sign of renal dysfunction, and appropriate hypertension management reduces both cardiovascular and the renal outcomes. So today's session will provide us newer approaches to the management, including the recent advances in CKD and hypertension management. We have eminent nephrologist, Dr. Bharat Shah, is with us doing the honors. And the second session is managing a cardiac emergency during COVID. As mentioned by Dr. Devi Shetty just a few minutes ago, a significant challenge for healthcare system during ongoing pandemic is not only the treatment of COVID-19 patients and limitation of spread of infection, but also to provide proper care to all the other patients. The latter is difficult due to the necessity of redistributing the resources, limiting access to medical care, and patients' fear of becoming infected, as a result of which there is delay in seeking medical help and avoiding contact medical services despite intensifying symptoms. So the crucial issue is to provide the optimal management, at the same time effectively protect the personnel and other patients against infection of SARS-CoV-2. So therefore, the aim of this session is to provide comprehensive and up-to-date knowledge on how to provide safe and efficient help in cardiac emergencies during COVID-19 pandemic. So we have distinguished speaker, Dr. Samir Srivatsav, doing the honors of taking the session here. So to conduct this session, we have our distinguished chairpersons to do the honor. The first chairperson is the distinguished cardiologist from Kolkata, Dr. Soumitra Kumar. Doctor is the professor and HOD of cardiology at Vivekananda Institute of Medical Sciences, Kolkata. He's the president, Indian Academy of Echocardiography, president, West Bengal Academy of Echocardiography. He has more than 152 publications in both national and the international journals. He has edited several books, to name a few, joint editor of a book on echocardiography in clinical practice and a book on acute coronary syndrome, along with Dr. C.P. Cannon, recently published a treatise titled this. And he also associated editor of non-specific aortoarteritis, a monogram 2 edition, and CSI textbook of cardiology in Indian perspective, first edition 2018. So Dr. Soumitra Kumar, most welcome to you, sir. Thank you for having you. Our next chairperson is Dr. R.B. Pathak, an eminent consultant physician and a diabetologist affiliated to Raheja Fortis Hospital, Jaslok Hospital, and Saifi Hospital and Motibai Delvi Hospital, Mumbai. He has completed his MBBS MD from Seth GS Medical College, the prestigious KIM Hospital, Mumbai. He has published several papers in Indian and abroad and indexed in the national index journals and international index journal. And he is also a member of several prestigious professional associations. He is in the private practice for more than 30 years. He comes with a rich clinical experience, and his practice is restricted to type 2 diabetes and its associated complication. So Dr. R.B. Pathak, sir, once again, welcome to you, and it's a pleasure to have you here. May I now request Chairperson Dr. Soumitra Kumar and Dr. R.B. Patnaik to take over the session and conduct the proceeding. Over to you, sir.
Thank you, Dr. Manjula. It's a great pleasure to be in this august audience. I sincerely thank Dr. Siddharth Shah and Dr. Manjula, Shirish Samak and Murthy from Microlabs for giving me an opportunity to get associated with this prestigious conference. I will now be introducing Dr. Bharat Shah, and Dr. Bharat Shah is an eminent personality in the field of nephrology in Mumbai, city of Mumbai. He is director, Institute of Renal Sciences, Global Hospital, Mumbai. He is a consultant nephrologist at Reliance Foundation Hospital, honorary consultant nephrologist at the Lokmanya Tilak Municipal Medical College, Sion. He is a managing trustee of Narmada Kidney Foundation. He is nominated in Specialist Board Nephrology by the National Board of Examinations, Delhi. He is president of the Indian Society of Nephrology, West Zone. He is secretary of ZTCC, Mumbai. He has 89 national publications and 17 international publications. He is recipient of many awards. To name a few, he has Khuller Oration to his credit at the annual meeting of Indian Society of Nephrology, J.M. Patel Oration at the National Annual Conference of Indian Society of Organ Transplant in 2016, Dronacharya Award at the Avatar in 2018, and Dr. V.N. Acharya Oration at the annual meeting of Indian Society of Nephrology. Over to Dr. Bharat Shah. Welcome, sir.
Thank you, Dr. Pathak. Now let me share my screen. So after that wonderful talk by Dr. Devi Shetty, let's come to the problem that we see very commonly in our clinical practice. And while the topic is newer approaches to management of CKD and hypertension, I'm going to confine myself more to talk about hypertension in chronic kidney disease, because chronic kidney disease management is a big subject by itself. And there are not many new things in management of CKD and hypertension. Therefore, my talk will be about management of hypertension in chronic kidney disease. So what I plan to do is tell you about association between chronic kidney disease and hypertension. I will then talk about management of hypertension in patients with chronic kidney disease, and then I'll tell you briefly about the newer approaches in management. What is the association between chronic kidney disease and hypertension? We all know that hypertension is common and it affects about 30% of the general adult population, but it affects 90% of those with chronic kidney disease. So it's almost synonymous with chronic kidney disease. It can be a cause of chronic kidney disease, but more often it is a complication of chronic kidney disease and an important factor contributing to the progression of chronic kidney disease. In practice, I do not see many cases where hypertension was the first thing to start, and then over a period of time, they went on to develop chronic kidney disease. What I find in clinical practice more often is that they present to me with chronic kidney disease and they have with it hypertension as a complication. As kidney function declines, the incidence and severity of hypertension increases. Additionally, hypertension and chronic kidney disease are both independent risk factors for cardiovascular disease. Lowering blood pressure can slow the decline in kidney function, delay the progression to end-stage kidney disease, and reduce the incidence of cardiovascular disease. Let me give you an example to show what a great role kidney has to play in causing hypertension. So this was a 32-year-old female with end-stage kidney disease on maintenance hemodialysis. She was very well dialyzed 4 times a week. And you know that in patients with end-stage kidney disease, volume is an important component in causing hypertension. So she was being dialyzed 4 times a week. Her target dry weight was maintained, and she was on no medication that would raise her blood pressure. And still her blood pressure used to remain 170 by 100 millimeters of mercury. And see the medication that she was on. She was on an angiotensin receptor blocker, she was on ACE inhibitor, she was on loop diuretic, she was on a calcium channel blocker, beta blocker, centrally acting alpha agonist, she was on prazosin, and she was on minoxidil. And despite that, her blood pressure used to remain 170 by 100. She underwent a living related donor kidney transplant. Mother was the donor. This was in 2015. She had excellent renal function. And within 3 months of transplant, her blood pressure was 120 by 80 on metoprolol 25 milligram once a day. And even today, with good kidney function, she maintains such excellent blood pressure control. Well, the other side of the story is also true that hypertension can be a cause in development of end-stage kidney disease, and it correlates with the severity of hypertension. Greater the hypertension, the greater the risk of developing end-stage kidney disease. But I would once more like to reiterate that hypertension as a cause of chronic kidney disease is much less. In my practice, it is much less. It is by and large chronic kidney disease, which is a cause of hypertension. And therefore, I tell everyone that any patient presenting with hypertension must be evaluated for kidney disease. We now go to the next part of my talk, management of hypertension in chronic kidney disease. So what remains true of hypertension in general remains true of patients with chronic kidney disease also. So lifestyle changes are extremely important even in management of hypertension in chronic kidney disease. Weight control, if one is overweight or obese, you all know that 40% of our patients with chronic kidney disease are diabetic, by and large type 2 diabetic, overweight and obese. And weight control will help not only the diabetes, but also the blood pressure control. We all know about the important role of salt restriction in management of hypertension in general, but that is even more important. This is even more important in patients with kidney disease who tend to retain salt and have a state of volume overload. Exercise remains important for all. Reduce consumption of caffeine-rich products. reduce intake of alcohol, and extremely important is to stop smoking. Smoking not only increases the cardiovascular risk, but also increases the renal risk. And if these factors, if the lifestyle change fails to achieve a control in blood pressure, then obviously one should resort to pharmacotherapy, because a good control of blood pressure has an important role in retarding the progression of chronic kidney disease. So when it comes to pharmacotherapy, there are three important factors that we need to take into consideration. One is an accurate measurement of blood pressure. The other is the choice of a number of drugs that we have available to us for control of blood pressure and achieving a goal blood pressure. How does one accurately measure the blood pressure? By and large, I don't think it is practical to go by what the books say, that you make the patient sit down in a silent room for 5 minutes, have 2 readings. I don't think most of the centers in the world are practicing what is suggested to us. In most cases, the treatment of hypertension is based on clinic or office blood pressure reading, which is not enough. It is like managing blood sugar on the basis of one reading you have in 1 month, 2 months, or 3 months. That's not correct. The most important is monitoring the blood pressure during the day. 24-hour ambulatory blood pressure monitoring provides a more accurate depiction of blood pressure. It also allows assessment of diurnal variation in blood pressure. But frequent ambulatory blood pressure monitoring is not practical. How frequently can you put someone on ABPM? It's not possible. Home blood pressure monitoring is an alternative strategy, and it is less resource intensive and much more practical. Today you get digital blood pressure instrument for 1,500 or 2,000 rupees. It is not difficult to monitor the blood pressure 3 times or 4 times in a day. You come to know about the diurnal variation in blood pressure, and that can help you adjust your blood pressure medicines. So home blood pressure monitoring is very practical and should be applied, particularly in cases where blood pressure is difficult to manage. Now let me come to choice of drugs. Since we are talking about hypertension in patients with chronic kidney disease, we should be looking at drugs which not only control the blood pressure, but which would slow down the rate at which the kidney function declines. And what happens in patients with chronic kidney disease? There are adaptive changes that take place in the surviving nephrons. Now let me tell you what I mean by adaptive changes. If in your office there are 10 people working and 5 people leave the job, the remaining 5 people have to work hard to make sure that the work gets done. In the same way, let us say 75% of the kidney is permanently damaged. Now 25% nephrons are remaining. They will work more. If your normal glomerular filtration rate is 100 ml per minute, if 75% of kidney is damaged, your glomerular filtration rate will not be 25 ml per minute. It will be 50 ml per minute, because each surviving nephron works more. And how does that happen? At the afferent arteriolar level, there is a vasodilatation. So there is more glomerular blood flow, while at efferent arteriolar level, there is vasoconstriction. So this combination of increased glomerular blood flow, efferent arteriolar vasoconstriction increases the glomerular capillary pressure, and each nephron increases the filtration. There is an increase in single nephron glomerular filtration rate. And this is the fact which maintains the glomerular filtration rate higher despite subsequent reduction in the number of surviving nephrons. Having understood this, we should use drugs that reduce blood pressure as well as glomerular hypertension. Because what may be sounding good in the beginning, glomerular hyperfiltration, is itself responsible for progressive decline in kidney function over a period of time. Besides the underlying cause of kidney disease, these adaptive changes themselves are responsible. So if in your office there are 10 people, now 5 people are working. But if they continue to work very hard for long, they themselves may fall sick. Something similar happens over here. So you want to reduce the workload on the kidney, and you want to reduce the glomerular hyperfiltration. And this is what can be achieved by ACE inhibitors and angiotensin receptor blockers, which will reduce the efferent arteriolar vasoconstriction and reduce the glomerular capillary pressure. So your first choice should be use of an ACE inhibitor or an angiotensin receptor blocker. If these drugs are not tolerated, then your next choice will be calcium channel blockers, particularly those which block not only the L-type calcium channels, which is the first calcium channel blocker which came nifedipine and amlodipine, but N and T calcium channel blockers like cilnidipine and vanidipine offer an advantage of reducing the glomerular capillary pressure. So, as far as CKD and hypertension is concerned, as I said, your first choice will be ACE inhibitors and angiotensin receptor blockers. This would be even more important in cases where you have proteinuria. When your urine protein to creatinine ratio is more than 1, it's very cumbersome to ask someone to do 24-hour urine protein all the time. So in practice, in a spot urine sample, estimating protein and creatinine is good enough. If your urine protein to creatinine ratio is more than 1, then again, use of ACE inhibitors and angiotensin receptor blockers is preferred. If your urine protein to creatinine ratio is less than 1, then you may use calcium channel blockers or other antihypertensive agents. When you introduce ACE inhibitors or angiotensin receptor blockers, monitor creatinine and potassium and ask them to repeat within a week of introducing. If there is more than 25% rise in creatinine, then you would want to stop it. But if it is less than that, you might want to observe, and I'll explain to you at the later part of my talk. If proteinuria is less, creatinine is stable, but potassium is a problem, continue these drugs and use loop diuretic. They will not only help in reducing the volume overload, but they'll also take care of hyperkalemia. And in my experience, chronic kidney disease subjects tolerate higher potassium up to 6 milliequivalents per liter much better, because it is not the extracellular potassium concentration, it is a ratio of intracellular to extracellular potassium which makes an impact on the heart. And since the total body potassium is increased in CKD, it is fine if the potassium is little higher in patients with chronic kidney disease. So choice of drugs. The first step would be ACE inhibitor or angiotensin receptor blocker. If not tolerated, a calcium channel blocker. If the blood pressure is not controlled, you will use ACE inhibitors or angiotensin receptor or calcium channel blocker and add a diuretic. Diuretic is an important part in control of blood pressure in CKD subjects. If the blood pressure is still not well controlled, ACE inhibitor or angiotensin receptor blocker, calcium channel blocker plus a diuretic. And if it is still not controlled, then you will add an alpha blocker or a beta blocker. One important point to remember, and that's true for all cases of hypertension, is adjust the timing of medication in such a way that you can achieve an improvement in nocturnal dipping of blood pressure. It has been found that nocturnal dipping of blood pressure, which is a normal diurnal phenomena, is lost in patients with chronic kidney disease, and that becomes an additional factor increasing the risk of cardiovascular disease. The aim should be to achieve a blood pressure of 130 to 140 systolic by 80 to 90. In those with proteinuric kidney disease, a slightly lower blood pressure is desirable. And in elderly men, don't go for an aggressive blood pressure control. Go for a blood pressure of 140 by 90. But there is no consensus. Appropriate blood pressure target for patients with chronic kidney disease remains a subject of debate. Overall, individualized blood pressure targets should be set only after weighing potential risk and benefits of blood pressure control. If one is not comfortable with a very rigid control, one should allow, because after all, it's important to have a good quality of life, and you don't want a postural fall and patient having a fall in the bathroom. Now we come to the newer approaches. There are not many newer approaches. Of course, one your approach is to use the digital technology. We had a wonderful talk from Dr. Devi Shetty for achieving a good blood pressure control. I use this. I ask my patients to maintain and send me the readings. It's very useful in adjusting your medicines. But all of us are recently reading more and more and hearing more and more about sodium glucose co-transporter 2 inhibitors. These drugs have proved to be a great asset in management of patients with type 2 diabetes, diabetes with kidney disease, diabetes with cardiovascular disease, and these drugs have proved to be useful even in lowering the blood pressure. How do they lower? The SGLT2 inhibitors, while they cause glucose diuresis, while people lose glucose, they also induce osmotic diuresis and natriuresis. So your volume part is managed, which is important, as I said, in chronic kidney disease. And another thing, what we saw with ACE inhibitors and angiotensin receptor blockers, a similar thing happens, that by a tubuloglomerular feedback mechanism, the afferent arteriole, which is vasodilated in patients with diabetes and chronic kidney disease, by giving SGLT2 inhibitors and providing more delivery of sodium to the distal tubule, you achieve a narrowing of the afferent arteriole, you reduce glomerular blood flow and glomerular capillary pressure, and that helps in retarding the progression of chronic kidney disease, while at the same time you achieve an improvement in blood pressure control. There was a recent article this month itself about dapagliflozin in patients with chronic kidney disease. And before this, there was an article about canagliflozin, but that was restricted to patients with diabetes and chronic kidney disease, whereas this study included 4,304 participants with estimated glomerular filtration rate of 25 to 75 ml per minute and with proteinuria, who were put on dapagliflozin 10 milligram once a day. But the most important part of the study is that they included not only diabetics with chronic kidney disease, but 1/3 of the subjects were non-diabetic chronic kidney disease. And they found a significant beneficial effect, not only in achieving a blood pressure control, but in retarding the progression of chronic kidney disease, improving the renal outcomes and improving the cardiovascular outcomes. So this is what happens. When you give a drug like SGLT2 inhibitor or an ACE inhibitor, or when you restrict dietary protein in patients with chronic kidney disease, there will be an initial rapid drop in glomerular filtration rate. And why does this happen? Because I explained to you that there is an afferent arteriolar constriction, reduction in glomerular capillary pressure, reduced filtration. But this reduced glomerular capillary pressure and hyperfiltration, which causes an initial rapid reduction in GFR, is very beneficial in the long run.
Dr. Bharat Shah?
I have 1 minute.
Yeah.
So if you have a constant rate of decline in kidney function, otherwise with SGLT2 inhibitor, you have a slowing down of the rate of decline in kidney function. And the same thing was observed. There was a 30% reduction in death from cardiovascular causes or from any other cause. So let me summarize. While hypertension can be a cause of chronic kidney disease, more often it is a complication of CKD and an important factor contributing to progression of chronic kidney disease. In management of chronic kidney disease and hypertension, lifestyle changes are as important. Home monitoring is very important. The first choice of drug is ACE inhibitor or angiotensin receptor blocker, because they not only reduce blood pressure, but they reduce glomerular hypertension and they reduce proteinuria, an important prognostic marker in chronic kidney disease. And SGLT2 inhibitors are a new class of drugs to be considered in management of chronic kidney disease with hypertension. I would like to thank the organizers for giving me this opportunity, and I would be happy to answer the questions at the end of the session.
So thank you, Dr. Bharat Shah, for your very erudite and exhaustive presentation on the subject of CKD and hypertension. We'll take the question answers at the end, as you said. Now it is my pleasure to introduce my good friend, Dr. Samir Srivastava. He is a senior consultant cardiologist at the Fortis Escorts Heart Institute, New Delhi. He heads the non-invasive department of cardiology there and also heads the research department. He has been working as a clinician and academician for more than 25 years with more than 100 publications to his credit in various journals and textbooks. He has received the Chairman's Appreciation Award, IMA Academy of Medical Specialties Fellow of the Indian Academy of Echocardiography. He is my colleague there, and he's been a past president of the Academy also. And he's a receiver of Distinguished Service Award and Outstanding Contribution in the field of cardiology in 2019. So a noted academician, erudite orator, known all over the country. He's going to speak on a topic that is currently very relevant. His topic reads Managing Cardiac Emergencies During COVID. And I am sure that we are going to be enriched by his always thoughtful insights into various problems. So as usual, I am sure he is going to give us some new thoughts and insights into the problem and also enrich us by his experience. So over to Dr. Sami.
Thank you very much, Dada. Whenever you are introducing me, somehow or the other, my wife disappears from the room. And I wish that the good things which you told about me are all true and they get conveyed to my wife. Anyway, thank you for the kind words, Dada, and thank you, Shreesh, for giving me this opportunity to be sharing whatever little I understand of COVID. As is true for the rest of the world, I don't think science knows too much about it. But whatever little science knows, let me put it across here. Just in case I'm not able, okay, so I should be able to show my slides. Are my slides visible, Dada?
Yes, yes. Yes, carry on.
So, good morning to you all, and thank you to Microlab, Shreesh in particular. These are the contents of the details. I'll just rush through them. Otherwise, I know that we are a little behind time. So global case fatalities rates attributed to coronary artery disease have been plus 10% regardless of where they are. Recent case reports of COVID patients, 16.7% developed arrhythmias, 7.2% experience acute cardiac injury, apart from other COVID-related complications. No reports on prevalence of cardiac complications in CAD naive versus cardiac comorbidities, and autopsies of COVID patients revealed infiltration of myocardium by interstitial mononuclear inflammatory cells. That means there is a lot of involvement of the inflammatory processes in the myocardium. It is associated with the increase of cardiomyopathy, as is very evident in case there is any myocardial damage. The myocardial biomarkers obviously would have gone up, which they did. So in a study by Shai et al. Involving 416 patients, cardiac injury was a common finding in 19.7%, not necessarily myocardial infarction, so to say, like the way we understand to be type 1 myocardial infarction. And coronary artery disease, heart failure, and cardiovascular disease, cerebrovascular disease were 10.6%, 4.1%, and 5.3% respectively. So this is how it complicates the cardiovascular system. Whenever there is an infiltration with the COVID, there is a direct viral invasion. And second is post-viral invasion, there is a cytokine storm. All of us understand that. What happens with viral invasion is that there is one element which is directly hurtful to the myocardium, and there is yet another component which is hurtful to the arteries. But by and large, what both of them do is, whether it is direct involvement of the myocardium or whether it is via the coronary arteries, that vascular inflammation occurs, that there is a myocardial injury, which can eventually lead to arrhythmias in myocardial infarction and heart failure, cardiogenic shock, and eventually death. When it comes to cytokine storm, then it is basically the inflammatory process, which is leading to plaque ruptures, instability of the plaque, again, ending up with myocardial injury or myocardial infarction. There is yet another pathway which the cytokine storm can take and does take more often than not, is procoagulant state. This procoagulant state leads to thrombosis, including pulmonary embolism. And that's the reason why this debate has started on the WhatsApp, that whether it is bacteria or whether it is thrombus alone. But now, whatever little we understand of this disease process, there is a lot of thrombosis, and that is how it gets picked up in as a pneumonia or a pulmonary artery embolus in the CT scan. And that's the reason why it is called, CT scanners have a better pickup rate than the RT-PCR. Sympathetic overactivation is a combination of infection, inflammation, whatever, but what it does is that it alters the myocardial demand supply, and it leads to that mismatch, leading to heart failure, cardiogenic shock. There is yet another third process which cytokine storm happens, which is the respiratory distress syndrome, whether it is because of immunological issues, whether it is because of inflammatory issues, that we are not going into the discussion, but certainly it leads to hypoxia, which can lead to, again, excessive thrombosis and pulmonary embolism, or myocardial supply demand mismatch. So the mechanisms, I'll just summarize in this slide that there are mechanisms of cardiac injury is that there is a direct toxicity through the viral invasion of cardiac myocytes, that is myocarditis. Then there is ACE2 receptor mediated cardiovascular injury, which is hurtful to the cardiac muscle and the endothelium both. Microvascular dysfunction and thrombosis, cytokine release storm, mainly IL-6, which is inflammatory marker, stress cardiomyopathy, and it manifests something like the conventional Takotsubo's that we understand. And this can lead to imbalance of myocardial supply and demand. Cytokine storm, many severe COVID-19 reactions can be traced to severe immunological reactions known as cytokine release syndrome or cytokine storm. The rapid release can be catastrophic, leading to multiple organ failure. Many severe cases of COVID-19 with multitude of complications are directly related to cytokine storm. Cytokine storm in ICU patients causes tachycardia, tachypnea, diaphoresis, and elevated D-dimers. Now, depending upon which way they are going, then the choice of medication will come. If the D-dimers are high, you would expectedly put the patient on anticoagulants, whether it is the heparin types or low molecular weight heparin, or whether it is the newer oral anticoagulants. Those choices keep on changing depending upon which is the parameter which is predominantly worse off, though several times all of them would be worse. Many patients progress to renal failure with about 30% requiring renal replacement therapy. Now, there is yet another issue, and that is that of venous thromboembolism. Now, respiratory failure in COVID-19 is driven by both acute respiratory distress syndrome and microvascular thrombotic processes. And there is a strong association of D-dimer levels, disease progression, and chest CT features suggestive of venous thromboembolism. Various studies have demonstrated a very strong association between the D-dimer levels and severity of disease or poor prognosis. Here are an examples of a 68-year-old man. If you keep looking at these arrows here, you will find that there is basically acute pulmonary embolism with pneumonias, which can be detected by CT scanners. And that's the reason why one of the major investigative imaging tool is currently, you can see it here that branches of the pulmonary artery are getting involved in several places. There is basal pneumonias. So these are all things which can be picked up by CT scanner. Unfortunately, we are in an era where CT scan, at least in the urban population, is very freely available. Now, recently as June 1st, the US FDA has issued an emergency use authorization allowing the Abiomed Impala. Impala is a catheter-based heart pump, which is a very small pump which you can insert percutaneously, and this is actually basically to buy time and stabilize the patient, though it is only a temporary thing or not even semi-permanent, but it is temporary implantation, which all of us used to use very extensively in high-risk angioplasties, in high-risk procedures on the left side, but this time it is for the first time for the right side. that they have allowed it respond to be used in patients with pulmonary embolism and right heart failure. So what it does is it picks up the blood and distally it ejects out through a pigtail catheter, and so the at least perfusion in the kidney continues. Now, these are certain drugs with associated complications. Every now and then the drug would erupt and then they would find the reasons not to give it. And the first few hours, the chloroquine derivatives, hydroxychloroquine, chloroquine, and azithromycin, though that is a macrolide antibiotic, but they can all cause short interval prolongation. So one of the reasons we prefer not to give it in cardiac patients, especially with interval prolongation of these. So several cardiological societies and FDA warned against the use of these drugs as they can cause arrhythmias, complications, and possible death. Bradycardia was more common in critically ill COVID patients who received a combination of antiretroviral medications, lopinavir and ritonavir. These are basically used for HIV and AIDS and their protease inhibitors. They have their own issues because drug-drug interaction with lopinavir and ritonavir are enormous. So the risk of bradycardia was more common in elderly, especially beyond the age of 62 years. And it could be a sign of severe cardiological and neurological impairment since it is associated with lymphopenia. When it comes to stroke, whether it is ischemic or hemorrhagic stroke, a study which was from Italy showed that 15% had acute neurological symptoms requiring neuroimaging, and the most common neurological symptoms were altered mental status, which was in 59%, and ischemic strokes, which were close to about 31%. So ischemic strokes were higher than the hemorrhagic strokes. Both ischemic and hemorrhagic stroke are associated with COVID infection, as is true with any infection. So let me just clarify one thing to all of us, including that COVID is no special when it comes to complications. It is special because of its infectivity, it is because of severity, it can kill a lot of patients. But when it comes to complications like all viral infections or like any bacterial infections, the complications can exist, though the percentage may be varying somewhere. So both ischemic and hemorrhagic stroke are associated with COVID infection and carry a high risk mortality. ACE2 receptor circulating cytokines and hypercoagulability are integral in the pathogenesis of stroke in COVID-19 patients. Treating physicians should have a low threshold for suspected stroke in COVID-19 patients. Close observation should be kept in such patients, particularly those with clinical evidence of traditional risk markers. So this is a very busy slide, but the sum and substance is that first is that during and post-COVID pandemic, you should have the awareness about how to do. Then there is avoidance, and then there is action, which right from the lockdown till what Amitabh Bachchan has started saying is all that has to be done. And assume as a physician that everybody is COVID positive, even in absence of typical symptoms. Once having said that, then you can continue to minimize the number of providers encountering any patient, avoid close contacts if possible. Personal protection equipment, whenever necessary, should be given. There is consult for admission with suspected or confirmed. So all suspected patients should be taken as confirmed COVID until unless proved otherwise. If there is any ambiguity, just continue to maintain precautions like the way you would do it for absolutely positive COVID patients. Now, these are certain broad guidelines that in case there is somebody who is suspected or this thing, preferably have virtual visits, preferably don't have personal encounters unless it is absolutely necessary. And if it is absolutely necessary, then all of us who are looking after the patient should be in PPEs, which includes N95 masks, gloves, gowns, eye protection with appropriate techniques of donning and doffing to be taught, avoid close contacts, and N95 recycling as per institution policy, though that is not a thing which is easy to do. Now, for confirmed cases, and follow-up should be there in about a couple of weeks. And if in-person visit is needed, then delay it for about 4 to 6 weeks and inform clinic staff in advance if it is in less than 4 to 6 weeks so that they can take adequate precautions. Biomarkers, the increased cardiomyocyte injury quantified by troponins, whether T or I. Advantage of I is a little better for patients with CKD, and rest is all hardly difference between T or I. So cardiomyocyte injury quantified by cardiac troponin concentration and hemodynamic stress, and quantified by B type natriuretic peptide or NT-dope BNP concentration for disease severity and mortality. D-dimers quantify activated coagulation and is a prominent feature in COVID-19. Mildly elevated cardiac props or BNPs are in general the result of pre-existing cardiac disease and or acute stress injury related to COVID-19. Though measuring cardiac troponins is needed only if the diagnosis of type 1 myocardial infarction is being considered in patients with COVID-19. And just to revise type 1 myocardial infarction, that is conventionally, very conventional because of the atherosclerotic lesions underlying. Now coming to the diagnostic recommendations for patients without any significant cardiovascular symptom and low-level troponins. In the absence of hemodynamic instability, LV function is not recommended. Close contact, so whether it is ultrasound or whether it is echocardiography, unless absolutely indicated, you should try to avoid it. And if at all you need to do it with the proper PPE. And of course, you have to take care of the machine also. So your machine has to be also sheathed and well covered with transparent sheet, which needs to be sanitized the moment that the machine is out from that COVID area. Like the way you don and off yourself, similarly the machine has to be done and off, or you leave it there in the COVID area. So for patients with hemodynamic or electrical instability, more than mild troponin elevation or heart failure, further cardiovascular testing, including bedside echo or focus, should be considered like the way I have told. And if the patient with suspected or confirmed COVID has any specific cardiovascular symptom, ECG abnormality, arrhythmia, heart block, and elevated drops, then coronary artery disease or myocarditis should be suspected. So this is a broad algorithm for triaging patients with suspected acute cardiovascular disease. So there is an ER axis. Check the list of probability of COVID infection, and the probability of COVID infection is if the fever is more than 37.5, respiratory symptoms, previous contact with COVID patient, or there is a family history of COVID infection. If there is no COVID, then you have to follow the standard protocol. If there is a COVID infection which is positive, then look whether there is a cardiovascular condition needing hospitalization. It totally depends upon vital signs of stability, and till such time it is considered that, or proven, then they have to be in a suspected area. Or if the unstable condition is there, then first care and then screen in the emergency department. So you have to be very cautious in case there is anything instability. You don't leave the patient unattended, but you keep yourself protected. Number 2 is that if there is a cardiovascular condition not requiring hospitalization, then you discharge, sent home for quarantine, consider for outpatient management. Here is consideration for patients with suspected cardiogenic shock and COVID infection. This is a little bit of a tricky situation where you have to be always on the guards, you have to wear PPE, and if shock is confirmed, then treat as proper monitoring for differential diagnosis with or without sepsis. However, if it is not, then confirm COVID diagnosis first, and then you take care of things very aggressively. And whenever there is a risk of or suspicion of cardiogenic shock, then myocarditis should be always a possibility, because one of the recent studies which has been taken off showed that almost 78% people had some kind of, this is data from Germany, which for some reason had to be taken off because of whatever overeating and suspicion, not to cause panic. So not only that, you must consider sepsis also as a possibility of having etiology. Now, this is the algorithm of managing cardiogenic shock in patients with suspected or confirmed. So first is you have to have troponins done, BNP done. If there is a possibility, then you can do a superior vena cava oxygen, central oxygen saturations done if it is less than 60, or mixed oxygen saturation from pulmonary veins, which is again 35 millimeters or less. Depressed LV or RV functions, rule out acute coronary artery syndrome. Then consider PA. Whenever you are doing a PA catheterization or intubation, you have to be in proper PPEs with a shield and double mask or whatever is the protocol you are having in your own hospital. Then the bias is that even in a cardiogenic shock, the conservative management is preferred. And you consider this mechanical circulatory support only when the patient is refractory to medical therapy, and then if it improves, then you continue without mechanical circulatory support. But try to see to it that there are certain relative contraindication even when there is an established need for mechanical circulatory failure. If there is somebody who's greater than 65 years, organ failure, BMI greater than 45, advanced comorbid conditions at baseline that limits life expectancy, and inability to tolerate anticoagulation. These are certain relative contraindications, though not absolute, because there is no absolute contraindication for mechanical circulatory support. In any case, losing the patient. In case there is somebody who's got a respiratory failure with refractory hypercapnia or hypoxemia despite ARDS treatment, then you have to start looking at other options. And these options are whether you want to put the patient on ECMO, or you want to put the patient on mechanical circulatory support with ECMO or not without ECMO. But those are tricky issues which gets sorted out on a case-to-case basis. You can have, if there is a left-sided isolated failure with right ventricle being normal, you can consider PA. If there is both, then you have to consider biventricular ECMOs or a staged mechanical circulatory support. Those are things which will be depending upon what the case situation is. Now coming to possible etiologies for pollen elevation in suspected or confirmed COVID, and these are the algorithm for that. That for cardiovascular symptoms, troponin elevation patient with suspected or confirmed, this thing is have an ECG, monitor the patient by telemetry, trends of troponin should be there, and consider POCUS. POCUS is point of care ultrasound, which a person there should be reasonably able to do. Otherwise not, you can take the images and send the patients online, and you can, experts can comment on that. Or
Dr. Samir, would you please summarize now?
Okay, so these are certain things where you have to consider myocardial injury, cardiomyopathy, type 2 myocardial infarction, and acute coronary syndrome. And I'm not going to just quickly highlighting there are certain drugs which have to be carefully looked after. Actually, if you have to give in acute coronary syndrome, then because of the increased bleeding risk, prasugrel is recommended if you have to use lopinavir and ritonavir. Apixaban is not recommended unless there is an absolute need for it. Don't use GP2B3 inhibitors. Okay, so quickly going to, in case of fibrinolytics, then tenecteplase is the reasonable choice. When it comes to mineralocorticoids, spironolactone is preferred, not eplerenone. You have to be very careful when you are using digoxin. Preferably, I don't use them. QT interval is a big debate these days because Torsade is an issue with QT interval prolongation. And if in case you are looking after the electrolytes, try to maintain magnesium more than 2 and potassium more than 4. And when it comes to thromboembolic phenomena in COVID, then venous thromboembolism has been reported in high percentages, and one of the systemic reviews reported occurrence of VT as 20%, while cumulative incidence could rise almost about 50% for hospitalized patients. CT is the investigation of choice, and then you have to manage them with unfractionated heparin or low molecular weight heparin. There are actually no specific proven treatment for COVID-19 associated myocardial injury, and current therapy is based on reducing viral replication and modulation of the host inflammatory response. And one of the reasons why steroids have taken a high dose steroids have taken over in a big way is for those issues. Avoid NSAIDs. Combination of HCQS and azithromycin is a bad combination to be used. Younger patients and those requiring non-invasive ventilation may benefit from remdesivir. And actually, FDA has also issued some emergency use authorization. We are using it quite often, more often than probably what is the recommendation. But some people have found good results with that. Such medications may be considered after consultation with infection disease patients. Steroids are typically avoided. It may lead to hemodynamic instability and end organ damage. But the use of steroids have been efficacious in treating myocarditis from immune checkpoint inhibitors on giant cell. IVIG, HCQ, avoid HCQS, ACE inhibitors and ARBs went into some kind of a very strong debates, but most of the societies have said that they're reasonably safe. Statins usage has brought down the severity of the disease compared to 27% people who got admitted were on statins and they had beneficial. They had lesser of complications and they were lesser into the group of severe. ECMO and other hemodynamic support are case-to-case basis, but FDA has cleared ECMO therapy for longer than 6 hours of COVID patients in shock. And that is the reason, and abiomed, which is the mechanical circulatory support, can be used. So it is not clear if hypertension is age dependent, but it is essential that hypertension remains well controlled. Do not stop ACE inhibitors of ARBs, and may plaque instability and MI, which is a common cause of death, is to be sorted out. So concluding that cardiovascular complications are a common finding, pharmacotherapy an integral component, drug interactions have to be very carefully seen, and hydroxychloroquine and protease inhibitors deserve special note because of drug-drug interaction. And there I will end saying, sorry, I just crossed a few minutes over. I understand we are running out of time, but I'll stop here. Thank you very much, Dr. Sumitra Kumar.
Thank you, Dr. Samir, for your very elaborate presentation as usual. Dr. Manjula, do you have time for some interaction?
So there is only one question, if you can take that. We are already 20 minutes.
I think Dr. Pankaj Manoria has asked Dr. Bharat Shah, what is the lower limit of EGFR for RAS blockade? Dr. Shah, would you please quickly address the question?
Yeah, so I did mention in the reply in the chat box that there is no limit as regards GFR. If you introduce a drug, if your renal function remains stable and potassium is not a problem, you can continue. But there is no significant benefit to be achieved by introducing ACE inhibitor or angiotensin receptor blocker at an advanced stage of chronic kidney disease. They are most useful when you introduce at an early stage, because then you have substantial renal function and you can preserve it for a longer period of time.
Dr. Sumitra, can I ask one very small question?
Yes, Senior Dr. Manoria.
Dr. Shah,
yes.
Are SGLT2 inhibitors effective in tubulointerstitial disease, and can you translate the data into transplant kidney and solitary kidney?
Yes, from the DEPA study, they will be useful even in tubulointerstitial diseases, because all chronic kidney disease will have an adaptive mechanism coming into play, and that will be minimized by SGLT2 inhibitors. They can be useful in transplant setting also. We have used SGLT2 inhibitors in transplant patients, and surely they can be used in solitary functioning kidney.
Yeah, Dr. Samir, can I ask a quick question?
Yes,
A person coming 4 hours after onset of chest pain with STEMI, COVID status unknown, PO emergency, what would be your reperfusion approach?
So actually, the heroic interventionalists in our hospital have done primaries also, but most of the people would accept that you reperfuse them by fibrinolytic therapy rather than take them up for primary PCI. Hemodynamics permitting, you should not be very heroic in such situations.
Okay, I fully agree with you.
Thank
So,
you.
Dr. Pathak, would you like to make some comments before we wind up?
Yeah.
Pathak, are you there? So I don't know whether his connection has been disrupted.
Yeah.
So a big round of applause for both the speakers, Dr. Shah and Dr. Srivastav, for doing a wonderful job with your deliberations. And thank you, members of the audience. Best wishes to you. So with that, I will wind up on behalf of my co-chair as well. So over to Dr. Manjula.
Thank you very much. Thank you very much to the speakers as well as the chairpersons. So we move on to the most sorted out session for today, which is a panel discussion, which is titled Hypertension, Comorbidities, Prevention and Management. We know that hypertension frequently coexists with obesity, diabetes, hyperlipidemia, or metabolic syndrome, and their association with cardiovascular disease is very well established. The identification and management of these risk factors is an important part of overall management of hypertensive patients, as patients with comorbidities are more prone to target organ damage. So effective BP control through a 24 period is very, very important, and it requires multidisciplinary expertise. That's the reason why we are having our panel of experts who have expertise in multidisciplinary phenomenal experts. So to do this and to take this panel discussion, we have none other than Dr. A. Muruganathan sir, whom all of you know personally, who does not require any introduction. As a formality, I'll be introducing sir. Dr. A. Muruganathan is a triple FRCP, and he's a chairman of AG Hospital, Tirupur, and governor of American College of Physicians India chapter, emeritus professor, the Tamil Nadu Dr. MGR Medical University, dean, Indian College of Physicians 2016 to 17, president, Hypertension Society of India 2015 to 16. He has edited several books, to name a few: Adult Immunization, Progress in Medicine, Medicine Update 2013 and 17, and Manual of Hypertension 2015 and 19. He has been given several awards and accolades, to name very few: BC Roy Award from President of India 2005, Best Performing Doctor Award from Tamil Nadu Government on Doctors Day 2014, and received Lifetime Achievement Award from Dr. MGR Medical University. And also Dr. Muruganathan sir has been helping us through our Micro-Knowledge Academy with a lot of scientific activity, as well as he's the chairperson for CME activity of Fever Foundation. And he's been our guide and the teacher for all our endeavors in terms of academic activity of Micro-Knowledge Academy. Sir, welcome to you once again, sir. And I request you to kindly take over the proceedings, sir. Over to you, sir.
Thank you, Dr. Manjula, for those nice words. At the outset, I must thank our mentor, Dr. Siddharth Shah, for the wonderful program. I thank Manjula, Dr. Sris, Mr. Sris, for arranging such a good program. So let me introduce the panelists first. Dr. P.C. Manoria is the Director, Manoria Heart and Critical Care Hospital, Bhopal. He is the former professor, head of the Department of Cardiology, CMC, Bhopal. He is honorary physician, to the Excellency Governor, Madhya Pradesh. Past National President of CSI, API, ICC, and past Dean ICP. Organized several national and international conferences, delivered more than 500 lectures in various national and international forums. Lifetime Achievement Award during the WCC PC 2008 by Bharat Ratna Honorable Sri A.P. Abdul Kalam. Special Award in Cardiology. Our next speaker is Dr. Amit Sharaf. He is the Director, Department of Internal Medicine, Jupiter Hospital. He is MRCP London examiner, a TNB teacher and MD examiner, National APA Governing Council member, consultant physicians and DNB teacher, ex-assistant professor at Terna Medical College, and reviewer for the British Medical Journal and Annals of Internal Medicine. The next panelist is Dr. Sanjay Maitra, is a fellowship in clinical nephrology, Toronto University, senior consultant nephrologist, Apollo Hospital, Hyderabad, a member of the ISN, PDSI, ISOT, and the American Society of Nephrology. He has published 27 articles in peer-reviewed journals, an expert in the management of all types of kidney disease, particularly renal transplantation and dialysis of both hemo and peritoneal dialysis. Presently working on the implementation of preventive strategies of slow, rapid progression of CKD. Our next speaker is Dr. Mangesh Tivaskar. My brother is the consultant physician and diabetologist, Silpa Medical Center. He is also the General Secretary of APA, gold medalist in MBBS, MD, Pathology, Microbiology, and Pharmacology, on editorial board of JOPI, Medicine Update, governing body, West Zone representative of ACP, India chapter, guest editor, Insulate Journal, World Journal of Anemia, delivered more than 1,000 lectures at national and international conference, and has multiple publications, poster presentations, and a great academician and great communicator. Next, the one of the architect of the program and mentor of API and the mentor of this program, Dr. Siddharth Shah, is a consultant physician, diabetologist, Saifi Hospital at SL Rahija Hospital, Bhatia Hospital, Reliance Sar HN Hospital, Mumbai. He's a postgraduate teacher in diabetes and medicine, executive editor, APA Textbook of Medicine, 11th edition, and Journal of the Association of Physicians of India. He's a convener of the Indian Hypertension Guidelines 1, 2, 3, coordinated and attended various scientific meetings in India and abroad, contributed more than 175 articles in peer-reviewed journals, textbooks, and monograms. It's a great pleasure to have Siddharth Shah, because when I was the president of API, he released the second APA, hypertension guidelines. It's always a pleasure to work with him. I was past president of the Hypertension Society of India under his dynamic guidance. Now, over to the panels. Now, we'll go to the panel discussion. The topic today we have chosen is hypertension, comorbidities, prevention, and management. Okay, let me ask my first question to my brother Mangesh. Mangesh, what are the common comorbidities in hypertension?
Thank you, sir, for those kind words of introduction. Good morning, everybody, and morning, Siddharth sir, Dr. P.C. Manoria sir, Amit, to you as well. And thank you, Dr. Manjula and Shirish, for this opportunity. Now, the commonest comorbidities, as we all know, which can come along with hypertension, apart from diabetes, is usually dyslipidemia, metabolic syndrome, obesity, chronic kidney disease, and some immunocompromising situations like malignancies, and nowadays COVID as well. So these are all the common comorbidities that we commonly encounter. But the most common which we encounter are usually diabetes, dyslipidemia, and obesity and metabolic syndrome.
Okay, thank you, Mangesh. Though we have comorbidities, whatever you said, we'll deviate a little bit because we'll have to ask something on CAD. We must ask something on CKD also, because nephrologists and cardiologists are there. First, let me ask our beloved mentor, Siddharth Shah, who has architected the Indian hypertension guidelines. So according to you, what is the target or goal of BP in the case of diabetic hypertension?
Yesterday we had a beautiful talk regarding the goal of blood pressure, and it was agreed that the target goal of blood pressure should be 130/80 for all. But beyond the age of 85, the goal of blood pressure can be 140/90. Otherwise, it has been now agreed by all the nations that the blood pressure goal should be 130/80 millimeters of mercury.
Thank you, sir. P.C. Manoria, sir, coronary artery disease is common in hypertension. Though it's not a comorbidity, it may be a complication. What are the pitfalls in diagnosis of coronary artery disease in patients with hypertension? Because this is a common problem which we come across. I think we should highlight this practical implication. How do you diagnose? What are the pitfalls in diagnosis of CAD in a patient with hypertension?
Good morning, everybody. Now, one of the common problems we face in hypertensive patient is we have history of angina and apart. The stress test is positive when the angiogram is normal. Now, this is very important to remember, and there are several reasons for it. The first reason is hypertension can produce a positive stress test due to increase in demand of the myocardium. The oxygen consumption of myocardium is increased because of increase in blood pressure, because of an inappropriate increase in blood pressure during stress testing, left ventricular hypertrophy. So as we know, angina is an imbalance between demand and supply. But in hypertensive, these are the reasons you can get a normal, you can get a positive test and a normal angiogram. The second reason is there may be associated microvascular disease due to endothelial dysfunction, capillary rarefaction. So you can get a normal angiogram and despite a positive stress test. So how do we make the diagnosis in a simplistic way? While looking at the angiogram, if the dye clears off rapidly and the epicardial artery are not showing any lesion, this means no epicardial disease, no muscular microvascular disease. If the dye takes 4 or 5 cycles to clear, this is an easy test to suggest there is microvascular disease. Otherwise, if you want to diagnose microvascular disease, you have to calculate CFR, which should be less than 2. In patients who are going for an angioplasty, if there's associated microvascular disease and you don't look for it, the results of angioplasty may not be appropriate and you may have precipitation of angina due to embolization in the microvascular bed. So this syndrome, when we look at is 17 times you get a false positive stress test in hypertension, and the message is please try to control blood pressure before submitting the patient to stress test, but still you can get a false positive stress test.
PC Manoria, as a sub question, in a microvascular angina, what is the treatment? You said angio is not possible. So what is the treatment you give?
The microvascular angina, usually we can give nicorandil and we can give calcium channel blockers.
Why not nitrates in the microvascular?
Nicorandil has a better action on the microvascular bed compared to nitrates. So that's why we prefer nicorandil when we are talking about microvascular.
Because nicorandil only can give the, it can donate nitric oxide. Nitrates cannot donate nitric oxide in the microvascular arena, and it has got ischemic preconditioning also. Nicorandil will be a good drug in angina. Now, I'll go to Dr. Sanjay Mitra. How common is hypertension in CKD? Because CKD can be a cause of hypertension, or it can be effect of hypertension. How common is that in your practice?
Good morning to each one of you. Good morning to each one of you, Dr. Muruganathan, Dr. Siddharsha, Dr. Manoria, and the other senior members of the faculty, and my thanks to the organizers. Answering the question in one word, it's very common. Let's put it like, for example, and it depends on the stage of chronic kidney disease. The worser the renal functions, by the time one reaches kidney disease stage 5 or even not on dialysis, the range or the prevalence of hypertension in that group is to the tune of 90%. By stage 3, in the early parts, I would say that the incidence is around 50 to 60%, and it progressively increases.
Okay, thank you, Sanjay. Amit, type 2 and hypertension. What is the common soil hypothesis? Why type 2 diabetes and hypertension, insulin resistance? What is the common soil hypothesis? Amit, unmute. Please unmute.
So sorry. Good morning to everybody. Dr. Muruganathan sir, Dr. Siddharsha sir, Dr. Mangesh Tivaskar, Dr. Manoria sir, and Dr. Maitra. Pleasure to be here. Thank you so much, Dr. Sasha, for this opportunity. So the common soil hypothesis for many of these conditions today has been put forth. When it comes to type 2 diabetes and hypertension, we've noticed to begin with a lot of insulin resistance coming in. That leads in the long term a lot of beta cell fatigue. That leads to in the long term a lot of insulin deficiency. And to top it up with atherosclerotic risk also increasing with hypertension, all these components have been an overlay of a genetic and an environmental factors. That has been today being considered a common soil hypothesis for both a metabolic condition like type 2 diabetes and a metabolic condition like hypertension.
Thank you, Amit. Mangesh, what is the role of lifestyle changes, especially aerobic exercise? And now we also introduce the resistance also in case of CVA and hypertension?
Yeah, sir, if you really look at the recently published guidelines and even our Indian Hypertension Society guidelines published under the leadership of Dr. Siddharsha, the third guidelines that we have published, the most important thing after becoming aware about the hypertension is to implement an adequate lifestyle change. So no matter it may be a dash diet, no matter it can be a aerobic or anaerobic exercises, weight reduction, smoking cessation, they all have class 1A evidence. So, and sometimes, a properly implemented lifestyle can serve you as probably one or sometimes even two pharmacological medications or the drugs that have been equal to like that and without side effects. And sometimes they can give blood pressure reduction up to 2 digits. So it's very important for us to implement these lifestyle therapeutic changes as a part of hypertension management.
Thank you, Mangesh. Sir, Siddharth sir, what is the ideal antihypertensives in a case of a metabolic syndrome or in a diabetic hypertension?
Thank you, Dr. Muruganathan. I think your pioneer work in the blood pressure must be recognized even in the Hypertension Society of India. You have done a lot of work for home blood pressure monitoring, I remember. So I think a few comments on home blood pressure, though you are the moderator, I thought it fit that you should talk about a little about home blood pressure monitoring whenever the chance permits. But answering your question, the best drug, as everyone has agreed upon, if there are no contraindication, ACE inhibitors and ARBs are the first drug of choice in metabolic syndromes.
Thank you, sir. Thank you, sir. Thank you for bringing out that home blood pressure monitor. I'm very happy and overwhelmed. The previous speakers emphasized that home blood pressure should be done in the nephrology aspect, in the cardiology aspect, and home blood pressure is the poor man's APBM. So in this conference, I request all of you promote home blood pressure monitoring. Please, request your patients, especially in the lockdown period, in the COVID period, to control hypertension, home blood pressure monitor is very, very helpful. Now, Dr. Manaria, sir, obstructive sleep apnea is not uncommon in patients with hypertension and also in the resistant hypertension. How do you make diagnosis and what are the predictors of SCD in patients with the OSA?
Obstructive sleep apnea is a very common comorbidity and it predisposes the patient to myocardial infarction, atrial fibrillation, sudden cardiac death, and even a stroke. The diagnosis of obstructive sleep apnea is made by the apnea-hypopnea index. The normal is less than 5, 5 to 15 is mild, 15 to 30 is moderate, and more than 30 is severe. There has also been work on the basis of polysomnography as to which subset of patients of obstructive sleep apnea are more prone for sudden death. And it is seen that if the mean nocturnal oxygen saturation is less than 93% and the lowest oxygen saturation is less than 78%, these are distinct subset of patients of OSA who are at high risk of sudden death.
Okay. What is the drug we use in the sleep apnea hypertension? What is the best drug?
Besides other drugs, the aldosterone antagonists have been found to be useful because they decrease edema in the pharyngeal area. So it is seen that if you use spironolactone, even eplerenone, it decreases edema and improves obstructive sleep apnea. But lifestyle modification, CPAP is a very good treatment that has to be resorted. Without CPAP, you may use antihypertensive drugs, but the hypertension remains resistant in vast majority of patients. So CPAP and aldosterone antagonist is the only drug with decreased edema is found to be useful. Otherwise, they are poor responders and they have resistant hypertension.
So, good point that spironolactone not only is a diuretic, it also produces reduce the edema in the upper airways. That is one point favor in spironolactone. Dr. Sanjay Maitra, please briefly tell me what are the pathogenesis or pathophysiology of hypertension in a chronic kidney disease?
Firstly, there are basically four mechanisms. The one which we all know and attribute to is the stimulation of the renin-angiotensin-aldosterone system. That's easy to understand. As the number of glomeruli come down, in the remnant glomeruli, there is ischemia and there is around the pericapillary tubules, there is less of blood supply. This stimulates the renin and subsequently the angiotensin and then finally the aldosterone. The other mechanism is in the part when the sodium retention starts. This is in the later part, and that is one. Sodium and volume retention is the second part. The third is the stimulation of the sympathetic nervous system, which in turn further stimulates and worsens the renin-angiotensin system, and the renin-angiotensin system further stimulates the sympathetic system. And the fourth is the lack of the nitrous oxide, the damage to the microvasculature, and the endothelin. These are the four major mechanisms which have been attributed to the generation of hypertension in the context of chronic kidney disease.
Thank you, Sanjay. Amit, what is the choice of antihypertensives in chronic, cardiac failure?
Right. So most of the patients of chronic heart failure with hypertension, I think a lot of cardiology colleagues will agree that beta blockers are the drugs of choice. So we have a lot of cardioselective beta blockers today, and I think they could be tailor-made and given as per the clinical scenario, individualized as well. Certain situations where sometimes with added on diabetes in present, and sometimes as Dr. Siddharsha and Dr. Mangesh Tivaskar also mentioned, and ACE inhibitors or ARBs can be brought in. And aldosterone antagonist receptor blockers also have some little role in the treatment of cardiac failure with hypertension. Not to mention also little of hydralazine at times has been proven to be beneficial.
Okay. Mangesh, what is the best antidiuretic in diabetes, hypertension?
Yeah, currently the evidence, even though goes towards probably, I would say thiazide-like diuretics, but still, I would say that, there can be some role of MRAs, if the thiazide-like diuretics are. But now currently, a good evidence suggests that, thiazide-like diuretics are the fair drugs of choices, and they do not cause too much of dysglycemia.
What about the indapamide?
Yeah, so I mean thiazide-like diuretics and indapamide is a fairly,
because indapamide is also lipid neutral, and especially in elderly patients, indapamide can be given. That is in the cardiac outcome trials, everything, indapamide is favorable. So it scores over the other diuretics. Thank you, Mangesh. Sir, Siddhartha, what are the beta blockers we use in diabetic hypertension?
As has been said by the Indian hypertension guidelines, we try to avoid beta blockers in diabetics, especially when we know that it causes postural hypotension and remodeling is affected. So as far as possible, we avoid beta blockers. But otherwise, newer beta blockers like carvedilol can be used in patients who are diabetics. I must say that we have on our panel Dr. Manoria, Dr. Amit Sharaf, Dr. Sanjay Maitra, and Dr. Mangesh Tivaskar. We all understand that beta blockers we should avoid, but if we have to, at the last resort, we can use selective selective beta blockers like carvedilol.
Yeah, if there is a compelling indication when we have to use beta blocker, carvedilol is the best drug in a diabetic hypertension. Thank you, sir. Why the mortality of uncontrolled hypertension is 1.5 to 2 times more compared to normotensive? PC Manoria.
Thankful to you for asking very tricky questions. Now, it's very important to remember that the mortality in a controlled hypertensive is 1.5 times, 2 times compared to a normotensive, which clearly gives the message that you should prevent hypertension and prevent hypertension. And there are a couple of reasons for this. The first reason is atherosclerosis continues unabated even after control of blood pressure. So you can still get a stroke, as we say, you still get a myocardial infarction, you can get stroke. The second important reason, which is not widely disseminated, is If your hypertension remains uncontrolled, fibrosis develops in various parts of the cardiovascular system. The fibrosis in the myocardium makes the patient more prone for diastolic heart failure, more prone for sudden cardiac death. And this is very easily demonstrable by LGE CMR, late gadolinium enhancement. And this does not apply to the hypertrophic ventricle of hypertensive, but also applies to cardiomyopathies and aortic stenosis. So an intelligent surgeon these days always looks at the CMR before operating. The results will not be good if patient has hypertrophy with fibrosis. Then there occurs fibrosis in the left atrium, makes the patient predisposed to atrial fibrillation, thromboembolic phenomena. It occurs in large vessels, which increases the stiffness and makes the patient prone for isolated systolic hypertension. So hypertension should be treated early, and the dicta remains prevention. Prevention must be attempted because even if your blood pressure is controlled, you are still at 1.5 to 2 times risk. So that are some of the reasons.
But one important message in this COVID times, the people with controlled hypertension has got the same equal morbidity and mortality than the uncontrolled hypertension. So the key is, even if you develop COVID, if your hypertension is controlled, your morbidity and mortality is as equal as normal. Now, Amit, our Sanjay, what is the secondary hypertension? Why people come to nephrology whenever there is a uncontrolled hypertension, and when there is a secondary cause, why do they come to nephrology, and what do you do? How do you approach?
Secondary hypertension, very simply described, is hypertension due to a disease or a condition or in any other organ. And why they come to nephrologists is because most of these hypertension patients are ones who are young, who have sudden onset and very high blood pressure levels, and to the nephrologist because the kidney, either renal parenchymal or renovascular, is one of the commonest causes of secondary hypertension. Secondary hypertensions are the ones who have to be treated very early, diagnosed and treated, managed very early, because they generally end up causing a lot of target organ damage, including being a kidney specialist, particularly the progression of chronic kidney disease and others, definitely cardiovascular disease, etc., which has already been discussed. So the first thing in any severe hypertension is the risk factors which have been attributed to obesity, sleep apnea, etc., poor control of blood pressure, this LVH, etc., has to be looked at. And once this has been diagnosed, the target has to be achieved quickly. You can start with 2 medicines, 3 medicines. Make sure at the same time that you've found out how severe the renal failure is. Is there anything else like a secondary, a hyperaldosteronism or a pheochromocytoma, a thyroid problem? These are some of the very common things. Once you've ruled it out, if there are no significant things, then the first motive should be to control the blood pressure, not worrying how many blood pressure medicines you're using. Maybe generally you need 2 or 3 medicines, including a diuretic, and mostly in terms of mineralocorticoids.
Thank you. Thank you, Sanjay. Dr. Amit, do you use statin for all hypertensive patients? If so, what is the ration behind it?
So right in the beginning, before even the atherosclerosis sets in, there is a phenomenon known as arteriosclerosis. That is a stiffening of the blood vessels. So there is definitely a role of first lifestyle changes. Statins come into play a little after if the patient doesn't adhere to lifestyle changes, dietary modifications. If the atherosclerosis is already set in, then you're worried about the secondary problems of maybe a plaque fissuring, a platelet plug formation, ultimately an ischemic event. So somewhere for plaque stabilization and atherosclerosis also removal, you need statin therapy to be instituted in a hypertensive a little early on. Choices are varied. We have statins, we have nitrates, we have fibrates, we have nicotinic acid as well. People have tried fish oil to a certain extent in the treatment of lipid therapy as well. So I believe, but the standard statins for their pleiotropic effects are very commonly seen, and a low dose statin can be continued in, I would not say almost all hypertensives, in those hypertensives which a family history with risk factors like smoking, like with ischemic heart disease, with other risk factors, they should be added early on in the treatment.
Manoria, you can add a comment on what Amit said.
We have 2 trials, which is an eye opener to these patients. Firstly, we have data from the ASCOT LLA trial, which showed that if you add merely 10 milligram of atorvastatin, there's a 36% reduction in MI and fatal CHD deaths. So that was the first trial which initiated this issue. The second is the HOPE-3 trial, which showed that if you use only candesartan plus hydrochlorothiazide, there's no change in the incidence of cardiovascular death, MI, and stroke in patients who are at intermediate risk without any cardiovascular disease. But if you add 10 milligram rosuvastatin, there's a 24% reduction in the incidence of cardiovascular death and MI. And what appears to me is very striking that when we examine patients, when we examine specimens of coarctation of aorta, most of these kids do not have any risk factor for atherosclerosis, but all of us have seen there's extensive atherosclerosis above the coarct, no atherosclerosis below the coarct, giving a message that hypertension damages the endothelium and perhaps allow macrophages to enter the subendothelial tissue and initiate atherosclerosis. So that may be one of the reasons, but hypertensive patient, even without risk factors, can have atherosclerosis. But we don't have any large trial on this, but these are the two data from the trials which show that even if your patient is intermediate risk, your risk of cardiovascular event is less than 1% per year, you can still be benefited from statins, low dose even.
In fact, the Lipid Association of India has come out with a guideline. If you have a CBS score for lifetime risk, for all hypertensives, it is more than 30%. So if there is more than 30%, they come into moderate risk category and they can be given statin. That is their recommendation. And of course, HOPE-3, they've done only the intermediate risk, and then they found out this statin is better than the antihypertensive in reducing the cardiac events. Thank you, sir. Mangesh, does diltiazem have a role in management of hypertensive CKD after optimal uses of ACE and ARB?
Diltiazem?
Yeah.
So as far as non-DHPs are concerned, as far as management of hypertension concerned, I'm not very sure about their role.
Sanjay, Sanjay,
yes,
yeah,
Sanjay,
you can answer.
Yeah, that
Sanjay.
is what I was to come to that.
Yeah, Sanjay,
please ask Dr. Sanjay on that.
Definitely, non-dihydropyridine, this calcium channel blockers have a role in the management of CKD patients with hypertension. If there is significant proteinuria and the blood pressure levels are not achieved even after starting ACE inhibitors or ARBs. The reason why it is said is that the ordinary calcium channel blockers, like the dihydropyridine calcium channel blockers, cause afferent arteriolar vasodilatation, and there is some data to show that they increase the progression of CKD. In this context, definitely non-dihydropyridine, like for example diltiazem, we use very commonly, and I have found that it is a good add-on to the ACE inhibitors and ARBs because they are reasonably effective, not as effective as the other ones, but definitely in terms it can reduce the proteinuria. Now, coming to the question whether you can use a cilidipine or a benedipine, well,
Yes, that was
went in different.
Yeah, in fact, I was to ask you the same question, sir, that,
Now
where you have got more renal specific calcium channel blockers on board,
but
how much the role of non-DHPs?
Guidelines, if you really look at the guidelines, the KD Goes Controversies Conference and all, as late as 2017, they have mentioned this very, very clearly. Now, in today's context, L, N, and the T channel blockers, there's a bit of a thing, and many of us do write cilidipine and benedipine more as compared to this group of medicines.
Yeah, but cilindapine is a good drug, but as an antihypertensive effect, it is not as good as amlodipine.
Absolutely.
So it is a weak antihypertensive. Of course, benedipine has got 3 channel blockers, and so we are preferring benedipine. Of course, it's a Japan drug. We are trying that also. Thank you, Sanjay.
Yes.
Sir, Siddhartha sir, you have mentioned an importance of diet in the guidelines. So throw some more light on diet, because this is a field where everybody ignores. Even the doctors, we advise, but we don't follow. Kindly throw some more light on diet and hypertension.
Thank you for asking me this very important question, which should have been the first question, I believe. As far as the treatment of hypertension, lifestyle modification comes first and last. Because if a patient stops his lifestyle modification, like diet, then his blood pressure, whatever the drugs may have been given, will become ineffective and the patient's blood pressure will rise. So as far as the diet is concerned, what is important is to restrict the salt in the diet of the individual. The things that are to be avoided are pickles, papads, and pastries, as it is commonly known that these things should be avoided. 4 grams of salt is allowed to the hypertensive patients on a day basis. Important thing to understand in our country, in our guidelines also, is that we have different uh, different parts of the country, different temperatures, and where it is extreme heat, person can lose a lot of water and salt. So you have to be very careful how much salt has to be restricted in this type of patients, because this can create a lot of imbalance. Also, you must try to do regularly electrolytes to find out if these patients have hyponatremia due to the diet itself or due to the drugs that the patient is consuming. And hence, what is important is that diet has to be individualized. Patients has to be educated regarding the salt intake, avoidance of certain drugs, especially in chronic kidney disease. One has to avoid the fruits, and in patients who have proteinurias with hypertension, one has to avoid high protein diet. This is what basics of diet in a hypertensive patient's need.
Thank you, sir, for bringing out that important, useful, practical data. Dr. Manoria, sir, what is early vascular aging and what is the relationship with hypertension and early vascular aging? How do you diagnose early vascular aging?
Hypertension is a very important cause of premature vascular aging. These days, we can determine prevascular aging non-invasively by measuring the brachial artery blood pressure, systolic and diastolic, by the central aortic pressure, the pulse wave velocity, and the computer calculates you for vascular aging. So you have 3 subset of patients. One, the vascular age is same as the chronological age. Second, the vascular age is higher than the chronological age. Another, rarely the vascular age may be lower than the chronological age. And hypertension is a very important cause of premature vascular aging, because if the vascular age, you are prematurely getting the vascular age, you are more prone for cardiovascular events. So hypertension is an important, and this is how they give the numbers also. 50 years old age is vascular age is 60, or 55 years old is vascular age is 50. So you can even get the numbers, and that creates an alarm to the patient, and the adherence of the patient to therapy increases. So that is one of the way even to get a number of the vascular age in a given individual.
What about central aortic pressure? Is it useful to find out the early vascular aging?
Yes, when we calculate the vascular aging, they also calculate the central aortic pressure, and all these calculations, the central aortic pressure also comes into way. Okay. Central vascular aging, as we know, is a better predictor of cardiovascular events, and obviously for the vascular aging.
Thank how about carotid intima media thickness, CIMT?
That there's a lot of controversy. People don't this. Central aortic pressure is, and as ambulatory blood pressure has come in vogue, I think after 5-10 years, this will also come to our clinics.
Okay, Sanjay, I ask a simple question. What is the earliest change in BP when you see a CKD patient?
Well, in that case, on the clinic blood pressure, routine clinic blood pressure, even though it may not detect, the ambulatory blood pressure may see a change in the nocturnal dip. That's the reversal of the nocturnal dip, or an early nocturnal hypertension. That's the earliest change. And it is seldom detected in the clinic context. And there are multiple problems, but just to emphasize the blood pressure as of today, we should be, if there are no major comorbidities, the target is 130/80, and better still, 125/75 in the view of the SPRINT trial and the latest data. There is controversy in this and has been mentioned, but this is what I would take. But to answer this, it's ABPM.
Yeah, Mangesh,
Yes.
Do you advise ABPM for all patients of hypertension or a certain sector of people?
The places where we probably advise ABPM, ABPM is not for all. And as Dr. Sanjay has already pointed out, and even Amit and Sir, Dr. Siddharsha Sir has also told that, in a patients, those who have probably, you're suspecting mass hypertension, or people, those who have got white coat effect, or, you want to find out about the why the therapy is failing, or sometimes you need to find out even the drug effect. These are the patients whom you may probably advise 24 hours ambulatory blood pressure monitoring. And as Dr. Sanjay has already spoken very well, that it could be the absence or the reverse nocturnal dip in, which could be one of the earliest indicator of the development of a CKD. These are the things where you may ask for, but ideally not for all. Somebody presents to you with a blood pressure of 160 or 120, you don't require an ambulatory blood pressure monitor. So
And
whenever
even-
you are suspecting mass hypertension or the white coat effect, these are the people.
Even for the drug,
Yes, and drug effect or drug failure, you want to judge the drug
you have to do
therapeutic
all this,
effects and all that. These are the areas where you can ask
have
for
to-
ambulatory blood pressure monitor.
Okay. Sir, Siddhartha sir, do you give combination therapy in the first day itself, or how do you approach hypertensive patient?
A very important point you have brought out. Now, all the guidelines have said that combination therapy early on is recommended in management of hypertension, because single drug is not able to do the performance of bringing down the blood pressure to the target level. So combination therapy at an early stage is recommended in patients having very high blood pressure on seeing on the first visit, having 180 by 110 and higher, or grade 3 type of blood pressure. I think combination therapy can be initiated in this type of patients.
Thank you, sir. Thank you, sir. PC Manoria, sir, what is isolated systolic hypertension in young? Is it common? And what is the drug you give for isolated systolic hypertension in young people?
I think these days we are seeing isolated systolic hypertension in the young. We have a lot of young individuals from the IT and other sectors who are very anxious, very tense. And when we give small doses of beta blockers, the blood pressure is controlled and they have a good feeling of well-being. The long-term impact and the long-term trials of isolated systolic hypertension are yet to be conducted. But this is one of the observations that in this subset of patients, particularly Indians who are hypersympathetic, beta blockers produce good response.
Okay.
So Muruganathan sir,
yes.
next 3 minutes, is it possible to close, sir?
Oh God. Okay.
We are running late.
Okay.
Thank you, sir.
I can finish it 3 minutes. Now, before I finish, because the panelists are very experienced persons, so give me 2 more minutes. 5 minutes I take. Okay.
Yes.
Now, Mangesh, some of the complicated comorbidities like psoriasis. Any precaution in a psoriatic patient with hypertension?
Yeah, certain drugs to be avoided. Sometimes there is a possibility of high incidence of probably psoriatic exacerbations with certain drugs. There, probably you need to be a little careful when you are using ACE and ARBs. You need to be a little careful.
In fact, Mangesh, why I asked this question, you should avoid beta blocker because
yes, and that's what I was coming to my second. Yes,
so
my second answer was that you should be careful because ACE and ARBs and beta blockers are the two drugs where you should be very careful.
Very careful.
And preferably the drugs of choice there. You should be using mostly the calcium channel blockers would be the first choice of therapy when it comes to psoriasis.
And Sanjay, in a case of HIV with hypertension, any particular drug you should avoid?
Well, HIV, the problem is firstly hypertension, and I'm talking only of HIV nephropathy. I mean, I'm a nephrologist. I mean, in general is all right, but HIV associated nephropathy, where it's very uncommon to find severe hypertension in this group. Now, coming to your question, I would be a little hesitant unless I know the therapy, because many of the HIV drugs are itself nephrotoxic. And without knowing, and particularly if the blood pressure is not very high, I would be a little hesitant to start ACE inhibitors or ARBs if the patient is not under my regular follow-up. If the patient is under my regular follow-up, I will monitor them strictly and continue the usual panel.
Because most of the retroviral drugs, protease inhibitors, act with the CCB, for example, it may increase the concentration of CCB,
Yes.
or it may decrease the efficiency of losartan. And in a case of hyperuricemia, when a patient with hypertension, it is an ideal drug is losartan, because you should not give diuretics. It may cause gout.
Yes.
So whenever there is a comorbid condition, when you do a drug trial, when you do give drugs for other diseases, you should be very careful. Same way in a rheumatology patient where they have got osteoarthritis, you should avoid NSAID, because if the NSAID is there, hypertension will increase. And when there is NSAID, you should always give calcium channel blocker, is the ideal drug for people. And people who are smoking also, the ideal drug is calcium channel blocker. That's why the drugs very important. PC Manoria, we cannot leave without talking about one comorbid condition is COVID and hypertension. Just 1 minute your message, and then we'll wind up.
COVID, hypertension does not predispose to COVID. Uncontrolled hypertension, getting a COVID, the mortality is increased. COVID does not facilitate entry of the virus into the cells, and RAS blockers should not be withdrawn. In fact, they were found to be decreasing morbidity and mortality of COVID.
Okay, so
it should be utilized.
Thank you, PC Manoria, because we had a very long discussion. Previous speakers spoke about COVID and hypertension, so I thought I will summarize that. And then the topic given to me is prevention. So we have not talked anything about prevention. So you can prevent hypertension, people developing diabetes by targeting nocturnal blood pressure. There is a study. If you control the hypertension, they may not develop diabetes for 5 years at least. Same way, a patient with asthma or COPD, if you give proper treatment, bronchodilators, if they don't go for hypoxia, they won't develop hypertension. Same way, if the patient with rheumatoid arthritis or SLE, if you give hydralazine-like drugs, that may produce hypertension. So whenever there is a comorbidity, you can prevent hypertension from the comorbidity. Also from the hypertension, you can prevent comorbidity. So both the ways we can prevent. So prevention is the title. So that point for food for thought for all of us, that comorbid condition, whenever they get, how to control hypertension. When hypertension is there, how to control comorbidity. Now the final message and words of wisdom from Siddharth Shah sir, and we'll wind up. Siddharth Shah, a drive home message for all the audience about the whole hypertension control.
I think, Dr. Muruganathan, we have discussed almost all the aspects of hypertension under your under your leadership. And I think that what is important is education and follow-up of these patients. It is very, very important to control the blood pressure.
Yeah, thank you, sir. And my message to all of you is focus on hypertension, because we have got so many diabetologists, but we don't have hypertensionologists or hypertensionists. First, finally, get a validated BP monitor and have 3 cup sizes. You know, always in every clinic, we have only 1 cup. We don't have obese cup or a small lean cup. So buy a 3 cup, have a validated BP monitor, focus on hypertension. I would like to develop more hypertensionists and hypertension clinics under the leadership of Siddharth Shah. So that will be a very good message, because we have got more morbidity and mortality and incidence of hypertension than the diabetes. With this, I conclude. I thank the organizers at Professor Siddharth Shah, Dr. Srish, Dr. Manjula, and all the panelists for their excellent deliberation and discussion. Manoria, Amit Saraf, Sanjay, Mangesh, and Siddharth Shah, sir. Thank you. Namaste.
Thank you. Have a nice
Thank
day.
you.
Stay
Thank
safe.
you, Dr.
Siddharth, when are you appearing live?
Thank you,
Dr.
the
Siddharth, when
panelists.
are we meeting?
Thank you,
Dr.
sir.
Manoria, Dr. Mangesh.
Dr. Mangesh, Dr. Saraf.
Yeah.
Dr.
Thank
Mangesh.
you,
Dr.
PC.
Amit
Thank you very
Saraf.
much. Yes.
Thank you so
Thank you,
much.
Thank
Sanjay.
you.
Thank you,
Thank
Amit.
you.
Very well conducted.
Thank you, sir. Thank you. Thank you, sir. Thank you.
Thank you, everyone, entire panel and the chairperson. And before we move on to the hot topic pro-con debate, I request Dr. Siddharth Shah and Dr. Shashank Joshi to address the gathering, and then we go on to the pro-con debate.
Friends, over the last 1 day almost, we have seen a galaxy of speakers, national and international, attending this 2-day meet done by Hypertension Society of India and Indian College of Physicians. I must thank my co-colleague, Dr. Shashank Joshi, who is the Dean of the Indian College of Physicians, to have agreed to this first virtual HyEcon that is being conducted in the COVID times 2020. I must place on record the excellent platform that has been given to the two societies by Micro and his team. Especially, I would like to mention Sirish Shamak and Dr. Manjula Suresh to have put their whole mind into this program and taking this program forward in such a nice way. The response has, as I've been told, is tremendous, and we hope that we keep up this response for the cause of hypertension, as has always been a part of the Hypertension Society of India. Thank you all. May I ask Dr. Shashank Joshi to say a few words on behalf of the Indian College of Physicians.
Thank you so much, sir. At the onset, I want to thank Professor Siddharth Shah, who is the Executive Chairman of Hypertension Society of India. Hypertension Society of India is at a global platform now, all because of Sir you, sir. And thank you so much for allowing Indian College of Physicians to partner with HSI. You have been a leader for us. You have always inspired us. You have been a mentor to all of us, and you continue guiding us. So I would like to place on record our heartfelt thanks and congratulations to you, sir, for continuing guiding us all throughout in our journey of path of knowledge and wisdom. And that is something for which you stand for, sir. I would also like to place on record, as sir rightfully said, the Micro Knowledge Academy for very efficiently partnering with the Indian College of Physicians and Hypertension Society of India. Particularly, my thanks are due to Shirish Samak, Dr. Manjula Suresh, and the whole team Micro. And I want to thank each one of you who are faculty and delegates at this excellent meeting. We are all here to, as they say, listen. What we listen, we learn. What we learn, we adapt. And I'm certain that at the end of the day, our common goal is to get our patients under better control. And that is what we all strive for. I will also take this opportunity to welcome all of you for the virtual HyEcon from 4th to 7th of March 2021. Due to the new normal of COVID era, we will be doing a virtual HyEcon this time, and you will soon see in the brochure in another 15 days. And I am with me here Professor Siddharth Shah, Dr. Mangesh Tivaskar, Dr. Agam Vora, Dr. Ashit Bhagwati, and the whole team API, including Dr. Amit Saraf and everybody. And of course, our president is Dr. Arul Raj, and our president-elect is Dr. KK Tiwari, dean-elect is Dr. Rajesh Upadhyay. So I welcome you all to the virtual HyEcon. And once again, I thank the Micro team for an outstanding meeting. And sir, thank you so much for allowing us this opportunity. Dr. Siddharth Shah, thank you so much. And I just want to congratulate each one of you. Proceedings of these meetings will be very much available on the ICP website later on. So if anyone has missed any particular lecture, that they will be able to visualize those lectures later so that we can capture them. So because learning is a constant process. If somebody misses due to any exigency, they can always visualize the lecture and learn something from it. Thank you so much. Jai Hind.
Thank you. Thank you very much. Thank you, sir. And it was wonderful to hear from both the Executive Chairman, Hypertension Society of India, Dean, Indian College of Physicians. Thank you so much. Now we move on to the pro-con debate, which is titled Hypertension Management, FDC versus Giving Individually. Hypertension remains, we know, the #1 cause of morbidity worldwide, and patients' comorbidity, especially of cardiovascular nature, need to be managed effectively. Today's debate is going to discuss what are the factors deciding when choosing between FDC or free dose combination of antihypertensive. Is it more flexibility in higher risk patients who are likely to require aggressive therapy, more precise titrated doses, or is increased persistence or adherence by patient is more important, with the ultimate goal to achieve optimum BP control? So to umpire this pro-con debate, we have renowned professor of cardiologist from Lucknow, Dr. Aditya Kapoor sir, And Dr. Aditya Kapoor, as I mentioned, Professor of Cardiology at Sanjay Gandhi PGIMS Lucknow. He did it MBBS from UCMS New Delhi and MD from MC New Delhi and DM Cardiology from SGPGI Lucknow. His special interests include coronary intervention and cardiac electrophysiology. Over to Professor Dr. Aditya Kapoor to take over this pro-con debate. Thank you very much, sir.
Thanks, Dr. Manjula. It's an absolute pleasure to be here, and I've been following the proceedings since morning, and the previous session was absolutely fantastic. So it's my proud privilege to, as you rightly said, umpire this debate. So Dr. Sani is there, and I've had the good fortune of listening to Dr. Sani so many times. He is the Chief of Cardiology at Sri Gangaram Hospital, New Delhi, and he's had numerous publications, more than 175. I'm told he's on the steering committee of many international trials, and it will be an absolute delight to listen to him. And the second person we have with us today is Dr. Jagdish Hiremat Saab. He is the Director of Cardiology at Ruby Hall Clinic. And Dr. Jagdish is one person who is, maintaining the right balance between an interventional cardiologist and the special interest in preventive cardiology also. Again, I've had the good fortune of being associated with him in previous scientific forums, and I've had it's my privilege to have listened to him in so many talks. He's always presented a balanced perspective of whatever problem is presented to him. So we are going to have a real delight in the next 20-25 odd minutes. So over to you, sirs. Let's listen to your individual perspective on fixed dose versus individual drugs in management of hypertension. Please, over to you. I think Dr. Sani will bat first.
Yes. Yes, thank you, Dr. Aditya Kapoor, and my dear friend, Dr. Hiremat, and thanks to Dr. Siddharth Shah, Dr. Shashank from HSIN, and also to Shirish and the Manjula for giving us this opportunity from the micro labs to discuss about an important topic. So I'll be speaking in favor of fixed dose combination in hypertension management. So we have learned now that over the last few years, the prevalence of hypertension is globally increasing, and in our countries also we have almost 30% of the adult population, they have hypertension. But unfortunately, only 10% of the rural and 20% of the urban population have controlled blood pressure to the goal. Now, why the blood pressure is so poorly controlled, even if detected and treated? There are two important reasons. One is that probably at physician level, and secondly, as patient level. The physician level, what we found, still a lot of physicians, they continue to prescribe monotherapy in spite of the good knowledge from guideline that we need more than one treatment drug. Secondly, they have a therapeutic inertia among the physicians that they do not escalate the treatment and do not follow the guidelines strictly. We have also learned that most of the hypertension patient in previous panel discussion that the comorbidities are very high with them and they need many more pills. And at the same time, for the control of blood pressure, they need multiple pills. And we know patients always, they fear about the pill burden, and that leads to the decreased adherence to antihypertensive treatment. And that is a big problem in real clinical practice, which leads to uncontrolled hypertension. We have a recent data coming from 15 countries, 28 studies, showing that approximately 45% of hypertensive population are non-adherent. And those who are uncontrolled hypertensive, it is almost 84% of them are not adherent to the drug. We know that the blood pressure lowering is designed to be difficult because it is maintained by multiple pressure system like sympathetic system, ROS system, and sodium handling. If we inhibit one system, the other systems gets activated. So pathophysiology of hypertension is heterogeneous, and so no single drug mechanism is going to be sufficient to control the blood pressure, as we have learned now. For example, if you use only vasodilator or diuretic, you're going to stimulate the ROS system. And that's the reason why ROS blockade has become a foundation of treatment of modern management of hypertension. We have also evidence from more than 2 decades now, various clinical trials of hypertension in various clinical settings have shown us that You need more than 2 drugs always, and maybe 3 or 4 drugs sometime to control the blood pressure. This is with the goal of blood pressure of 140/90 at that time. And now with the new guidelines, both of them, BSC and ACC, suggested keep the goal of less than 130. So it becomes much more difficult now to reach this goal with the available. So we need to have to give more than 2 or 3 drugs to control the blood pressure. We have a strong evidence to say that if you're using monotherapy, like telmisartan 40 milligram, and if you want to double it to 80, versus adding another group of drug from different pathophysiological mechanism like amlodipine, the efficacy is 5 times more. So this is again a very important information. Compliance usually decreases as the pill burden increases. There's a study done almost 20 years ago showing at that time that if you increase the pill burden, the compliance is going to go down. You can see here, if you use 2 times, 3 times drugs, and so the compliance reduces significantly, and that leads to uncontrolled blood pressure. We have also now data from the single pill combination versus the same drugs given as a free combination, same doses, same drugs. Although it's not a randomized clinical trials, but they are the studies from the patients, those on never antihypertensive drugs, patients those already on antihypertensive drug. And if you look into the compliance issue, you can see the significantly 13-fold increase improves if you give it to start with a combination treatment, because patients, they tend to forget the drug if they are on 3 or 4 drugs of antihypertensive management. We have another evidence which has published almost a decade ago that if you start initially with combination treatment versus the monotherapy and then having a sequential adding of a drug later on, which is generally added with physician inertia, then you are not going to improve the control the blood pressure, which ultimately leads to increased cardiovascular events like coronary artery disease and stroke. So in a nutshell, what we can say that if you use combination treatment with fixed dose combination treatment of antihypertensive drugs, we have increased efficacy, better control, maybe earlier or prompt control of the blood pressure, because we are using 2 different group of medicines. They have a complementary mechanism of action. They have less side effects because we have to use initially with a smaller dose of 2 drugs. Smaller dose of each drug will generally have less side effect. But if you increase the dose also, then also we have learned now, for example, if you're using alone amlodipine, the pedal edema is there. If you add ROS blockers, the pedal edema side effect of the drug is counteracted by the ROS blockers because their action on the afferent arterioles. And an important thing finally is the adherence and compliance improves. It becomes more cost effective, at least in us and some of the countries where they become generic drugs have been used, because the packaging is important at that time. And if you control blood pressure effectively, as we have seen in our studies, which we have just discussed, you reduce the cardiovascular events. There is a downside of the FDC also, but that downside can be managed by modifying the management strategy. Like, for example, you can have a side effect of one component of a drug like ACE inhibitor, cough. Now we have FDC easily available with ARBs. So with that can be taken care of. You have a drug flexibility is a problem always. Multiple doses, FDCs are also available to us now, or we can use even score tablets to manage that. So this is a way we can, some of the challenging issues of fixed drug combination can be overtaken by the modification of these strategies. Some of the studies using the FDC versus free equivalent combination meta-analysis which have been done, although no randomized clinical trial is available at the moment to discuss about that. Few of them are going on. Light ACD, quartet US studies are going on at the moment. I think we have to wait for 1 more year to give the final answer for that. But definitely FDC group have shown a 15% increase in the compliance, and the risk ratio goes increased by almost 1.84. Looking at the blood pressure lowering efficacy, we have seen that 30% better control of blood pressure in the same meta-analysis of 1,600 patients, which was available to us. Looking at the adverse effect, surprisingly also, which I've told you already, probably one of the factor, that's why the side effect is also less. So the sequential management of hypertension, the other drug when it is added, by the time patient has already have side effects, so it does not help us. To begin with, if you start fixed dose combination, always beneficial to reduce the side effect. Now, the WHO has taken a step to improve the availability and affordability of these drugs to more than 1 billion people. So now they have endorsed the fixed drugs combination for the management of the hypertension, like they have now ACE inhibitor, calcium blocker, or ARB calcium blocker with diuretics, multiple combination available, particularly with generic drugs. So they become very cost effective and very effective to be used. So the WHO has clearly endorsed this FDC now. And now we have a guidelines which came 2018, SCAH guideline, which they have said that single pill combinations treatment to improve the BP control is a preferred use of two drugs combination, single pill combination. It is a simplified treatment algorithm for this. So you can see that they have suggested that you can use ROS blocker, calcium blocker, diuretic, 2 combination drug to start with, 3 combination drug in single pill, and only when resistant, then you have to add spironolactone and beta blockers in such specialist compelling indication. For beta blockers, for CAD or heart failure, they come on stage 1. Now we have combination available with ROS blocker, beta blocker, and calcium channel blocker available for this group of population where there is a need to add beta blocker for management of hypertension like heart failure. And this year, we saw 2020 International Society of Hypertension guideline also published, and they have also reinforced the same thing of ESC guideline. Only there is some difference is that they have given only choice of ROS blocker with calcium channel blocker to start. And first stage 1 is divided into 2 groups, step 1 and step 2, where they've given to start with low doses of combination of ROS blocker and calcium channel blocker. If not controlled, increase to the double dose combination, which is easily available to us now, and then only add the diuretic as step 3, and then remaining the spironolactone beta blocker the way. So they have only suggested use free combination if SPC is not available, which is very easily available, at least in our country and maybe in various countries. We have now evidence from US FDA and Europe also, that they have a lot of fixed combination drugs available for control of that patient. If you look at the market trend of the drugs in the country now, the fixed drug combination and monotherapy both are improving, but the fixed drug combination at the moment is showing a better growth, 11% versus 9% for the management of hypertension. So in conclusion, dear friends, I would like to say that the recent guidelines are actively encouraging to start with treatment with single pill combination treatment because it gives a better BP control, a faster BP control, less variability in response, everybody responds, safe and well tolerated, less adverse effects, fewer pills, better adherence to treatment, which results in better outcome in detection of cardiovascular events. Before finishing my, I've just got some information from Pune regarding the prescription of Dr. Jagdish Hiramat. 9 out of the 10 prescriptions of Dr. Hiramat contains fixed dose combination, and he believes strictly on guidelines. Thank you very much for listening to me.
So I think Dr. Sani, in his usual clear, concise way, has summed it up very beautifully. And the last bouncer which Dr. Sani has directed, and I know Dr. Jagdish is a very prolific cricketer as well. I know it from.
He can hit 6.
So I am sure he'll take it on the front foot and come up with some real useful answers.
Dr. Hiramat, you're muted.
Shall I share my slides now?
Yes, sir. Yes.
As the slides come on, I think I thank the organizers for giving this opportunity to be shoulder to shoulder with Dr. Sani and also to be with Dr. Aditya Kapoor. You know, any statement that you make in medicine, there is always a supporting evidence and a counter evidence. And these debates are there to bring out nuances from both sides so the listener gets both the sides properly. However, when the debates are formed, if you are close and in the good books of the organizers, you get simpler and scientific side of the debate. And if you're on the other side, then you get difficult debates to defend. And I did not know that cardiologists nowadays have jasus also moving around the country finding out information about debating. Obviously, I've used those combinations when it was required, but otherwise, I would stick to my role of isolated drugs. So we are three types of treatments. We have lifestyle, monotherapy, and combination therapy for hypertension. And in monotherapy, initial monotherapy is successful in almost 30%. So stage 1 and mild hypertension, you need only one drug. Those patients who deserve the blood pressure to be brought down in less than 20 systolic and less than 10 diastolic can get away with just one drug or a soft combination. Indian hypertension guidelines recommend initiating with either ARB or ACE in the young patient, as you know. And as I said, initial monotherapy could be sufficient in 30% patient. Now we come to the combination therapy. The targets have now gone back to 140/90. They are no longer tighter as we see from the latest European guideline. Remaining patients will reach the goal with multiple drugs. That is true, about 70%. The long-term prospective studies have shown that patients have needed average of 3 drugs or adequate control. That is known. But the debate here is not the number of drugs, but whether you should use a fixed dose combination pill or use individual drugs separately to get about a perfectly tailor-made prescription for that given patient. Look at the see this debate of fixed drug combination started in 2017 ACCHA, and then it was reinforced in 2018 European Society. But NICE guidelines have come later, and they start with step 1, one drug, and step above age of 50, one drug. And when you cannot do that, then you go to the combinations and combination therefore. And it is very clearly said that confirmed resistant hypertension, then only you go for combinations, and fixed drug is not even discussed. So the initial choice of drug to be used as monotherapy should be best in the following aspect: ability to lower CV morbidity mortality, predominant pathophysiological mechanisms the patient treated, individual characteristic, associated disease. For example, India, we know that very high sympathetic tone patients, we need to have beta blocker in the prescription upfront. And there are not many good combinations related to beta blockade. So there also, I would say that Indian patient, especially little younger, we've proved by data of 19,000 patients that Indians generally have a high sympathetic tone. So what are the guideline recommendation? ECCHE document suggests considered monotherapy in patients with low risk or grade 1 or above 80 years. You have to start with monotherapy. Another positioning statement where the BP goal is not achieved, then only you would step to 2 drugs. And the NICE guideline recommend that eventually it has to be a step-up strategy in all patients below 80 years with stage 1 hypertension or with high CV risk. All of us have seen this diamond in the past where diuretic on the top and all the combinations thereof. The dotted lines are not good combinations or not to be combined. And look at those. Majority of them are dotted lines. So what we are left with: ACE with diuretic, ARB with diuretic, maybe calcium channel with diuretic. And the play is only on the right side. The left side is gone out of work, it seems. The fixed drug combination with the free two drug combination therapy, if you want to talk, a new FDC guideline, what is not clear is whether the FDC has advantage over combination of individual drugs in efficacy. Compliance is discussed, convenience is discussed, but efficacy is not discussed. And with all the patient initiation of hypertension treatment as a means of enhancing persistence and adherence. What does our clinical evidence suggest? That we would like to titrate. If a patient comes to me with a blood pressure of 160/100 first time, I don't think he goes home with a fixed drug combination. I give them separate drugs, titrate the patient, get an idea of what he wants. I definitely don't want iatrogenic hypotension at home. He may remain uncontrolled for a few more days or weeks, but I want a proper control when it comes slowly. So It has to be that way. Fixed drug versus free two-drug combination. This is, as I said, every statement that you make, there is a supporting evidence. So this is a 4-year follow-up of nearly 8,000 patients. And the results show that persistence was best with free two-drug combination, 56%, compared to a single pill strategy, whether it was monotherapy or a fixed drug. Data on the impact of fixed drug in terms of reducing cardiovascular morbidity and mortality are sparse. What are the limitations of a fixed drug? Obvious, they are logical, they don't come from science, but it comes from less feasibility to increase the dose of one of the individual components. Like you want 40 milligrams of telmisartan, 12 milligrams of hydrochlorothiazide, and 10 milligrams of amlodipine. You cannot do it because no such combination is available. Let's take example of ACE inhibitors. You give, say, 10 milligrams of ramipril. It has wonderful pleiotropic effects, or 80 milligrams of telmisartan. In which fixed drug combination do we use 80 milligrams like this? Because majority of the time when you combine the drugs, the synergistic combination brings the individual doses down. So the cardiovascular benefit may go away. Hypertension control may be equal. It may also expose the patient to unnecessary treatment. Synergistic combination, even in smaller doses, may lead to hypotension. Some branded fixed dose are more expensive as compared to the free drug combination. And the duration of action of individual components of the fixed drug combination might not be equivalent, which imposes a limitation on once-a-day therapy. Furthermore, if a patient develops any side effect, obviously you have to break the combination, go for that. Night dosing of diuretic, it becomes a problem because many of the fixed drugs will have a diuretic, and if it is to be given at night, it could cause inconvenience. The risk of serious side events such as hypotension, syncope, electrolyte imbalance are all known if you produce a drastic reduction in blood pressure, as was shown in the SPRINT study. Hence, the use of fixed drug combination as a first-line treatment for patients who are milder variety has to be weighed against the potential of these adverse side effects. Now, this is a very pharmacological slide. As clinicians, we may not appreciate much, but look at these observations made in a very reputed textbook. Observed association between fixed drug combination prescription and duplication. What happens is this drug appears in combination in different tablets, and that leads to duplication. The lesser the proportion of free combinations prescription with co-founder is on the x-axis, the less combination that you write, more combination that you write, more are the repetitions, is what the inference of this trial is. And the therapeutic duplication, it is known, again, a very busy pharmacological slide on the right side. So I want as clinicians to concentrate on this side. Is therapeutic duplication occurred in 0.8% prescriptions, most often involving calcium channel blockers and statins. So you could get double drug without the person writing, realizing, because it existed in fixed drug combination. There could be advantage of a combination therapy, but disadvantage are obvious. Reduction in the prescription flexibility, difficult to identify precise cause of unexpected side effect, difficult to memorize the exact component of a single pill. There are so many. I get frustrated when the poor reps promote to me fixed drug combination. I tell them, I can't remember so many combinations, which is what doses, especially doses are so very difficult to remember. Then you have to resort to computers, and then we end up looking like lawyers who pick up books of evidences from the backside in front of the patients or their patients, their clients. I don't like to do it. Again, I am an old-fashioned doctor who wants to work from the brain and not through the computer. The combination of the two drugs was associated with more adverse event without an increase in the benefit. Was a fairly largish trial, again a very busy one. I want to understand the spirit of the trial. It said that the combination of the two drug was associated more side effects as compared to individual drugs used. So the disadvantage we have been talking about, so I just want to summarize by saying there may not be a FDC available for appropriate drugs and respective strength for a given patient, which can lead to some patients getting too much of an ingredient of one drug and not the other. Then that's why people come with multiple combinations, and then it's difficult to remember and the individual dosing. If an adverse drug reaction occurs using a FDC, it may be difficult to identify, and combination products may not always be appropriate for the patient. Costs may be similar or may be higher. So summary and conclusions, we can say mild to moderate hypertension can be successfully treated with monotherapy regimen. Large randomized trial comparing monotherapy with FDC are need of the hour. The choice of the drug should be tailored on the basis of clinical profile of the patient. First-line drug choice could be driven by concomitant number and type of drugs, tolerability, safety profile, by efficacy in terms of prevention of death and major CV events. It's important to consider how their use may influence prescribing quality and risk of medication errors and thus medication safety. We don't even know what is a combination. Why there are combinations not available abroad? Because it's difficult to make two powders of drugs compatible to each other in one single pill. So that's why the combinations are difficult. That's why they could be expensive. What we get is a capsule with a tablet and a powder. So it's not a true combination. It's like giving two drugs separately. Pill burden reduction. Now, most of our patients who are diabetic, hypertensive, IHDs, BAP, and whatnot are on 18 and 19 pills. So from 16 pills to 14 is not a great reduction. If a person is on only hypertension, reduction from 3 to 1 may be significant, but in majority of the patient, this does not happen. And that's why I feel be scientific, start with monotherapy build. I don't say build up monotherapy, but use individual drug combination, titrate the patient, and then if a suitable fixed drug combination is available, switch to that rather than jumping directly to the FTC. Thank you.
Thanks, Dr. Hiramath. So again, in your usual style, you have presented us whatever data is available. Dr. Sani, you want to respond to that, or shall we just discuss it? How do you want to take it forward? I think Dr. Sani Saab is muted.
Yeah. Sir, you are muted, sir.
Sir, can you hear me?
Dr. Kaditya, you can give your comments on this.
Yeah. So I think what I gleaned from both the masters was that, first of all, as Dr. Sani Saab rightly said, there is intuitive need to improve our blood pressure control and our blood pressure outcome. So that is there. And as you rightly said, sir, that there is some degree of therapeutic inertia. Our mindsets need to change, that this is one option which is available to us. But I think Dr. Hiramath pointed out a relevant thing, that say for patients who are at the lower threshold of high blood pressure, grade 1 hypertension. So he pointed out a good fact that although, we know that compliance will be better, it's a convenient dosing schedule, but for say about 1 in 3 hypertensives, would you still consider monotherapy in your therapeutic armamentarium? We know that fixed dose combinations are there for us, but as you rightly said, we need more data. But in a certain subset of patients, would you still, as you also showed, 20/10, if the blood pressure targets is more than 20/10, would you still consider starting with monotherapy, or your intuitive choice would be a fixed dose combination?
You're asking me?
No, I am asking sir first, and then maybe you can also.
Sure. I must say Dr. Hiramath very rightly pointed out some of the facts, which we believe, we agree with that. I think as the problem is the number of pills, definitely, I agree. You see, if you're diabetic, dyslipidemic, now even diabetic population, we are finding fixed combination pills are coming up to manage this sugar, HbA1c better. So everywhere, people are now moving towards fixed dose combination, because it is definitely two different pathological mechanism working. That becomes more effective, become more safer, compliance improves, and cost factor also improves, which leads to reduction of events, no doubt in that. So I personally agree with Dr. One thing is that let's start with the guidelines first. The NICE guidelines have been now overtaken by the ESC and now ISO, which has been now supported by the ACC and AHA and everywhere. All the guidelines of supporting no fixed dose. That's why the International Society of Hypertension 2020 guideline has come up with a smaller dose of fixed dose pill, which becomes probably safer, as Dr. Hirameta said, that if you start with smaller doses of two different group of drugs into single pill, probably it will be much more effective than giving a single pill of that drug, like 20 milligram of telmisartan and 2.9 milligram amlodipine combination may be working better for that. I do agree with him that very small number of patients, according to like frail patient, more than 80 years, those who get very early blood pressure, like very young people with a very 145 by 95, something like those people may not be start with double pill, because should start with pill. But majority of the patient, as they have got comorbidities, we have to not only control their blood pressure, but also the other risk factor also in addition to them. So I think controlling them early will be a good idea, and effective will be an idea. So compliance definitely improves. So guidelines have moved that way, in that direction. And that's why probably WHO and everyone has now endorsed that we should use this combination pills. I know, I fully agree with Dr. Irimat that the randomized clinical trials are not there at the moment, and we have a problem about that. Most of the people I can see them practice, they start with two drugs together, and they see if they are working well, then they put them into single pill. This is also a practice done by significant number of physicians. So I think we have to balance out between the two. Some area probably very small area where monotherapy is required, but most of the people, I think they will be requiring dual therapy. And if dual therapy, why not put them into single pill if this is available? Because a lot of flexibilities are available in our country now with different doses combination.
Dr. Hirman?
Yeah, I mean, you don't enter a debate to lose, so you have to make points. So what I feel is, yes, monotherapy in a small percentage, no doubt. But I'm not saying escalate monotherapy and then change. I'm saying individual drugs used separately. That way you probably get a better idea of what the patient really, I call it titration. So titrate the patient with individual drug. And if a commensurate fixed drug combination is available, then one would shift. Like whatever combinations we have are actually our individual drugs used together, like in one capsule, 2-3 tablets are put in. These are not combination. These are all just convenience packagings. So even that I support because it brings in compliance. But to arrive at that conclusion, I want to start individual drugs, get into the dosing that is required. You may spend a week or two in this, and then come to the fixed dose, which is best possible for the patient, will bring in compliance, bring in control, and bring in shall we say, continuation of the medicine, the persistence of the medicine.
And I think, as both of you rightly said, that one should be aware about the potential advantages and disadvantages of the fixed dose combination. I mean, they are there for us to help us manage patients, but as Dr. Hiramat also rightly said, the dose flexibility issue, and I think very interesting data he showed about the duplication, because personally I was not aware that even about 1%, sir, I think you said that 1% or something. So that is a good number.
Quite a bit actually.
Yeah, I would just like to
prescriptions in 10 days. So.
Yeah, just like to pick your brains for another 1 or 2 minutes if we have the time. The various combinations which are available, what is both of your views on? We just have most combination if you see the diuretics, hydrochlorothiazide, although we had a lot of data with chlorthalidone in the past. So what is your opinion about having chlorthalidone based combination? I am personally not aware whether it's available. So
it's available. It's available now. Chlorthalidone based small dose 6.25, 12.5 is available. Now, as we practice in north part of the country, we have a lot of seasonal variation of the BP, which we observe, like temperature from 2 degrees in winter to 45 degrees in summer. That makes us really, for all clinicians, to adjust the doses of all hypertensive patients. Generally, in these months, November and onwards, we start adding 6.25 chlorothalidone, which is now available. Even hydrochlorothalidone, small doses is also available in various combinations. Most of the combinations are with ARBs, calcium channel blocker, and diuretics. Very few are now also available with ACE inhibitors. Now, ACE inhibitor, perindopril is also available with that, and ramipril is also available. Those are also drug combinations that are available now. They are very useful, particularly hypertensive patients with coexisting comorbidities, which is very common, like diabetes, maybe early CKD. Dyslipidemia is another one big problem which we face these days. Probably every hypertensive will have to be on statin. It looks like in future guidelines will change, I'm sure. So these combinations are available, and we change like in summer we like to avoid diuretics, so we'll from 3 drug pill to we'll make it 2 drug pill, something like that, or maybe higher dose of the combination drugs which can be given to these patients. So my only contention is that if a patient of diabetes, hypertension has got coexisting comorbidities, then early control of blood pressure and effective control of blood pressure will be very important to reduce the events.
Yeah. The doses that we use as diuretics, 6.12, 25, 12, are very, very small. Very rarely one would use a 25 milligrams of hydrochlorothiazide or chlorothalidone. And despite the theoretical merits of chlorothalidone, it's a long-acting, it's definitely a superior drug. All the major trials, even in the past, are based on chlorothalidone. But if you look at world over, what is the most prescribed diuretic for hypertension? It is still hydrochlorothiazide.
Yes.
So one has a potential theoretical backing, and other one has a practical backing. So I won't be shy of using either of the two in combination. And despite what I said in the talk, I am not shy of using these diuretic doses at night, because even if you use it at night and if it fits your prescription, for the first few days, it could be a diuretic effect. Later on, it could be a vasodilatory effect. So even by good counseling, you can get away by writing a fixed dose combination of diuretic at night and still be compliant, bring on compliance from the patient.
Now we have indipamide also as a combination available. Yeah, is available also now.
Sir, one last question before we close. Any particular drug combination, fixed dose, or any other combination you would like the industry to sort of have in future, which you still think is missing from our armamentarium?
I think the initially missing was the beta blocker combinations. Now they are also available.
They're also there.
Available now. Beta blocker, calcium, and ROS blocker. All 3 drugs are now also available to us now. Although the number is much less compared to the prevalence of ARB, calcium channel blocker, and diuretic. They are the most commonly used drugs. So I think that is the only lacking thing which is now available. Only thing is the newer beta blockers like combination are coming up now. Like the bisoprolol and the amlodipine, so this group of drugs which are newer beta blockers and different calcium channel blockers also now available, which we like cilnidipine, benidipine, and now agonidipine. All combinations are available now. So I think a lot of only thing newer beta blockers are also available. I feel that probably there is no need for any new. Only thing we may need more doses flexibility. I mean, smaller dose and large dose combination. Those probably are not available. We need
and
some
more data.
Yeah, we need data. Like I need 2.5 amlodipine and 2.5 bisoprolol, for example, is not available. We have 5 milligram and 2.5 and 5. But that probably I need sometime in clinical practice. 2.5 amlodipine and 2.5 the bisoprolol is not available. Nebivolol is available, but this is not available.
I was going to say the same, newer calcium channel blockers.
And
blocker combination.
Yes. So I think Dr. Manjula is also there. So we had a wonderful half an hour, 40 minutes. And personally, I would declare this as a tied super over.
We wish we had a time, sir, for
You are a good umpire.
He's a kind umpire.
Kind of.
Very
But
nice.
we must play super hour.
Yes, yes.
Right, sir. It was really wonderful. I'm getting a lot of positive feedback even from the audience. Wonderful session, sir. Dr. J.P. Sani, sir, and Dr. Hiramat, sir, and our tough and gentle, both ways. He was tough at the time and gentle at the end. So combination umpire, sir, Dr. Aditya Kapoor, sir. Thank you all so much.
Bye-bye.
Thank you. So we will move on to the next session, which is STEMI during COVID pandemic. ST segment, elevation myocardial infarction is a fatal cardiovascular emergency requiring rapid reperfusion and treatment. And during COVID-19 outbreak, there is reduced STEMI patient probably accessing the care receiving timely reperfusion. It may be delay in reporting, or is it the fear of getting COVID? So there are various issues that will be discussed in this session, and followed by a session on CCB revisited. We know that calcium channel blockers are pillars of antihypertensive therapy. They have the flexibility, allow them to use a broad range of combination in patients with specific medical needs. So in this session, we are going to get update on CCB in hypertension management. So to conduct this session, we have eminent chairpersons. The first chairperson is Dr. Thomas Alexander, sir, consultant and interventional cardiologist and head of Division of Cardiology at Kovai Medical Center and Hospital, Coimbatore. He's published more than 60 research papers in various national and international journals. He's faculty at many national and international workshops and meetings, including American College of Cardiology, American Heart Association, TCT, and Euro PCR. And he has established STEMI in India, a non-profit organization, along with Dr. Ajit Mullasari, course director of STEMI India, which is an international meeting focused on STEMI care. STEMI India is assisting other countries to implement similar programs, acknowledged as the global STEMI model for low and middle income countries. So he is ably supported by another eminent chairperson, Dr. B.R. Bansori, physician and cardiologist at Dr. BAM Hospital, Mumbai, past president of Association of Physicians of India, honorary secretary, Hypertension Society of India, secretary of Cardiologic Society of India, Mumbai branch. He's organizing the Society of HyEcon and scientific committee chairman of HyEcon. And he's also edited several books, to name a few: editor of Medicine Update, volume 2 and 3 in 2017, and editor of Multiple Choice Question in Medicine in 2017. And he has received several awards, to name a few: received General Managers and Chief Medical Directors Award for Meritorious Service. That's a central drivers in medicine and cardiology. So Dr. Thomas Alexander and Dr. B.R. Bansori, welcome to both of you to conduct this session. May I now hand over to Dr. Thomas Alexander to introduce the first speaker, sir. Over to you, sir.
Thank you, Dr. Manjula. It's been really an exciting morning today with so many really good talks and discussions. I think we'll carry this onwards to the next session. Let me first introduce Dr. Pandey. Dr. Pandey is well known to physicians and cardiologists across the country, and I'm really now going to read out his academic the various fellowships and the papers that he has accumulated over a period of his practice. But I could just tell you that Dr. Pandey is one of the very, very incisive speaker who brings out very subtle points that I think many of us would find very, very useful in our everyday practice. So can we start with you, Dr. Pandey, so that we will leave more time for discussion?
Thank you very much, sir. And I'm just sharing my slides. Can you see the slides?
Yes, sir. It is starting now, sir. Yeah, it's come.
Yeah. But it is not going on the slideshow. There is a problem.
Oh, is it?
Yeah.
Should we say from our end, sir?
No, no, एक minute. I'll just do this.
while Dr. Pandey is loading his slide, maybe I could make a couple of comments. I think we're at the threshold of a second wave of COVID. So I think this is a very appropriate period, especially when we see that patients are not coming to hospital. Yeah, okay.
I thank you all for inviting me here, and thanks Dr. Thomas Alexander to be here as a chairperson. Who better chairperson than him for this kind of a discussion on STEMI? He's the father of STEMI India and the pioneer, absolutely pioneer in establishing the STEMI program in the country. And STEMI during COVID pandemic, I will just put forward small points which we have experienced in this COVID pandemic. The number of STEMI patients treated during the outbreak of COVID pandemic has reported to have decreased. And there was an increase in the median time from symptom onset to reperfusion. And the decrease in the STEMI cases was a global phenomenon. Italy reported around 25% decrease. France reported around 30% decrease. Northern Europe, 32% decrease. But New Zealand and China reported the highest 50% decrease in the overall STEMI cases during the COVID pandemic. Of course, some of these studies were in general acute coronary syndrome, but some of them were reported specifically for STEMI decrease. And this is one study from the Northern California. You can see here this the red line is the STEMI decrease from March 2020 onwards, and the yellow bar is the same period during the same period in 2019. These you can see approximately 30% decrease right from March onwards till April and May onwards. And at the same time, the COVID cases here, the blue line, they kept on increasing. So this has been a discussion, in fact, a very heated discussion across the interventional cardiologists over the globe. Why has the TAMI decreased? And patients presenting late was the main factor, according to me, because of fear of contracting COVID in the hospitals. The second biggest fear of the patients, or problem of the patients, was poor accessibility of the medical centers. So many medical centers in Mumbai were converted to COVID centers, and people didn't know which was COVID and which was non-COVID. They didn't want to go to COVID facility for contracting the COVID, the fear of contracting the COVID. And on the top of all that, please understand that in Mumbai, 70% of elderly couples stay by themselves with no manpower support to take them to the hospital. And with lack of transport and lockdown, they were just stuck to home, waiting for the medical contact to happen. STEMI misdiagnosis was another big problem, because the general practitioners and the local physicians working in local areas, they had shut down their clinics. So just to take an ECG also was very, very difficult to a patient. And therefore, the STEMI misdiagnosis was another common problem. But of course, one session which Dr. Thomas Alexander had been a chairperson of Dr. Sameen Sharma, and I heard that session, and Dr. Sharma said that there are some true factors as well: relaxed time at home, no stress of job and travel, healthy home food, less of smoking and less of drinking could have contributed really to a small proportion to the true decrease in the STEMI incidence during COVID pandemic. But of course, patients have a concern of fear of contracting the COVID. That remains. And some of these patients then do self-triaging. No, this could be just acidity, this could be just indigestion or things like that. And this has really produced a problem. So the biggest problem was onset of symptom to the first medical contact. But the buck lies with us as well. I can tell you that after the medical contact, the availability of a senior cardiologist for taking the patient to the cath lab, the availability of the expert junior medical resident, the senior lot among the junior medical resident to triage the patient to STEMI or non-STEMI, to assess them in the triage facility about the possibility of them having a background COVID or not, is all has taken enormous amount of time, and that is called lot of delay from door to the needle and lot of delay from the door to the balloon. There were some other factors which led to delay from door to balloon because of the in the initial times, most of the centers in the country, and Dr. Alexander will agree, could not meet this target of 90 minutes to 120 minutes of revascularization STEMI times from the door to the balloon. And with COVID pandemic, these delays have even become furthermore prolonged because of, number one, fear of COVID delays medical contact, non-availability of the local GPs to take an ECG, lockdown with poor transport, lack of manpower to take elderly to the hospital, peculiar problem of Mumbai, many centers converted to COVID facilities, and non-availability of senior invasive cardiologists who just didn't want to do invasive procedures in a suspect patients with STEMI with COVID. So these were the problems. So the symptom onset to the first medical contact was a patient factor, but the first medical contact to the delay needle was decision of a strategy to be adapted. So we in our center for the first 2 months, trust me, we have struggled to shorten this time, because when the patient arrives, he was breathless, then find out the history, travel, any COVID contact, any COVID in the family, etc., etc. The decision making was delayed. The medical contact to cath lab arrival therefore was delayed, and the cath lab to reperfusion because of the availability of the staff, adequate PPEs, and the non-availability of negative pressure cath labs in almost 85 to 90% of the centers in my country. To get we had 2 labs, to get that one converted to a negative pressure cath lab, it has taken us almost 3.5 to 4 months. So you can imagine that delay was a problem. And the access point specific therapeutic strategy, the patient arrives to a CHC or hospital with an ECG. ECG is taken within 10 minutes of arrival. Then it is interpreted by someone as a STEMI or non-STEMI. And then, of course, the patient is transported after giving a chewable aspirin or clopidogrel available there to a STEMI capable or a reperfusion capable facility. That has again produced a delay in the pandemic because of non-availability of ambulances, which were charging bombs in Mumbai to take the patient from one place to another. And therefore, this delay has produced many presented complications rarely seen in the pre-pandemic period, like pseudoaneurysm, ventricular septal rupture, free wall rupture, and left ventricular mural thrombus has definitely increased. And I think CSI is in a process of compiling the data, and will have the publication out in less than a month's time now. So the preferred strategy in the present COVID pandemic has been immediate thrombolysis, immediate primary PCI with a full safety precaution, the second possibility, and the clinical evaluation of the possibility of COVID in a given patient was the biggest black hole in the casualty and emergency rooms. And this we have experienced until around 2.5 months ago. We have rapid antigen assay for COVID-19, and that has made life quite a bit easy. Once this assay is negative, you can take the patient to the lab, of course, with full safety precautions, but at least the minds of the personnel working with you will be at ease, saying that the COVID rapid antigen is negative. The COVID affects the heart in several different ways, as we all know, but plaque instability and rupture is a specific phenomenon because of generalized endothelitis in COVID. We recently had a big discussion about COVID coagulopathy. And I will tell you the way to differentiate COVID STEMI due to COVID and a garden variety of STEMI presenting in a COVID pandemic. Number one, if you have history of travel, fever, cough, out of contact with a COVID person, one thing. ECG, ST elevation not in peculiar to one arterial territory or very atypical reciprocal changes. Echo showing wall motion abnormality which are diffuse and not concordant with the ST segment elevation in the ECG. X-ray chest, ground glass opacity. D-dimer elevated. HS tropi disproportionately elevated. And rapid COVID antigen either positive or negative. This is the patient most likely to have primarily a COVID and a COVID-related STEMI. On the other side, a garden variety of STEMI presenting in COVID pandemic, no such history. ST elevation, which is classical in one arterial territory with reciprocal changes. Echo wall motion abnormality concordant to that arterial territory. X-ray is clear or might show pulmonary edema-like picture. D-dimer essentially normal. HS tropi modest elevation and rapid COVID antigen negative. So these are the things which you have put in our casualty and emergency room so that the triaging becomes easy. Marked elevation in cardiac troponin are peculiar, more than 5 times the upper limit of normal. Within 5 hours of presentation, your antibody should go up that this patient is most likely to have COVID. This initial series in New England Journal of Medicine had shown that 40% of patients presenting with STEMI tested COVID positive within 24 to 48 hours after presentation. Let me put one of my case. A 46-year-old female, no comorbidities, had cough fever for 2 days, treated by local GP. Around 7 days ago and subsided completely. She presented with chest discomfort and breathlessness for 16 hours duration. Pulse was 80, BP was 105/70, SATs were 90% of room. Look at the HS tropi, 1200. D-dimer, just beyond the upper limit of normal. Our upper limit of normal for my lab is 350. This was around 2 times the upper limit of normal. Look at the ECG. ECG showed some ST takeoff in V1, V2, E3. Not much of reciprocal changes there in inferior leads, some in lateral leads. But look at the PR interval. Look at the PR interval. The PR interval was 280 milliseconds. Weird looking STEMI, I would say that. And look at the wall motion here. There was an apical septal area in wall. Here, the anterior apical septum looks okay, but the mid-basal inferior wall is clearly showing hypokinesia. So these are not the wall motion abnormalities, peculiar, concordant with the ECG. There, my antennae should go up. And look at this. This global strain, apex, which was not moving on echo, has been preserved on global strain. She had normal coronary arteries. So this was a STEMI related to COVID. She was COVID positive. We just treated with low molecular weight heparins and a single antiplatelet. And then she went home on apixaban and a single antiplatelet for 6 weeks. Why lysis is the first choice in many? For the logistic reasons, because when a pharmaco-invasive strategy is not really inferior to a primary angioplasty performed after 6 hours of presentation. Many of these patients are presented with STEMI in COVID pandemic 6, 8, even 10 hours later. There were logistic reasons: non-availability of the cath lab personnel, non-availability of level 3 PPEs, negative pressure dedicated COVID labs, and inability of the duty staff to decide the probability of COVID in a given patient was the biggest black hole that personally I have experienced. In Rajasthan, there was almost 30% increase in the lysis as against the pre-pandemic period. In China, again 3 times higher lysis for the same period, comparable period in 2019. So there was an editorial in Open Art as well. As COVID-19 spreads, US cath labs ponder about fibrinolytics for STEMI. The European Association of Percutaneous Cardiovascular Interventionalists, EAPCI, and the ACVC have again given their own guidelines about the central hub for the peripheral hospital, the central hub hospital, how to reorganize themselves for the COVID pandemic. And the Mayo Clinic had given this guideline in last week of April. And this is very, very simple and easy to follow. If you see a severe non-cardiac illness with a low predicted benefit from an invasive strategy, stay put and treat the patient with thrombolytic plus minus medical therapy as aggressively as you can. And treat, if the patient turns out to be positive for COVID, treat the patient with COVID dedicated facility and intensive care. But if you have high clinical suspicion of an acute coronary occlusion, low suspicion of COVID, and great expected benefit from revascularization with all safety precautions, just go ahead and treat that STEMI as you would have treated in the pre-pandemic period. So the resource and infrastructure appropriate management of ST elevation MI, this is the ICMR guideline which we have followed almost close to word by word in my institute. And we have been benefited, and this is the CSI for which Thomas Alexander sir has been a pioneer for this STEMI guideline for CSI. Here again, if you have confirmed COVID, then of course, if patient presents less than 12 hours, hemodynamic is stable, thrombolysis in an isolated designated facility, and then move him to the ICU. Whereas if there's a low probability of COVID, you consider pre-COVID strategy. So this is a very, very simple to understand. And now with rapid COVID antigen testing available, the results of which are available in 45 minutes with a single drop of blood, I think things are becoming easier and will continue to become easier. Now we are more geared. Our fear factor has gone relatively down as compared to what it was in April and May. Number one. Number two, the fear factor of our staff working in the cath lab has also gone down. PPEs are available freely and rampantly. We have got a negative pressure cath lab now. So all these factors have worked with us to take patients aggressively for our STEMI program. Let me give you a second case. This patient, 55-year-old male, presented 14 hours with severe substernal chest discomfort, no comorbidities. Admission vitals were reasonable with a little high BP. But look at the tropi, 1200. Look at the D-dimer, grossly elevated D-dimer. His COVID antigen on admission was negative. But the second day RT-PCR turned positive. And look at his ECG. His ECG showed ST elevation V1 to V5, not much of reciprocal depression there, multifocal ectopics on admission. His X-ray prima facie looked normal, but when we did HRCT, they said CORAD score of 6. You can see this linear shadow there at the left base, at the right base, striking shadow, which could have been missed at the rib or something like that, but this was striking on the CT scan. Look at this on admission itself. This, I don't have a clip, unfortunately. There was a LV apical mural thrombus. 1 month later, that mural thrombus has started organizing, and there's a central lucency saying that the thrombus is getting resolved. And this is his angiography 3 days after lysis, or 72 hours after lysis, and after fixing with a stent. We gave him aspirin, clopidogrel with lysis, dabigatran 150 BD, triple therapy went on for 1. Dabigatran we gave for left ventricular mural thrombus, and after 1 month we continued just with T2Y12 inhibitor, that is clopidogrel and dabigatran. So STEMI and COVID concomitant challenge has been crazy. This is a high mortality. We have seen relatively higher mortality with STEMI and COVID. Some of them have been transferred to COVID facility after second and third day, but they have almost 30% of them have not done really well. Couple of them, after 6 weeks of discharge with a successful angioplasty, have come down with cryptogenic stroke. So you can imagine this is a bad news because of higher coagulability in COVID. COVID coagulopathy in these people, your antennae should be up to give them a anti-10A oral inhibitor if their D-dimer at the time of discharge is 6 times the upper limit of normal for a period of at least 2 to 4 weeks. So all that I say here, it is not the strongest species that survives, nor the most intelligent that survives. It is the one that is most adaptable to change, that lives within the means available and works cooperatively against the common threats. So we have to adapt ourselves to this pandemic. We have to evolve ourselves to this pandemic to treat our patients better. Then only we will survive through this pandemic. And that is Charles Darwin. Thank you very much.
Thank you, Dr. Pandya. I think you've covered the whole spectrum of the problems with managing patients with STEMI in this pandemic period. Now, maybe we will have a couple of points here because the next topic is totally unrelated to the STEMI area. I think the two important areas that you touched on, one was the reasons for the drop in number of STEMI during the lockdown particularly. And as this country now opens up, I think we're going to see a surge in both COVID cases as well as STEMI cases coming back to the hospitals. And this is going to be a very, very difficult period for all of us. We do know that with the inter-district restrictions, the numbers that came down may have been due to access problems or fear of the patient. But once the lockdown opens, now you can expect a surge in both COVID cases as well as an increase in STEMI. And this is going to be a huge challenge. And you very correctly emphasized two issues. One, look at the geography that your hospital is in to decide how many cases of COVID are there. Therefore, to decide how you're going to manage COVID alone or COVID suspected STEMI or patients with COVID and STEMI. And these require totally different ways of management, as you've shown. If you have COVID and STEMI, that is the most potent patients who will run into problems, thrombogenic problems, problems in the cath lab and in the period beyond that in managing these patients, because many of them come back with stent thrombosis. So I think it's going to be a difficult time. And as you've clearly shown, each hospital has to decide their strategy, whether they're going to be a thrombolytic center, they have the facilities to convert a cath lab completely into a COVID or a possible COVID patient with STEMI management, or whether they're going to have a combination. And I think each hospital needs clear understanding of the incidence of COVID in their geography or in the geography of where their patients come from, and also to plan out strictly how they're going to manage. And all three options are on the table: thrombolytic plus pharmacoinvasive, or primary PCI after a quick antigen test. I think these will be decided local at your place. Pandit, for your final comments before I ask Dr. Bansode to take over the second half of the session.
So, sir, that's all I wanted to say. I just wanted to say that the coagulopathy in COVID is a real devil, which unleashes lot of adverse events in COVID positive STEMI patients in the post PCI period as well, and that has to be kept in mind. And we have to keep on repeating their D dimers every third or fourth day for almost 2 weeks to know whether they need an additional anti-factor Xa inhibitor oral, because the Megaline trial with rivaroxaban was very, very effective in reducing their thromboembolic events in the post STEMI period. Thank you, sir.
Thank you, Dr. Pandey. Can I now ask my co-chair, Dr. Bansode, to take over for the second half of the session? Dr. Bansode, you're muted. Can you unmute, please? Thank you.
Hello, I'm audible?
Yes, sir. Yes, sir.
First of all, I thank, 1 minute. I am audible?
Yes, sir. You are audible, sir. Very clear.
Yeah. This second part is CCB revisited. The speaker is Dr. Tani Nair, and his biodata is already shown by Dr. Manjula. Without wasting time, because we are already behind the schedule and the program has to finish on time. Still, we are lacking. I'll request Dr. Tani Nair to proceed with the deliberation, CCB revisited.
Yeah,
thank you.
It was very nice. Absolutely smoothly, yes, sir. Good, good. I think, like you said,
thank you, sir, for that introduction. And I think as we are late on time, we'll straight away go to the topic. Give me a moment's time by the time I share my screen.
And there was no drag in the video. It was very smooth.
Mr. Shirish, please mute yourself.
Yeah, is my slides visible and am I audible?
Your slides have not come as it, sir.
Yeah, it'll come. It'll that number one.
Oh,
is there.
number
Okay,
one
right.
is there. Yes, sir.
Yeah.
It's perfect, sir.
So, we are going to talk about CCBs revisited. Obviously, we are going to talk about hypertension and CCB. But first of all, understand that today we have moved much beyond hypertension when we discuss about CCB. For example, this data came last year. This data came last year when we saw that calcium channel blockers may be effective in treating memory loss in Alzheimer's disease. Alzheimer's disease, calcium channel blockers. Yeah, the data actually showed that if you look at a healthy neuron, that blue is a neuron, and those yellow blobs there are basically calcium channels on the surface. If you look at the diseased Alzheimer's neuron, you see that is in gray color, and a lot of green inside. Those are calcium ions inside. And that is because the L channel, the calcium channels of the neuron increase, and they push a lot of calcium inside. If you treat these patients with calcium antagonists, calcium blockers, you see that the calcium, those green blobs are less inside the neuron performs better because some of those yellow blobs, the calcium channels, are blocked. Not just in Alzheimer's, but calcium channels seem to have a lot of effect on even malignant brain tissues. For example, if you look at that picture, that's a glioma cell, cerebral tumor cell, which again, the intracellular calcium, those red dots, dictate about how much proliferation, migration, invasion, and character malignancy would be there in the cell. For example, if you block that cell with that is a voltage gated calcium channel, block that channel with a calcium blocker, you find that the proliferation, migration, and invasiveness of the tumor is far less. So the point is, we are looking at calcium channels far beyond hypertension, but we will first come back. Remember what we said in the beginning, keep that in mind, we'll come back to that. But we are going to discuss about CCBs in hypertension management in 2020, what is new. The first thing is, of course, the 2018 ESCSH guideline very clearly told us what, for the first time they said that use 2 drug combination for every patient that come in, excepting unless the patient has got is very frail, unless the patient has borderline hypertension, use a combination of ACE or ARB with a CCB or an ACE ARB with a diuretic in a single pill. And if that fails, add up ACE ARB with a CCB and a diuretic, but again in a single pill combination. That highlights where we put CCB. Almost every person with hypertension today needs to go on a CCB. Now, if we move ahead 2 years and come to the 2020 International Society of Hypertension Global Guideline, that this came just now, a month back, and look into their guidelines, you've seen that, Dr. Sahani has shown you this already, that we start with, again, ideally single pill combo. And in that combo, first step would be a low dose of ACE or an ARB with a calcium antagonist, A plus C. The second step would be a full dose of A plus CCB. The third step, ACE ARB plus CCB plus diuretic. And the fourth step, ACE inhibitor ARB plus CCB plus diuretic plus spironolactone. So you see that in every stage, there's a C. So CCB is there for every stage of hypertension. There's a reason for it, right? But before we go into the reason, understand an unusual epidemiological redistribution in India. This data that is from 2018, JAMA showed that hypertension in India, the data is known to us, 25% to 107 million hypertension is responsible for 1.7 million deaths. But the point is not that. Point is this: hypertension creates a debility to the tune of 40 million. And that is what basically because of creating strokes. So hypertension is responsible for stroke. Now, with that background, hypertension and stroke, look at the data. If you look at stroke data, for example, this is the standard data we always see. The x-axis is blood pressure, systolic blood pressure. 120, 130, 140, 180, 170. As blood pressure increases, the graph progressively goes up. The stroke mortality increases. We all know that. Okay, look at ischemic heart disease. Same pattern. The SBP in x-axis 120, 140, 160, 180. As it goes up, the IHD mortality goes up. Now, look at those letters on the right. What are they? The gray bar is 50 to 60, red is 60 to 70, orange 70, 80, and blue is above 80. Yeah, same thing for ischemic heart disease, which means as we go up in age, as we become older, the graph becomes steeper and steeper and moves higher up, which means both systolic blood pressure and age contribute to stroke. Far more in stroke, because the stroke lines are far more steep compared to ischemic heart disease. Right. Now, if you understand that, look at the Indian epidemiology. We are talking about the population growth rate, not total population. Total population in India is increasing, everybody knows that. But if you look at population growth rate in India, it's progressively coming down. We are getting smaller and smaller families. But in contrast to the blue line, if you look at the red line, the elders above the age of 65, it is gradually going up. So from 1991 onwards, India is becoming a top-heavy, elderly predominant society, and the graphs are quickly separating. So we are likely to see this more often in our practice. And that is what the hypertension elderly, mostly isolated systolic hypertension of the elderly. Isolated systolic hypertension of the elderly, as we see, the systolic blood pressure goes up and you have the age growing up. So a bad mixture on your platter for stroke and debility, right? And what is the drug of choice? We know that in ISH, isolated systolic hypertension of the elderly, we have calcium channel blocker based therapy with or without diuretics are the drug of choice. Now, pause for a moment. We have learned so much from ambulatory blood pressure. In fact, we have so much of work on that, right? We have taken out blood pressure from the lamps of office and clinic and hospital out to patients' home, right? And the first thing that we realized a lot of things, but let us see the first and the main thing is that blood pressure is a variable parameter. Now, if you look at that ABPM record, look at that night record. At night, blood pressure drops, and that is a normal nocturnal dip. Because the night blood pressure is governed by renin-angiotensin system. Daytime, we are all active and up when the blood pressure is high. So there's a variability. Morning is high, night is low. And not just that, early morning, we have that sudden rise as we get up. And today we know that dictates. That is a vulnerable point for stroke and MI, right? So there is a variability. Some of it is good, some of it is bad. And now the point is, we today know that if we give a CCB and a RAS inhibitor combination at bedtime, that is perhaps the best in taking care of the night BP, which is the most important parameters telling us about the cardiovascular risk of blood pressure, and also that morning surge, so that strokes and myocardial infarctions come down. Now, understand a little bit on variability. You know, when we talk about blood pressure variability, there's a morning BP, there's a night BP drop, and early morning rise. Let's say the same patient's BP of 1, 2, 3, 4, 5, 6, 7 days, right? So the dip and the rise, that is a normal variability. So the moment we say excess variability, what comes to mind is this. Yeah, which means the night BP is same, but the early morning surge is significantly high. So the variability is significantly more compared to normal. But when we are talking about variability, we are not just meaning this. We are meaning this. That means every day's blood pressure pattern is different. Every visit blood pressure is different. And that's why we call it visit to visit variability. Visit to visit variability. And when we looked into the visit to visit variability effect on long-term prognosis, for example, the UKTIA trial very clearly showed that as the variability increased, the hazard ratio of stroke increased. When we looked into that 8,000 patients of ASCOT for 5.5 years time, ASCOT BPLA, we found that both the stroke risk and the coronary heart disease risk significantly increased when there was increased variability. So blood pressure variability is a bad thing. We don't want too much of variability, and that can increase stroke risk and coronary vascular disease risk. We have data that came for the first time from Rothwell's group, a meta-analysis of antihypertensive drug looking into variability. And very, very clearly we found this. The CCBs are the best drug in reducing variability. Next, followed by diuretics and then ACE-ARB, and the beta blockers are the worst. So CCBs are the best group of drugs that prevent variability of blood pressure. And that may be the reason why we get so much of benefit by CCB. Now, okay, this theory, does it all translate into practical benefit? It does. Look at this data. This data came in 2018, unique data. Is the ASCOT trial data, but looked into the long-term mortality, what we call as legacy effect, right? So this is an 8,600 patients. It was basically ASCOT group. So CCB-based therapy, it was amlodipine, versus beta blocker-based therapy. If CCB didn't control, there was an addition of perindopril. Beta blocker didn't control, there was an addition of diuretic. So CCB-based therapy versus beta blocker-based therapy. And trial was stopped after 5.5 years when we showed that CCB-based therapy was better, right? But then look at this. Look at this. Now this is coronary heart disease death. And the trial stopped there, that straight line of red, at 5.5 years, right? Now, the patients stopped the trial, they went home and continued their own treatment. And exactly 15 years later, we see that the red line amlodipine-based therapy had a 12% lower coronary heart disease death? 12%. But when we looked into the stroke death, yeah, that is 5.5 years, the trial stopped. 15 years later, we found that there's a 29% benefit in the CCB arm, which says that if you start your therapy intelligently, very early, that has a significant legacy effect in prevention, particularly of stroke death. This is a hard endpoint, right? Stroke death. So we know today that CCB started on a right time, CCB-based therapy significantly reduces stroke and stroke-related mortality. And that has been very clearly shown. Now, something very interesting and very close to my heart. We did a lot of ambulatory BP trial, and this was one of those trials. 16 of us joined together and did. And this is one of those largest ambulatory BP trials in the world that came in Journal of Human Hypertension. We found something very funny. 27,000 patients. We found masked hypertension accounts for about 20% patients. What is masked hypertension? That means in your clinic or your office or your hospital, the patient's BP is either normal or slightly elevated. But if you do an ambulatory blood pressure or home blood pressure, at home, his blood pressure is significantly elevated. Masked hypertension is just reverse of the white coat effect, just opposite of the white coat effect. Now, what is interesting is here. Now, for a moment, pause about ambulatory BP. This is data from dementia, right? What was found that if you look at patients of dementia from age 60, 70, 80, 85, you look at that 70, right? And that red line is vascular dementia. As vascular dementia progresses, the blood pressure tends to come down. The yellow line is non-vascular Alzheimer's dementia. As Alzheimer's dementia progresses, the blood pressure comes down. Why does it come down? We don't know. But this data has been supported over and over and over again. Maybe because loss of sympathetic tone, maybe because of loss of renin-angiotensin axis, maybe autonomic, maybe they take less food, maybe their muscle mass comes down. We don't know. But the point is blood pressure comes down. So as it becomes a florid dementia, your patient's blood pressure may be normal. And by then, you have missed the bus. So this is one of our patient data. In fact, this is one of our favorite topics we talk about. For example, you see that is the night data. So I put it in red, and you see that the blood pressure is elevated at night. But look at the daytime BP, normal, right? Normal, below normal. So nocturnal elevation of blood pressure, masked hypertension is often goes unrecognized if you record blood pressure in office. But these patients very often show left ventricular hypertrophy, history of TIA, and some kind of brain damage. Now, the point is, that is what we talked about. Our review article came in Nature JHH in May 2019, which talked about hypertension and dementia. Now, the point is, this is not gross dementia where a patient comes in a wheelchair, unable to talk, walk, and vacant looks. No. This is a patient who would come to you who had borderline hypertension, but his wife would say, sir, now he forgets everything. He forgets where he put his wallet, his mobile phone he loses, his spectacles he forgets anniversary dates and phone numbers. And the man would say, no, sir, she is just fooling around. I have so many things to remember. And if you put him through a mini mental scale, you will see that they have MCI, minimal cognitive impairment. And at that point of time, if you do an ambulatory BP and you find a nocturnal hypertension, unless you treat that, the patient will go in for frank dementia. When the BP would come down to normal, treat, there would be no significant benefit. Do we have proof? Yeah, there's a lot of literature now talking about dementia risk and the role of blood pressure pattern. And we have very clearly seen this is a large data that came in JAMA last year, which shows the association of midlife to late life blood pressure pattern and dementia. So they looked into dementia probability. And what did they find? They found that the blue line means midlife hypertension, late life hypotension, what we talked about, has the highest chance of dementia. Yeah, they have the highest chance of dementia. Okay, so what did we learn from the CCB that we are talking about? The CCB learns that one, CCBs control blood pressure. They are very good for isolated systolic hypertension in the elderly. A group in whom systolic blood pressure is high, they're elder, and they, because of their age, they're highly prone for target organ damage like ischemic heart disease and stroke. Point number two, CCBs might improve cognition, as we know today, beyond controlling blood pressure. Do we have large data? No. But the signals are quite good that we have additional benefit of neurological protection, perhaps from dementia or whatever, cognition, apart from blood pressure control. And the good thing is that for example, the ISH guideline has said stage 1, 2, 3, 4, wherever you are, there is a calcium antagonist. CCBs reduce blood pressure variability. They're the best in reducing blood pressure variability. Mass hypertension is linked to dementia. Mass hypertension, understand that mass hypertension is about 20% in India. But in the Caucasian population, Europe and US, it is only about 7 to 8%. And that is why most of the guidelines till recently did not even mention them. They just neglected it. But we have pointed out very clearly that mass hypertension and dementia is important in India. Don't forget that. And of course, CCBs and RAS inhibitors, the first line combination, tends to control the nocturnal blood pressure and early morning surge and might control a lot of these ravages of hypertension. Now, how do we choose a CCB? This is the last part, right? How do we choose a CCB? We know that the voltage gated calcium channel are 3 types. One, the L type, the long lasting type. That's why it's called L channel. Nifedipine, amlodipine, and of course the non-DHP blockers block the L channel. Diltiazem, verapamil, other effects of the conduction system also. Now, the T channel currents or the transient current channels. For example, cilnidipine blocks L plus T. And then of course we have the N or the neuronal channels. Drugs like benadipine and azinidipine blocks L plus N. So the point is there a benefit in this additional N and T blockade? Yes, there are. For example, if you look into the L, N, and T type channels, right? And you look at the practical outcome. One is that there's a tendency for the sympathetic nervous system to be less activated when you add up a T or an N, particularly the N to the voltage channel, to the L channel. That is because the sympathetic neurons have these channels and they are blocked. And second is because the efferent artery of the glomerulus has the N channels. As you block them, there is a reduction of intraglomerular pressure. And thirdly, as you can see there, aldosterone secretion is reduced. So how do we select a calcium antagonist? It is not potency. Many people think it is potency. It's not potency. It is the TP ratio, the trough peak ratio. Any trough peak ratio more than 50% is good. You might say, what is TP ratio? TP ratio, if you look at the clock time and the dose, we know, let us say we have 2 drugs, right? One is a very strong drug. It's called a red drug. The red drug reduces blood pressure on dose at the peak performance 10 millimeters mercury. But at the fag end of the day, the effect obviously comes down. Any drug, it comes down. It reduces blood pressure by 4 millimeters. So the TP ratio is 4 by 10 into 100 or 40-45%. Another drug which is much weaker, weak drug, not good, right? That's what we would think. 5 millimeter reduction only. But at the end of the day, it has still 4 millimeters BP lowering effect. So the TP ratio, 4 by 5 into 100, that is 75%, right? So the point is, it is not just the potency of an antihypertensive drug that is important, but it is important that we have a TP ratio of at least more than 50%. And if you look into all the calcium antagonists with the TP ratio, and we find that there are a couple of them who have got significantly high TP ratio, and they're amlodipine, benadipine, which has a good TP ratio on a single daily dose. Now, what about combined L and T and L and N? Do they have a practical benefit? Yeah, they have some benefits, like slowing heart rate. This is important because the India heart study, which we had done with 18,000 patients, very clearly showed that in India, we have a faster heart rate. The average heart rate of the Indian hypertensive is 83 beats per minute. Compared to Western, it is higher. So since we are not recommending beta blockades earlier in our algorithms, so calcium antagonists which would take care of the heart rate would be better chosen rather than one that produces reflex tachycardia. Reduced intraglomerular pressure. If you add N or T, you get reduced intraglomerular pressure, and of course lower aldosterone levels if you give a combination of L and T or L and N like the newer calcium antagonists. So before we end, understand the reason why we're all talking about dementia. A record of 16,927 dementia patients went missing in Japan in 2018. And then they started thinking, and this is the graph. Look at the prevalence of dementia in Japan. Women and men, men at least is plateauing down. Women after a certain age is significantly high. The x-axis is age, right? So what they did was they created groups in Japan, which is sit together and talk about dementia. They created trackers. So elderly people moving around, they put on trackers so that you can track where he has gone, he is not lost. They created orange colored dress and groups. We roam in the daytime on the streets or in the shopping malls trying to find out if an elderly is lost because there's a lot of dementia. And they are now planning to put beyond a certain age everybody's thumb barcode, so that you find somebody roaming around in the street, he doesn't know his address or home, can quickly find out all his details. Obviously, can we do that in India? We can't do that. We can't do that, obviously. This is our OPD, right? Where people are standing with a token to enter my room. So, our blood pressure record is different. The people standing in a queue. All our hospitals are like this. So Western situation doesn't match. But understand that today, the incidence of dementia in India is 2.7%. And when you link it with hypertension, the problems become huge. And if you can control hypertension, for example, with a good drug like CCB, you can prevent long-term dementia and a lot of these neurological sequelae. So I always say that our problems are different. Our solutions too need to be innovative. So don't lose your curiosity. Thank you for your time. And I think if there are some questions, we'll take it.
Thank you, sir. Dr. Bansare, you're muted, sir. You're saying
muted,
something.
Sir.
Yeah, yes. So before we take the question, I know that three of you are involved in STEMI survey, Dr. Pandey and Dr. Thomas Alexander and Dr. Tiny. Would Dr. Pandey would like to say a few words on the recent survey on STEMI Indians?
Yes, that was a wonderful thing that Micro Labs has initiated. They have taken the initiative, and I thank all the authorities of the Micro Lab for taking this phenomenal initiative to do this survey of more than 1,084 doctors across the country, predominantly cardiologists, but even physicians practicing as cardiologists. And the survey is now almost about to be published. And Dr. Tiny Nair was insightful in giving us a lot of advices and lot of corrections when we formed a questionnaire. And I'm very happy that he's here today. Dr. Thomas Alexander is also here today. Thank you very much. It is a great thing, and it's good. It will be published in a week or two, I think, from now. Yes, thank you.
Yeah, I think that was a fantastic initiative by Micro, because it is something of an innovative which we can do in the COVID times. And just wait for the publication. I think you will be surprised to see the data.
Thank you, sir. All right. Over to chairpersons. If there is anything to say, or
yeah. I think we've overshot our time. I think the speakers have done a fabulous job of going through every aspect of their topics. Both Tiny and Dr. Pandey, you've done a great job. I think there can be very little that anybody can add to what you've both done. Thank you so much. And I think in the interest of time, I think it might be best that we
Thank you, sir.
Thank you very much. Thank you very much. Thank you, everyone, chairpersons and the speaker. It was really a wonderful session. Thank you so much. So we move on to the next session, and slightly different than hypertension management, but it is the need of the hour. And with the new normal setting in, I think it's really important for all the doctors to know about it, because social media usage among healthcare professionals has skyrocketed in recent years, unveiling both the benefits to professional practice as well as pitfall and cautionary tales. So this media is increasingly becoming a tool supporting healthcare processes, gathering and sharing information and bringing people together, and encouraging communication regarding their health topics. So preserving patients' privacy, confidentiality in all environment is a main issue. In the context of social media usage in healthcare and research, there are certain ethics issues, there are some etiquette to be followed. So we have a really eminent, and I think is an authority. He's been doing this session for training lots of people on that. So we are fortunate to have Dr. Jagdish Channappa doing the honors here. And also there's one more aspect of social media usage is the laws and the regulation that covers doctors whenever they use the social media. Because it poses many risks for healthcare organizations, and that could potentially affect the safety and security of patient information, patient consent, employment practices, also physicians credentialating, licensure, violation of HCP, and patients' boundaries and other issues. So therefore, doctors need to comply with the privacy laws, respect copyright laws. So for that, we have a legal expert, doctor, but a legal expert as well, Dr. Jagdish, doing the honors here. To do this and to take this forward, we have two dynamic and renowned chairpersons with us who are going to chair these two sessions. First chairperson is Dr. Prashant Advani. It's my privilege to introduce her. He's a consultant preventive and clinical cardiologist, Director Advani Heartline and Metabolic Center, Raipur. He's honorary and visiting consultant at various corporate hospitals at the city of Raipur, regular speakers at national, regional, cardiac, as well as international levels on cardiac, cardiometabolic events and congresses, and published several review articles and research paper in indexed national and international journal. Is passionate about disseminating current medical knowledge, especially pertaining to cardiovascular, cardiometabolic medicine amongst the medical professionals and medical students, as well as the pharmaceutical personnel through seminars, CME, conference, and ad books. Sir, it's our pleasure and privilege to have you, sir. Welcome, sir.
Yeah, thank you, Dr. Manjula. Good afternoon. A nice show on. And this is on the fag end, and we are already delayed. And this is I must compliment whosoever has chosen this topic. This is a beautiful topic, and we are still learning. Can I audible, ma'am, Dr. Manjula?
Yes, sir. Just a minute. You have a co-chair with you.
Oh, yeah, Dr. Parik. I'm sorry. I started.
Yes, sir. I'll just introduce
Dr. Parik, please.
Parik. Yeah. So we have a co-chairperson. Dr. K.K. Parik, we are fortunate to have you, sir. He's a senior consultant physician from Kota, Rajasthan. He's the President-elect, Indian Association of Clinical Medicine, President, Association of Physicians of India, 2019 and 20, past Chairman of Scientific Committee of the API, HyEcon 2019 at Kochi, past Dean of Indian College of Physicians, Founder, President, Research Society, RSSDI, Rajasthan chapter, as well as organizing chairperson of RSSDI 2019. He's been organizing chairperson for several conferences, to name a few, organizing chairman of the upcoming National Conference of Association of Physicians of India, which is planned in 2021. It was told that it will be a virtual conference. And chairman and senior consultant at SN Parekh Memorial Hospital, which is a multi-speciality 100-bedded hospital at Kota, Rajasthan. Sir, it's our privilege to have you, sir. Most welcome to you.
Thank you, Manjula. Thank you,
sir.
Now
Thank you, sir. Now hand it over to Dr. Prashant Advani to introduce the first speaker. Over to you, sir.
Yeah. I'm sorry I interrupted between you. So, and this is a wonderful seminar going on. And again, I said that this is a beautiful topic chosen and we have to learn from the stalwarts. And I thank Manjula, Sirish, Micro Labs, and all the eminent dignitaries of Hypertension Society of India for formulating wonderful marathon event, which literally covered everything, hypertension as well as all pertinent cardiovascular topic. Good afternoon to my co-chair, Dr. Parik. And we have eminent speakers speaking on these pertinent things. Social media, we cannot live without social media in these times. And this is very important, but there's always a thin line. There's a blurred line between professionalism and personal, which we might inadvertently infringe without being aware of the legalities of it, like inviting a defamation or contempt of court or something. We shouldn't be ideally posting anything on social media out of our whims and passion, which we don't want to see on print media or on a newspaper. We shouldn't be posting that thing. Of course, this is very important. Social media is very important for dissemination of knowledge, exchanging of ideas, information, and generating peer reviews, having a discussion, a debate on any work of your interest. But then, of course, we are not aware. We just do it on a passing day. We're not aware of the legalities or the ethicalities or ethical tension that we might brew through these things. So we have to learn from the experts like Jagdish Chinappa, nobody can be better than these guys, eminent humanitarians who can enlighten us about the nitty-gritties and nuances of this thing, and we should be wary of, and we should be awareing our peers in order to be quite safe and in order to be a responsible consultant in order to post something on social media. So Dr. Jagdish Chinappa is a MD-Pedia and is a very well-known in Bangalore and the cluster head of Manipal hospitals. Is numerous achievements, President IAP, examiner for MD-Pedia, organizing chairman of RxEvents.co.in, So many things. Certified in pediatric bioethics from the Mastery of Children Hospital, Kansas in 2015. Certified by Karnataka Medical Council, Mumbai Medical Council. Member of Ethical Committee 2012 to 2013 and 2019 onwards. Immunization Subcommittee of EPI, and it's a practice of pediatrics and neonatology at Bangalore for last 30 years. In a tertiary hospital, we know that Manipal Hospital is a signature hospital in India. So this is Dr. Chinnappa. I asked Dr. Parikh to introduce the other speaker of the session, and we are looking forward to learn from this session. It's very important for us. Yeah, Dr. Parikh, please, sir.
Yes, thank you. Thank you very much, Dr. Prashant. And it's really a great opportunity and an honor to chair this very important session and to be a part of this very important and a successful conference, for which I thank Dr. Siddharthan Shah, our mentor and guide, and Micro Labs, Dr. Manjula, Dr. Shiris. So thank you, so nice of you to be make me part of this important. As Dr. Prashant said, we have got it's a double sword. Social media, we can have a advantage, we can have a disadvantage. You know, advantage is that biggest is to aware the public. How can we aware the public about hypertension, CID, diabetes, corona, and all these things? So I think this is the best medium to aware public about what to do and what not to do. But there are disadvantages all. We should not put our individual performances, individual achievements, and some differences, because all these things make a little difference between the doctors. So we have got another very well-known luminary in this regard, Dr. Jagdish N. He is MBBS MD. He is a member of review board of journals like India Journal of Medical Ethics, consultant NGOs organization for so many organizations, member National Committee of Framing Guidelines on Management of Child Sexual Abuse of Indian Medical Association. Sorry. Is the person guidelines developing group guidelines for the sexually counseling for healthcare providers, World Health Organization, Geneva, Switzerland. He had been member, and curriculum committee member for forensic medicine toxicology of Rajiv Gandhi University of Health Sciences, Bangalore, Karnataka and Maharashtra University of Health Services, Nasik, Maharashtra. So he has written several chapters and 2 books, published 28 papers in index journals, and edited books of national and international repute. And he is a trainer for medical examination of sexual violence case, medical ethics, medical education, forensic medicine, gender mainstream for doctors, judges, police, lawyers, and NGOs. He has got a wide experience for more than 20, 25, 30 years, and he'll be telling on what are the laws and regulations covering social media uses for doctors. So without wasting time, I invite our first speaker, Dr. Jagdish Chinnappa. Thank you so much.
Thank you very much, chairpersons, Dr. Prashant and Dr. Parikh, for that very kind introduction of both of us. I am Dr. Jagdish Chinnappa, and I will be speaking on the ethics part of it, and Dr. Jagdish will be speaking about the legal part of it. So I would request if I can they can allow me to share my screen, please. Yeah. All right.
Yes.
So social media in ethics for doctors is what I'm going to speak about in the next 20-25 minutes. And basically, I will start off with a small story. This is a story of Mesut Ozil. He's a football star, and all of y'all might have heard about him. He used to play for Arsenal in the UK. So Mesut Ozil very innocuously, just a year back, posted a innocuous comment on his Twitter post and his Instagram post where he criticized China over its treatment of a particular sect of Muslims in China. What happened after that? This was just an innocuous post. But what happened? A lot changed after that. Though we do not know whether it is because of that criticism, but what happened was immediately the fallout was he disappeared from all video games, merchandise, the Chinese internet, got his pay cut, and has not played since June. And this is a report which has come out just a few days back, which means that an innocuous post can have a rippling effect right across all social media. So we know, let's look at health now. 40% of consumers say that the information found via social media will affect how they deal with their health. 30% are likely to share this health information across social media sites with patients, other patients. And 42% will post comments about a doctor, nurse, or healthcare provider on social media. So all the rating that you get, or whether you're a good doctor or a bad doctor, there are many patients who will keep doing that. So basically, what is the social media? Basically, it comprises of three main things. Basically, one is a networking social media, a blog or a microblog social media like Twitter, and a content. TikTok, of course, is banned now, but Instagram and YouTube are of the same thing. There are a host of other things. So what it basically does is that they are web-based applications that allow people to create and exchange content on the platform. In addition to this simplified picture which I showed you, there are a number of other things that happen. There are tools like podcasts, image sharing, video sharing, content sharing, so many things that can happen when you are looking with a social media network. So what I'm going to do in this topic is going to look at 4 aspects that are going to affect all of us. One are what are the unique characteristics of social media? 2, what are the ethical priorities in social media? Some examples and key principle to safeguard yourself as far as day-to-day practice is concerned. Let's start with what are the few adjectives by which you can describe social media which is different from what the normal thing is. 1, it's a brave new world. It's somewhere where all of us want to be in, but very few of us have the guts to go in. 2, it is pervasive. It's there everywhere, including your local grocery person, including the lady who's selling vegetables on the street is using social media. It is shrouded in mystery because many parts of it we don't know. We just know the superficial parts. It's addictive. I think every one of us cannot spend even more than 15 minutes without looking at WhatsApp or looking at what is the latest post on Facebook. So I think it is addictive. It's anonymous. You can remain totally anonymous. Nobody needs to know what is being looked at. It leads to some degree of indifference. We will come to that a little later. It is manipulative. People can manipulate. The companies can manipulate. Organizations can manipulate. You know very well about the US elections which took place last time. Much of it was manipulated. Another thing which is there is cause its uniformity. It tends to produce the same kind of people. If you look at the youngsters today, they would like to dress the same way, do the same things, almost the same things. Virality. This is another thing which is very important because you might just post something, but it can spread all over the world. I had a small video on vaccination, which I thought was an innocuous video. But somebody called me from Iowa saying that we have seen this video and we agree to what you're saying. So, I mean, it spreads very fast and it becomes an interconnected thing. Another thing is that it all becomes self-centered. Everybody is looking at what is the claps they get, what is the thumbs up they get. So I think self-centeredness takes place and tend to be secretive. I'm sure if you have a teenage daughter, that daughter is not going to share any of her social media handles with you because they tend to be secretive. So there are a few adjectives which can define this entire thing, which is very different from what we are used to. Like for example, let us look at anonymity. Most people will try to remain anonymous, especially from people, from the organizations, government, etc. They don't want to see what they are doing on the social network. As I said, there is no diversity. We all tend to do they all tend to do the same kinds of things. So that's one thing which happens. Then this is a very interesting picture. If you look at self-centered, there's a fellow who's drowning over there, but everybody is either taking a selfie with him or trying to take a picture of what's happening over there and posting it on their social media handle. So it's all about self-centeredness, which is a problem. The next very important thing is money is the king. Human values have gone away now because everything is termed in terms of commerce, directly or indirectly. So that's another problem with social media. Another major issue is addiction. We all are used about putting the cheese and getting the rat trap, but we are also trapped by the internet. We cannot survive without the internet. So there is a trap which is set there. It starts early in life. This child, for example, is a very nice cartoon with a ball sitting in the web and the Facebook, which is the child is getting addicted to. It even goes even further. It starts even very early on, where children are shown social media posting. The other issue is we tend to be myopic. They don't see any world beyond social media. They don't see the other parts of what is happening. So these are all the problems which are happening with social media. So social media, you would agree, alters your thinking pattern completely because of this anonymity, the myopic nature, the uniformity, emphasis on money, self-centeredness, addictiveness, and manipulativeness. So there are a large number of things which are different. Now, what are the ethical priorities? Now, if you look at the normal thing, doctors are existing in two worlds. One is the real world, which you can see on one side with the bag, etc., and the virtual world, which the monitors, etc. The ethical principles are very different in these two worlds, and that's what I would like to emphasize. We know that in the real world, our primary thing is autonomy. Patient has his autonomy to decide and has got the choice to decide what he wants to do. Beneficence, what is going to benefit the patient, what we do no harm, and finally justice. There are different types of justice, I won't go into that, but basically these were what was taught to us as the basic principles of bioethics. Professionalism was important, confidentiality was important, veracity or truth telling was important, and communication was important. Let's see, this is the real world scenario where these were the principles were primarily here. But let's see what happens in the virtual world. In the virtual world, the primary emphasis is on confidentiality, on veracity, on the communication that you do, and professionalism. Whereas the autonomy, beneficence, non-maleficence, and justice have a slightly reduced importance compared to the other principles of bioethics. So what has happened is a paradigm shift. On one hand, we were all the time looking at parent-patient choice, but now we are looking at how do we maintain confidentiality, how do we maintain truthfulness, etc. So let's look at some of these things. How has this changed? Why has this changed? Primarily, when you're looking at the real world, it was doctor-patient without anything there. But when you look at the virtual world, there's an interface. And what has changed is this barrier or this interface. And that's what we need to look very carefully into how it happens. Because of this, social media entitles us to blurring who you are. And that's anonymity is a problem. So you can be that, you can be the wolf actually, but you can be portrayed as a sheep. Okay, so the basic thing is that these are the issues. Now we'll come to a very important concept of what is the agenda. The agenda of the doctor, the patient, and the creators of social media platforms are entirely non-congruent. And this is very important. The patient in a social media setup is looking for a solution to a problem. The doctor in a social media is looking at his reputation and looking to increase practice. Now the social media platform has a different agenda altogether. What it wants is attention, addiction, and targeted marketing. Somewhere down the line, even if WhatsApp is free or YouTube is free, they make their money by targeted marketing. And that's what we need to understand very well. Let's explore this a little more. Let's look at the patient. How does a patient use social media? The patient, every search, whether he goes on Google or Quora or whatever it is a problem seeking a solution. He has got a problem, he's looking for a solution. So he goes to Google, goes to Quora. He finds a solution again in these two sites, and then he will start looking at rating sites. He'll start looking at people like me. He'll try looking at groups, Facebook groups, etc., trying to choose which facility, which doctor, which hospital. If you look at the doctor, he's got two avatars, his actual avatar and his online avatar. And the reviews which will do that will change his reputation. He wants increased patient load. How will he do that? By defining a niche area, by looking at referrals, by positioning, and indirectly he makes more money because of the quantity of time he spends on social media, the quality of time he spends there, and of course the time that he spends on social media makes a great difference on this. The social media's basic thing is to get attention, sustain that attention, reward. Now let me tell you that the reward that you get in a social media is addiction, because you'll get the claps, you'll get so many things which are built-in algorithms within the social media. And they want more traffic, and you get targeted advertisement. So these are the things that the social media people are looking at. So this is a complex ecosystem. So ethical behavior is very, very important. And you may be able to rectify it, you may not be able to rectify it. So what does a doctor do? He's got three basic responsibilities. One is self-regulation. You have to have confidentiality, veracity, and competence, and professionalism. You have to regulate the patient's behavior online. You have to set boundaries, respect their rights, and you have to assist social media regulation. And it's very important to recognize transgressions, report these transgressions, and be an advocate. I can tell you that I have seen there are posts which are very, very bad, but it's up to you to report. And it's extremely important that you report it to the authorities, report it to the concerned social media regulatory authorities, and to the national regulatory authorities. So we completed 2 of them. I'll just go through the examples now. For example, this is one doctor who portrayed his capabilities in an exaggerated fashion. He says, I'm a pediatrician, come neonatologist, come allergy specialist. And normally doctors, at least pediatricians, put MD-DCH. So this is fooling the public by just putting MB-DCH. So many patients will not read this as MD-DCH. So basically he is portraying it in a wrong way. So this is a kind of hype which you can create on the social media. Well, there are now, you can defend a fraudulent, exaggerated claim on a social media, at least in many of the foreign countries. And I'm sure very shortly it will come here. So veracity or truthfulness on social media is a very important thing. You have to portray exactly what you are and not what something else. You can see that these are reports from India, where you can see a fake doctor who has faked himself completely on social media and got a job in a very prestigious institute. You can misrepresent yourself. Then you can also see people with alternative medicine misrepresenting themselves on social media. You can this girl is going to choose what she wants to portray herself on a social media on a day. She can portray anything she likes because it is anonymous. So the doctor must be very clear what he is going to protest. The next important thing is a doctor trolls a colleague who just performed a life-saving procedure. You're jealous, so you troll him. You make uncharitable comments about him. So this is one of the biggest fallouts of social media. And it's very important that you beware about this. Please do not post anything that will be against anybody. You can be sued for defamation. Third important thing we can look at is should a doctor accept a friend request from an attractive patient who once was his patient? Well, this can happen. Well, it's important that there are boundary issues. Therefore, you need to see what is professional, what is personal, and please do not transgress these boundaries under any circumstance. Example 4, a doctor puts a photograph of drinking and smoking party where he was one of the participants. You can see many of these posts where you can see doctors dancing away, drinking, smoking. Well, it's very important that the doctor maintains his professional image and not put up such examples on social media. Another one is a rare case. Recently there was a case which was from Nagpur where there was a very rare case which was put on the social media, and immediately it was pulled up by the medical council saying that such photographs are not to be put up because we need to respect patients' privacy and confidentiality. This is another way of social media where a doctor forwards an anti-vaccine message which he just receives on WhatsApp. This again is not to be done. The primary reason is that there are multiple anti-vaxxers on the platform, and by forwarding it, you're only giving more teeth to their movement. Another thing is a doctor forwards photographs of an ugly scene that happened in the ER. This again is a wrong thing to do, primarily because it does not fit into the professional image of you. So basically there are various types of transgressions that can take place. One can be conscious, the other and unconscious. Amongst the conscious, it could be major, like for example, sexual harassment can be there. Minor can be sarcastic comment about a colleague. In the unconscious, you may forward something with an unsecure network where many people have access to it, and minor, you can probably forward a racist joke. This was a recent article which came out just day before yesterday about about doctors who are sharing pictures of a C-section of triplets. I think my colleague Dr. Jagdish is going to talk more about it. So how do we safeguard our principles? Well, we looked at the virtual world ethical principles. Look at these 4, and these are the 4 things that you need to look at. Have a respect for boundary. As in the cricket, the boundary should be guarded. You must have a personal social presence and a professional social presence. This is very, very important. Do not mix up your professional and personal social media handles with each other. Second is be authentic. Do not exaggerate. Be what you are authentically. 3, maintain confidentiality. Do not post anything which is non-shareable on the web, even though it may be between a few friends. Remember, everything can go viral anytime. Maintain professionalism, etiquette, dress code, measured communication, and always go through the clinical process flow as you would do in a regular consultation. Have respect for the profession, members, organizations, and the society. So in all these examples, we see that there's a great need for caution while handling social media. We need to be aware about the truthfulness of our posts, maintaining confidentiality, maintaining a professional outlook, and avoiding deceit at all costs. So I have shown you all the things that can go wrong. So should we not post at all? Should we not get onto this platform at all? Well, no. There are always good things and bad things. The advantages of social media: you can connect with patients, you can connect with industry, the media and the public can discover you, you can spread messages as my chairperson mentioned, you can establish yourself as an expert, you can indirectly brand yourself, you can have a very wide audience. However, as I mentioned before, be cautious, strictly go according to regulations, and be aware of ethical breaches. So keep posting on social media, because ultimately the squeakiest wheel is the one that will get the oil. Thank you very much.
Can I take over?
Yes, sir. Over to you, sir.
Okay.
Okay. Thanks for the Hypertension Society as well as Microlabs for picking up this topic and also inviting me to present my views on this. As my chairpersons as well as my fellow speaker Jagdish Chinnappa has already pointed out, this is something new which has come in, and thus the legal impact is also something new for the medical community. So in my next 15-20 minutes, we'll try to look at laws and regulations that cover social media use for doctors, and particularly this interface when we look at the medical community would be in terms of patient care. The other arena where we try to look at social media would be health education for patients and society. The third, which Chinnappa brought out to a certain extent, is the professional life, wherein we try to have peer interactions through the social media and the personal life. So these are the four areas wherein there is an interface with the social media. We try to look one by one. The first is the patient care. Today, if you try to look out, I have put the dots at the end. These are just a minimal thing which I have picked up, which are more popular in the Indian context. If you take the global context, there are many more, whether it's Practo, 24/7, Librate, 1mg, likewise, or these are specific to the medical community. Or if you look at the general things like the Facebook, LinkedIn, or Instagram, Twitter, Google Plus, or likewise. So many of these have entered into the medical profession, and we are now having an interface of the social media in our medical profession. The previous session was on the ethical aspect, but today something has become a norm wherein today searching a hospital or a doctor on these apps is something considered appropriate. Booking consultations for admissions or procedures in the hospital is something which is considered as a new normal. But are these a new normal? Is there a selective bias? Are these apps trying to pick a select doctor or a select hospital? Or how are those? So if something goes wrong, so whom should we sue? Is it only the doctor? Is it only the hospital? Or can the patient sue the app? So that's something new, the legal dimension which has come in. Another dimension, particularly the public image of a doctor, the online visibility of a doctor, and the issues which are proclaimed through health education or in terms of posts being posted by the doctors or the hospitals. So that's something, if it goes wrong, then all the stakeholders are liable. Additionally, the social media, the app is also liable. Feedback among the clients, that is the patients, about doctors. This is something which is happening today. There's an image being built about a hospital, about a doctor through the social media presence, the likes they get, the dislikes they get. So that's another legal domain of late which has added up. promoting ease of access to pharmacy services or diagnostic services in the patient care. As I pointed out, apart from selecting a doctor or a hospital, if it is selecting a pharmacy or a diagnostic center, so something goes wrong, then the app would also be liable along with the concerned diagnostic lab or the pharmacy. This was shared by Jagdish Chinnappa, but I want to go more in detail on this. This is a couple of years old case, but it's very pertinent for our discussion today, because today it's something which is so common. A doctor would click something which is unusual, click something which comes out, and we feel proud in trying to push it through the social media. But what happens if you don't follow the legal norms? Three docs were suspended for sharing the cesarean section photos via the WhatsApp. Though it was a rare case where they were delivering a triplet, but the essential point was without consent. If you read this paper news, it goes saying that immediately after the discharge from the hospital, the lady went directly to the police station and lodged a complaint. Immediately, the State Medical Council suspended the doctors, but it didn't end there. It went beyond that into a criminal complaint, and the paper post is trying to say that the High Court denied bail to the doctors because the cases which were put, the criminal cases which were put of indecent assault of 354 IPC. So that means the photos which were shared were the genital parts of the female, and without consent or with consent also you can't share that. The issue is the IT Act of 2000, particularly Section 66E, violating the privacy, which talks about capturing, publishing, transmitting image of a private area or part of the body. And again, sexually explicit material in the electronic form 67A of the IT Act were the charges which were framed. So the take-home message from this is you cannot post anything with it without the consent of the patient. And whatever we were doing in the past, that cannot become the norm. So we need to follow the ethical values as well as the legal thing, because now the privacy laws are very, very clear, saying that without consent, we cannot do any of these acts. So an advertisement of a doctor, as I pointed out, the interface, what we are currently doing is we try to put ourselves into practice. I'm naming some of them, but it could be any of those apps, trying to make myself visible in one of those apps which are available in the market. Is it an advertisement? If I pay more, so I get a bold advertisement, I get a front homepage advertisement, or I may be made visible. So are these legal? Definitely not. So the Code of Medical Ethics very clearly bans advertisement in all contexts, but it gives a small window when you start or close your practice or shift your practice. Those are the only areas when it allows. But beyond that, if you try to make yourself available, so that would be violative of your Code of Medical Ethics as per the erstwhile MCI, which now would be automatically applicable under the NMC Act also. Putting self photographs so that our visibility is very clear. We had a case about the print media, but similar advertisements are running through in the social media, and trying to show the photographs of the doctors of a particular hospital, and trying to show would also be violative of the Code of Medical Ethics. Self-boasting of your capabilities. So many a time we put our profiles which are online, and we try to say that we did that surgery, we did this procedure, we have treated so many people. If any false claims are put in, so we need to be very cautious, because this online forum is a verifiable forum, and everything will have a digital trial, and all our false claims will be counterproductive against us. Posting previous patient cure details without consent would definitely be violating privacy and confidentiality. The previous newspaper report very clearly points to that. Soliciting patients online is against the code of medical ethics. But what are these apps trying to do? What are these social media presence trying to do? So that's something which we have to be very careful. Whatever the regular human interface doesn't allow, the same is not allowed in the social media. We should be doubly careful when we are posting the child's photos, particularly the genital images. Automatically it comes under the child sexual abuse. Posting the patient photographs without consent, the previous case itself, how the IT Act of 2000 would apply. Spreading false information, this is something in the COVID era we have found, and there are cases which are being claimed under the Epidemic Disease Act as well as the Disaster Management Act. We have to be very careful what goes out from our handle or Twitter handle or WhatsApp or how we are, even if it is hacked, we need to immediately lodge a complaint saying that your handle is hacked. Otherwise, whatever issues happen from your handle, you are liable until it is proved the converse. Posting or sharing patient reports, this is something which has become a new norm. All my subordinate or the resident doctors may send the patient details for a further advice. But have we sought the consent of the patient when we are posting this onto an online platform? Or these all WhatsApp or Telegram or whichever social media we are trying to use, sitting at the comfort of our house, if we are trying to without seeking the consent of the patient, and tomorrow anything which enters into the internet is out into the world. So are the firewalls such strong enough that they can, when we are using a third party interface wherein we don't have a control over the app, in such situations, definitely without consent, we are liable. Today, we have telemedicine practice guidelines from March with the COVID, though these were pending from quite some time. The government in the COVID initial days of March, they had to give out so that we have some amount of medical practice in the lockdown period. And look out, it says very clearly that there should be a patient assessment and an examination. Without that, there cannot be any sort of a medical management. And identifying the patient online is a must. And if I'm trying to go with a WhatsApp message, and if I have not seen the patient, if I have prescribed something and that goes wrong, then definitely I'm liable because it has gone through from my WhatsApp number or from my WhatsApp post. So identifying the patient is a must. The telemedicine practice guidelines clearly give out there could be a patient directly contacting the doctor, the caregiver would be a paramedic and likewise, or the kith and kin of the patient who would be interacting with the doctor, the paramedic, nurse, or others who are interacting with the doctor, or another colleague trying to interact with the doctor. And in emergency, little later we come back how that is different. So if the patient is not identified and you try to give out your professional advice, then you may, if it goes wrong, you are liable. Today we are looking at prescriptions which are sent online. Very clearly, telemedicine practice guidelines put out. If you don't follow the list what is given out, then it's professional misconduct and an additional penalty. Over-the-counter medicines are put into list O, but whatever you are giving in the first consultation or for a refill, it should be only done through a video consultation, and that is all at the list A drugs. The follow-up consultations, what you prescribe, are put into the list B, but there is a strict no for all the drugs which come under the NDPS Act or the Schedule X. They are prohibited. So you cannot give them online. You cannot prescribe them through your social media or whatever be the internet interface. We need to be very careful. Jagdish Sinappa pointed out about the footballer, how the professional life got out. But the same thing applies even to the healthcare provider, whether it's a doctor, whether it's a nurse, whether it's a paramedic, whoever it is, whatever we speak on the social media, we should be very clear. We cannot argue out as it's a freedom of speech. Yes, we all have fundamental rights, but there are reasonable restrictions to that. If the comments what we put out are racist, whatever ethical principles we have, we cannot be religious, racist, caste, creed, color. So any of these, if you violate, definitely a defamation suit is definite on us, because we have a digital proof which is against us, which automatically proves that we have violated it. Another area where we have to be very clear is the conflict of interest, particularly the photographs which you post about your own professional life. What is visible behind you? If you are trying to promote a particular brand of a medicine or a particular device from a biomedical company, so tomorrow you would be charged for a biased approach. And if the claim which you are putting it is not correct, then definitely you would be having a legal suit against you. So the conflict of interest has to be proclaimed well in advance. The other issue, whatever we post online, we should be very careful. Whatever photographs I'm trying to take online, whether they are protected from copyright issues, whether there are licenses to procure, whether there are any patents to procure. Otherwise, definitely I am liable under the Copyright Act, the Patents Act, as well as violating the license. I would be having a civil suit, as well as a suit under the company law. And another aspect which we have to be very careful, what we post in the social media, we may proclaim several claims, and if that is not originally your thought, or it's not originally your idea, if you don't do a proper acknowledging or a proper referencing of the original source, then all the laws of plagiarism would also apply against us in the social media. The breaches of patient privacy, we had enough examples in the previous session, and this session also. They are not only under the Code of Medical Ethics. The Puttaswamy case, the Supreme Court has very clearly brought out the privacy, the right to privacy. And today we are, when we are not sharing our own fingerprints for Aadhaar, or likewise, we don't want Aadhaar to be made compulsory. So definitely what we do in the professional life, particularly when we are trying to look out the patient information, we have to be very careful, otherwise we are legally liable. We need to be very careful, because now there is a new, Jagdish Sinappa brought out that there is an interface of the social media between the doctor and patient. Now there is a new norm for this doctor-patient relationship, with an additional party of the social media in between. Any violation happening at any corner, whether it's by the social media or by the doctor in particular, so definitely that would be the breach of the doctor-patient relationship. We would be liable both ethically and legally for that. We need to be also very careful about what we post and what we comment on the social media, the follow-up comments, what we do, what we post. Yes, we also have a social life, but once you put your party images wherein what is not acceptable to the professional life, your images over there, that definitely would dent your professional image. And if you have chosen to post yourself, then definitely you are to be blamed. If somebody else posted, then definitely you have a defamation suit against those people. More and more apps are coming in. We are quickly embracing them without doing a check behind what it actually proclaims is true or not. There are many apps to run your OPD, which run your own hospital, nursing home. Likewise, we are even now going into the electronic medical records. Today, if there are no protective mechanisms, particularly firewalls and safety precautions, And the data of the first today's presentation from Dr. Devi Shetty was trying to show what's the new interface and how the things are changing thick and fast. And the doctors need to upgrade ourselves, and if we don't upgrade ourselves and whatever available in the market, we get into those apps, and tomorrow the patient data gets breached. The patient is not going to sue the app, patient is going to sue the doctor, and then you are to yourself defend for choosing or trying to take that app. The new norm is doctor-patient relationship established on physically a patient reaching the doctor clinic and getting examined? Yes, the answer is definitely yes. On sending an email, and if the doctor responds, the patient sends an email regarding whatever professional advice they want, and the doctor responds to that mail. Is the doctor-patient relationship established? Yes, definitely it's established. And tomorrow, in a hurry, I just typed the drugs, and things went wrong. So I did not personally examine these defenses, or alibis will not come. So we will be liable for medical negligence. So because the doctor-patient relationship would have been established the moment the doctor responded by answering the email. Similarly, on sending a WhatsApp message, if the doctor responds to that patient's WhatsApp message giving the professional advice, then definitely a doctor-patient relationship established. Similarly, on sending a Facebook request and the doctor responds, and for the apart from the request, you also give an advice over there, or you try to give a response to that. For you may feel that it's not a professional advice, but the moment you put a response on the social media from you as a doctor, so the doctor-patient relationship establishes. Otherwise, you have to refrain yourself from putting your professional advice over there. This is something which came out from the US. The Facebook, Twitter, YouTube removed a video of the so-called doctors who were denouncing masks and promoting a particular drug. So immediately this took a furore, and even the president of US had to respond to this. And all these social media apps removed that video because it was trying to proclaim something which did not have a scientific basis. And this is something which has happened. So whatever you put onto your social media, if you don't have a scientific backing, scientific evidence to back up that, then definitely you are liable for posting those false information. The poor quality of information or the wrong information shared on the social media, the poster is definitely responsible. So even the Disaster Management Act, the Epidemic Disease Act have enough check mechanisms for that. All the lab reports, whatever we are sharing, even the radiology reports, it should be only with consent. We had the famous case of teleradiology when people from US sued them, saying that we had never consented that our images should be shared with the Indian doctors. So if in fact your hospital is sharing to an outside doctor or an outside hospital wherein you are seeking professional advice, which forms part of the patient care, it should be well within the information given while seeking consent with the patient. Nothing can happen with hide and seek. If anything happens with hide and seek, if something goes wrong, definitely patient has a right to sue. You can't argue that we sent on an anonymized data. Even an anonymized data, if there is a reference to any patient, then definitely the patient has a right to sue the doctor. Is accepting patient as friend acceptable in the doctor-patient relationship? We are also human beings. We are also part of the same society. We need to be also part of the social media, but definitely we need to have our own boundaries. The moment I, as a doctor, accept a patient as a friend, and subsequently, if that in that group, the patient puts a status that he or she is not feeling well, and if a doctor reminds the patient to take medicines on that group,
does that mean it violates privacy? Because your message is not only seen by the patient, it's seen by the entire group. So can the patient sue you? The same comment in the general fora may not attract any attention, but the comment by you as a doctor, unless until you have denounced yourself as your professional profile, so that's something which we have to be very careful. The legal issues which have a conflict between your personal profile and the professional profile. So we need to be very careful regarding the safeguards. We should be doubly sure who are part of your, what is part of your profile data, which you are sharing with as a part of the professional care, and your own social site, what you are looking as a personal profile. So who are the people whom you are going to interact? So if you don't maintain that safeguards, if there is an overlap between the two, definitely it's a murky area or getting into legal quandary. So not to respond to requests for therapeutic care on personal profile. So tomorrow you can't argue out it was a general message which was put out, and I as a general respondent gave it. There is no doctor-patient relationship. I did not agree to care for that person. So all those things will not be acceptable the moment you have not separated your personal profile with the professional profile. The patient privacy concerns in a personal profile. Though you are running a personal group of your own relatives, but amongst them, one of them is also you are seeking your professional advice as a patient. So whatever information you have through the professional channel, you cannot share that information in the personal group. Then definitely that patient can sue you for violating the boundaries, ethical boundaries, as well as the legal boundaries. Before we end, let's look into now the new norm in India. Thanks to COVID, we have a new interface. Now we are having the telemedicine guidelines, which are part of the same Code of Medical Ethics regulations under Section 3.8, which very clearly says mandatorily issuing of prescription. So there should be a prescription, there should be a digital trial, there should be a documentation of the consultation, the logs, records, charts, everything should be there. You can't argue that it was part of a social media response which you have given. Tomorrow there is a suit against you by not maintaining this digital trial itself. You would be liable under the telemedicine practice guidelines. You definitely, yes, you can charge your fee, but the fee again comes with the same Code of Medical Ethics regulation. You need to give a receipt, and that receipt automatically would be having a digital trial, and there's nothing of a hide and seek over there. In emergencies, you need to restrict yourselves to first aid. You can maximum advise about the referral where you can facilitate, or the counseling what can be for the initial period. Barring this, if you go beyond it in an emergency, it would not be applicable under the telemedicine guidelines. Unless until you have another doctor who is beside the patient and you are trying to advise that doctor to take care, then that doctor is primarily responsible. If you are directly interacting with the patient and then things go wrong, then definitely you are liable. It's not like the Bollywood movies where it's trying to portray. There is a strict no for surgery and invasive procedures through telemedicine. You cannot do that. The guidelines end up saying that ethics are the foremost, data privacy is the responsibility of the healthcare provider, maintaining confidentiality. It puts a strict no on advertisement. So all those apps which are in the market, recently we had a couple of legal suits against some of them. So we need to be very careful. One, yes, we need to make a professional practice, but the other, we should also have an ethical and a legal practice. What the law does not permit, I am afraid we have to strictly follow that. Otherwise, we would be liable for the charges of misconduct or penalty. Though the list puts out soliciting patients, privacy violation, all those acts which we do without consent. but the telemedicine guidelines are a couple of almost 70-80 pages. The entire is almost 100 pages. So unless until each doctor goes through all those things and personally agrees to that, then definitely you have to be careful with the ethical and legal requirements of the usage of social media. So through this, we touch based. This is a new arena. This 20 minutes is too less to discuss the intricacies. Maybe we have just gone into a bird's eye view. We have several such case scenarios to discuss across the globe, because telemedicine was there part of the Western world quite earlier, and today we are just 7-8 months old. So we need to be very careful in picking up the laws. So thank you very much. If there are any questions beyond this, I'm very happy to answer that.
Yeah, thanks, Dr. Jagdish sir. It was very elaborate and made us conversant with the nitty-gritties and the finer aspect. Actually, it's a new arena, and we are just taking it for granted, and we are not aware of the innocuously we might upload or post, and then the consequences. That law not known is never an excuse. So it's better that you raise awareness, and so that we have become conversant and more responsible. Still, doctor being the elite of the population, and we have to still be behaving, ought to be behaving very responsibly, and vis-a-vis, in person, also on social media. And you rightly said, Dr. Jagdish, both are Dr. Jagdish and Jagadish. So I think for these kind of pertinent topics, Jagdish is the right pertinent word. So, and Chinnappa sir has elaborated what is actually the social media, what we are into, and it's just an ocean all around, and how we have to be sailing ourselves safely. And we should be aware of the liberties, the limitation, and the liabilities of social media. Of course, in spite of whatever Dr. Jagdish and sir has concluded with, but still so many infringements and violations are being done, probably because of the unawareness or probably knowingly. One of this would be kind of, I see in various states, I go pan-Indian, the advertisement of the so-called corporates and the hospitals and the claims, and that they say pertaining to weight loss and bariatric surgeries and the fantasy operations and some cures and some miracle treatment for blockages in heart, and they're person, they come daily. So and those are allopathic doctors. So what are the repercussions, Dr. Jagdish, of this? And because something is going on, but then once you are in hot soups, so everything is just opened up. So is there any mandate from any new law or any new guidelines about advertisement on print media on a daily basis?
What has happened is, I think one of our own colleague from Kerala who fought an unsuccessful case against the Medical Council of India. The Medical Council of India a couple of years back had specifically made it in such a way that the code of medical ethics applies to a doctor individual, but it doesn't apply to an association. It doesn't apply to a hospital. So that's unfortunate. Unless you are a teaching hospital, it doesn't come under the MCI. For that, yes, we have a Clinical Establishment Act 2010, which has brought out an interface. Much of the states have adopted that, but some of the states like Karnataka, we have our own Karnataka Private Medical Establishment Act. Likewise, many other states have their own state-specific laws. So in all those, it has come out very clearly that there cannot be any advertisement, there cannot be any tall claims or false claims over there. But when one end we are looking that we should have an ethical and a transparent practice, when we are looking at even the NMC was formed trying to remove the erstwhile organization to bring that transparency in medical profession. But yes, there are some people, I know many of those people who are arguing, saying that when you allow hospital as an industry, but when an industry is allowed for advertisement, 40% of the revenue is allowed for an industry which goes for advertisement. Why is not an hospital, which is also under the Industrial Disputes Act, it's an industry? Then why there is a double standard? When you consider it as an industry, then all the norms of an industry should be allowed. So this is a peculiar industry because we are trying to look at human values. We are looking at a human person, and what applies to a company, what applies to a non-living entity may not be vis-a-vis applicable to a human being, or when we are dealing with a human being. So this is where we are. There is a difference of opinion among our own colleagues, unless until all of us try to look at an ethical plan, or looking at based on the merits, the patient should come, not on soliciting, not on advertisement. This would be definitely
Still, it's a gray area as of now.
yeah,
Like
yeah. It's a
some
gray area.
lacunas, some missing links. Yeah.
Yeah, it's a gray area because the hospital is mixed with multiple applicable laws. When you go with the industry, when your hospital is considered as an industry, then everything what is applicable to an industry should be applicable to the hospital. Then automatically advertisement should be considered normal. But the Code of Medical Ethics bans that. But if a hospital issues an advertisement, see, if you read all those advertisements, it's not the doctor who is giving. It's all the I don't want to name. It's
Yeah.
the hospital which is trying to give out that ad, and thus they are not covered under the Code of Medical Ethics. But if anything goes wrong with that, some of the state medical councils have pulled down those those advertisements when the doctors' photos were put. The doctors' heroics were said, saying that we have done so many surgeries, so many procedures.
Yeah.
So they pull down the individual doctor, saying that you are part of the advertisement. But there's again a sort of a rat race. Some of the doctors claim, saying that I no longer have continued my practice in that hospital. It was in the past. The hospital is misusing my photo, misusing my profile. So this is a new area. Once the social media, once the commercialization, once the money matters have come in, so we have new and new things which are coming up, and we need a larger debate for this to
Yeah.
sort it out.
And Dr. Chinnappa, sir, I think in a doctor's close group, like suppose the peers of cardiologists themselves, and discussing about a patient, right, and then that sharing the angio image and something, and in the doctor's group, there's no patient in that thing, and just for the sake of taking opinions and offering the better care or dissemination of knowledge without any commercial interest. Is this a violation of privacy or confidentiality?
I think before I answer that question, I'll just go to your previous question, and I'll just add on one small thing, and that is there is what is called as the Magic Remedies Act.
Magic Remedies Act. Okay.
So if there is somebody who is portraying something that is not, which you think is offensive, you can always complain. It's under the Health and Family Welfare Ministry. You can complain for that particular purpose. Unfortunately, most of us will not complain against another colleague.
Really?
Because we keep that camaraderie going. Okay, coming back to your question now about sharing the information, there are two aspects to this. One is there should be no identifier in the information that you are sharing. Like for example, the name, hospital, everything should not be there. That is point number one. Point number two, there should not be also an indirect identifier. Like for example, supposing there is a child who is born with let's say a rare form of ichthyosis, and such a case is born only once in an area. If you put that photograph, it's automatically identified that it is from this hospital. So I think the important thing is that there should be no identifier. And the third important thing is, as Dr. Jagdish mentioned, is if you can take a consent, that will be the best thing from the patient, saying that we are going to share this on a platform without identifiers for getting better treatment. So I think three important things: one, no identifiers; two, consent; three, even if you are going to put something, indirect identifiers also you should be careful about. These are three things which I think are important. I think Dr. Jagdish can add something else.
Yeah, another thing in the consent is a blanket consent is not valid in the law. What happens is many of the hospitals and doctors, what they are trying to say at the time of admission itself, they are trying to take it saying that your data, your photos, your part of the patient information may be used for publication, may be used for sort of the publicity of if it turns out to be a rare case or likewise. So that sort of a blanket thing, if we take, would not be again valid in the eye of law. Subsequent, the photo which I showed, the triplet, the doctor should have, after the surgery, the photos which they have taken should have been discussed with the the mother there, and then if they had posted, then it would have been a different thing. But not even consulting the mother, trying to put out. There we can't come out, because many of the hospitals have that sort of a fixed printed format, which says that everything they have consented, including dissemination of information. That will not be valid in the eye of law.
Yeah, there's a question in the chat box. Yeah, so it's rooted to me as, can a doctor, probably you answered in your deliberation, Dr. Jagdish, can a doctor accept a friend request from a patient on any platform, like a Facebook or WhatsApp or Twitter or anywhere, a friend request from, and does it establish a doctor-patient relationship? Just a casual friend request as a social being?
See, it's the conduct, the after conduct, what happens. Mere accepting a friend and not corresponding further may not establish a doctor-patient relationship. But when the friend request has a prerequisite saying that somebody is already suffering from a particular ailment and they specifically choose you, and then they ask for a friend request, then you are agreeing to be part of their caregiver. So then it's a problem. Unless until the doctor's professional profile and the personal profile are different, then this becomes an issue. If it's a common profile, and then you have accepted, then you can't argue that was my relative, I did not agree, or it was somebody unknown, I did not agree, cannot be an answer.
Yeah, but then at times, like, we have to be wary that at the very same time, we shouldn't be exploited. Patients send a friend request and then carry on with the as a friendship, and then they start doing the same thing. And then again, you said that, of course, law doesn't differentiate among all this. We have to be wary of that thing. Yeah, I invite Dr. Parikh sir to make a comment about these things. Dr. K.K. Parikh, the co-chair of mine. But the unmute, you have to unmute, sir.
Yeah, by the time Parikh sir unmutes.
Yes. You said once a hospital is registered under industries, still the laws, the same laws follow? Because now the hospital can be registered under an industry.
No, sir. We are not registering under an industry, but the courts have argued saying that hospital is an industry. But now what has happened is, to run a hospital, there are umpteen number of things which we have to get licenses. Today, maybe 4 or 5 decades back, people of the stalwarts of yesteryears, they would say that we opened it, it's a part of our own will. But today, to start a hospital, you need so many licenses. Particularly if you are looking at the Clinical Establishment Act and the so-called Private Medical Establishment Acts, which are there in the many states. It talks about so many licenses before you actually start your professional practice. The industry thing is, see, the moment I employ 10 or more people under me, so automatically the employment rules will start. The moment I am using the much of the gases which we are trying to say, power, water, I am producing the waste, the biomedical waste, automatically I am looked as an industry. See, it's by default. We never applied to the Companies Act. We never applied for an industrial license to start a hospital. But by default, we are being considered as an industry. That's the reason. And today, if you look, there are so many things over there, and there are so many private hospitals which are being pulled out across the country, saying that you did not follow the national mandate, you did not earmark the beds for the COVID management, you did not participate in the national program, you did not participate in the medical legal care. So these are certain of the restrictions. If I give out Karnataka example, Section 11 of the KPME Act very clearly puts out, if you look into that, none of us can start any hospital, because you are liable for everything. The government has a restriction. Even the non-communicable diseases, you may have to submit the data. The number of the cataract cases which we have seen, now we are in a hypertension conference. Tomorrow it comes out saying that the government wants to have the data of all the people who are with kidney disease are associated with that. So the hospitals and the doctors should be able to provide that data. See, the laws have gone beyond, because as doctors, we never commented them. As doctors, we did not deliberate them. today we are in such a situation, we are at the receiving end. We need to do it. Otherwise, we are liable. And I am very happy this conference had the social media, because we blindly followed social media, but we never had an interface into it. And in an online platform also, I was closely following it. And next week I have my own state conference. We had made our own rules saying that none of the people would give out identity of any of the patient data unless until it's already in public domain, or it's the responsibility of the speaker. So we have newer methods now with this online thing. The other interface, we have online education going on in all the colleges, and these online webinars are going on as part of our professional thing across the country for last 7-8 months. But whatever we have disseminated in this online, today I saw this was, I am taking the example because Zoom also had its own problems in the initial, but there were a lot amount of safety mechanisms which were built in. There are plenty available in the market, but if I use a platform and the platform doesn't have a safeguard or a firewall, and my information goes to the public domain or the people who are not, and this was a free registration thing, though there was safeguards saying that you need to identify yourself, but many a time when we are trying to put it as a free domain, we may be little careless in trying to restrict who. So in all those situations, we have to be very careful what data we are putting out. If any aspect of the patient's private data or the data which we did not have consent goes into the public domain, then we are liable.
So the app per se, the app or the app maker or the platform provider is also liable for the breach or the leak that happened by whatever mechanisms.
Yeah, correct. But what happens is, along with the app, we are also liable. See, vicarious liability is something which is a part of the doctor-patient thing. The patient will not sue the app. The patient will sue the doctor.
Of course, yeah.
I can just come in here. I can just come in here. If I think this was 2 years back, when the Tamil Nadu State Board, that is the Tamil Nadu Medical Council, pulled up one of the app providers, because they were putting the ratings of doctors. Of so and so was best, and so was number 2 and number 3. Obviously, that's after collecting some money from the doctors.
Yes.
So somebody who was on number 10 or who came on the second page went and complained to the medical council saying that these people are paying money and this is advertisement. Ultimately, it is advertisement. So
yes.
I think that the important thing is that there are very few laws which are governing this kind of apps as of now.
Yeah, but
even for example, if you look at all these online pharmacies which came in, there was a lot of hullabaloo about whether they should be allowed to function or not. But I think over time we are evolving, and I think in this evolution there is going to be a lot of opinion that is required from people like Dr. Jagdish and from everybody to strengthen the laws and to look at where the loopholes are, because I am sure the government also is not very clear about how to regulate many of these things. So I think the point is that on this learning curve, I suppose all of us have a responsibility.
So the technology is evolving faster than the amount of regulation that we can draft as so can't keep pace. Of course, so there should be some soft regulation and for the larger benefit rather than like making a kind of red tapeism here.
Absolutely.
So you're right, sir.
To add to what Jagdish Chenappa pointed out, the NMC, the National Medical Commission, which is now functional, has a MARB or Medical Assessment Rating Board. So what we have an official mechanism to rate the hospitals and the establishments now, because that's what was the need of the hour, and now we have an official mechanism. It's only a couple of weeks they have taken over, so let's wait for them to officially get into the nitty-gritty of how they rate the establishments.
Like TRPs.
We have in Mumbai the fight going on with TRPs.
I think most of our healthcare professionals are not aware about, not even 5 to 10% about the laws and regulations and responsibilities of social media. Because, when you go to a print media about the diseases, awareness, and this is all right. But when you go on social media and other things, because even print media is not in favor of doctors. They would like to print news which public likes. So it is very important to, yes. So it is very important to have a positive approach in the social media as well as in print media, and we must follow the telemedicine guidelines. And I think, in my opinion, we must have such webinars, more webinars on these medical legal aspects of social media and print media and the responsibilities of doctor, because we are so busy that we don't have any time to think about all these things. So I think we, Dr. Jagdish, and both of you, I request we'll have more such type of webinars. And thank you very much for very excellent deliberations on and awareing us of our responsibilities and regulations about the social media use for doctors. So thank you very much, since we are running off late of time.
Very late here.
Yes.
Thanks, Dr. Thank you.
Thank you so much.
Thank you.
So nice of
Wonderful
you.
deliberation.
Thank you so much. Thank you.
Thanks, Dr. Dr. Suresh, Dr. Siddharth, sir, everybody. Wonderful
Dr.
seminar.
Prashant,
Wonderful.
thank you.
Thank you, Dr. Parekh.
Thank
Stay
you,
safe.
sir.
God bless. Bye.
Thank you.
Thank you,
Bye. We'll catch
chairpersons.
up
Thank
again.
you, wonderful speakers, Dr. Jagdish sir, Dr. Jagdish Chennappa sir, both sir. Sir,
Wonderful,
thank you,
wonderful.
Absolutely.
They are eye opener for doctors.
Sir, this session has 1 hour 20 minutes. We did not realize it.
This opening,
very eye-opening. Yes,
this is the psychology of doctors. This opening of eye is only for few minutes and seconds. We forget them later on. So this is very important to remember it and to have spare some little time for understanding and reading these laws.
Dr. Siddharth Shah, Dr. Manjula too have included this topic. I think kudos to you. This is wonderful.
No, we will, Dr. Jagdish, both of you will have some webinars in Rajasthan and more all over India. So we'll request you to please spare some time for them. Okay? Thank you so much. Thank you.
Bye. Good day. Bye.
Thank
Enjoy
you. Thank you all. Bye. 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 Thank you, sir. Thank you all. Thank you.
Bye. Bye.
Thank you. Yeah. Thank you, chairpersons, and thank you, speakers. I think that was the last session of the conference. We successfully completed 2 days of wonderful conference. Actually, we had really all experts sharing their thoughts, giving insight. Truly hypertension expert conclave. All experts came and gave their insights, and all. I'm sure all the participants who logged in enjoyed as much as we did organizing it. And also, I should thank the wonderful doctors who logged in as audience as well. And now, just before closing, I just thank all the eminent faculty, wonderful participants, and our IT team, backend, and everyone, and my colleagues over here. So now I will hand it over to Dr. Bansodi sir and Dr. KK Parekh sir to make the closing remarks. Over to you both, sir.
Dr. Bansodi, please unmute. Unmute yourself, sir. Yes.
Thank you. Thank you, Manjula. Since yesterday, 5 p.m., 5 hours, and today since morning to this time, a mammoth task has been done by the speaker and chairperson. On behalf of Hypertension Society of India and Indian College of Physicians, I have a proud privilege to propose a vote of thanks first to my mentor, Dr. Siddharth Shah, and my brother, Dr. Shashank Joshi, who has formulated this idea into practice, that virtual conference of hypertension expert conclave to be organized. And from the micro side, Dr. Murthy, Dr. Manjula, who has provided a platform for discussing this experts conclave on hypertension. I also thank the micro lab team, academic and dynamic team, who has helped to organize all this since yesterday and today's program on hypertension expert conclave. I thank all the participants who has participated in this hypertension conclave since yesterday and today. With this, I hand over the concluding remark to the Dr. K.K. Parekh.
Thank you, sir. Thank you, sir, Dr. Mansoori. It's really a wonderful and a successful conference. It's my
Very
great
successful.
honor. Yes, very successful. It's a great honor for me to extend thanks to our mentor and guide, Dr. Siddhartha Shah, and his team for organizing such a excellent and a very successful conference, which will be really aware clinicians to stick to the guidelines of hypertension and to remove the clinical inertia of accelerating or adherence to the guidelines and to treat the patient, because it is more important that we must keep the blood pressure at a target level. Whatever medicine, whatever investigation we done, it is more important. The first priority is to keep blood pressure at a target level. So it is very important. And I thank micro team, Dr. Murthy, Dr. Manjula, Dr. Shesh for a very
dynamic
educative,
person,
educative grant for organizing this conference, being very active during this conference. It has been a very excellent academic feast. I extend my thanks to all the galaxy of speakers, all the luminaries of the faculties for deliberating all the important topics in hypertension. I also extend my thanks to all the delegates, participants, without whom it cannot be a successful conclave. So again, a great thanks to our mentor and guide, Dr. Siddhartha Shah, and the micro team, and our delegates and our chairpersons, our panelists, our galaxy of speakers. So thank you very much again, and we expect much more in future also, because hypertension is a very big problem, and we must aware patients. In spite of all these our efforts, still only 30% of our patients are on normal blood pressure in spite of taking drugs, but 60% still are not taking drugs, or even if they are taking drugs, they are not keeping their blood pressure to normal. So I think this conference will be a milestone in awaiting our doctors, sir. Thank you so much. Thank you. Thank you, Manjula. Thank you.
Particularly Mr. Sirish, Dr. Sirish and Manjula, who has taken a pain to organize this successful event. Thank you. Thank you very much.
Thank you, sir. It was our pleasure to do all this, sir.
No, it's wonderful.
Thank you very much.
I mean, short and sweet. Short and sweet. 5 hours yesterday and 5 to 6 hours today. Wonderful. I think one can spare so much time. And I think attendance was also wonderful.
Yes, we had a lovely attendance. Thanks to all the delegates for being so patient.
Yes.
You can have
hypertension
2-minute word, sir.
Yes.
Mr. Sirish also have a 2-minute word.
Yes.
I think you stalwarts like you have summed up the whole thing. I think I'll just say thanks to each and every faculty member and all the delegates for being wonderful audience. And we would love to be a part of this again next year. And God willing, we want to make this an annual event from next year onwards.
Good.
So thank you very much, sir. Thank you very much to all the faculty.
Micro is always rather
behind a good cause.
Yes. A part of educative program.
Yes.
And for last 3 years, they are printing medicine update in progress in medicine.
Yes.
So this really, when I talked to Mr. Surana, and he immediately agreed. He did not take as not even 5 minutes to say, no, go on for printing.
Yes.
It was a big thing. And so I thank Mr. Surana also for printing and providing a very important medicine update in progress in medicine to our members. And this time, it is again a very big thing that every API member will get. Every API member will get this medicine update in progress in medicine. So thank you very much. Extend sincere thanks to Mr. Surana also Please
Sure, sir.
extend my gratitude and thanks to him.
Sure, sir.
Because when I talked to him, he started for the first time. Thank you very much. Thank you.
Sir.
Thank you, sir. Thanks to all of you. And with the consent of the faculty, we will close this conference.
Thank you.
Hoping
Jai
to
Hind.
make
Jai Hind. Jai Bharat.
Jai
Thank
Hind,
you,
Jai
sir.
Bharat.
Thank you very much. Thanks to all.
Thanks to all,
Thank
sir.
you.
Thanks to all.
Thank you. Thank you.
Thank you, sir. Namaste, sir.
Stuti, we can conclude.
Namaste.
Yes.